Morning, UMS, Achal.
Morning, Nirmal. I can't start my video. Says the host just stopped it. Yeah, now it's okay.
Recording in progress. We have Dr. Paulani sir, Dr. Gopi. I think Paulani sir.
I've just spoken to Sir Dr. Srivastav, Dr. Achal Srivastav, sir. He will be relocated.
I think they're all as attendees. Achal, Sumit, Paresh, you'll need to upgrade them.
Yes, sir, we are doing that.
I can see them in the attendees list.
Yes, sir, we are trying to do that, but somehow.
Hi, Achal.
Hi, morning, sir.
Morning.
How are you?
Yeah, I am good. How are you?
Doing well, sir.
Morning, everybody.
Hi,
Sumit.
Sumit again. Yes. Hi, Sumit.
Yes, क्या हाल चाल है बॉस?
बहुत बढ़िया. Please do as discussed.
Yes.
Guys, the two of you always talk as though you haven't met for years. Well, you guys keep talking 24 times a day. You maintain this as though you're seeing after 24 years. Hi, how are you? How is everything? Kya haal hai? Hi, Paresh.
Good morning, everybody. Hi. Good to see you.
Good to see you. How are you?
So, निर्मल जी, कहाँ पे बैठे हो आप? बढ़िया माहौल है.
कंट्रोल रूम पे है वो.
वाह रे वाह. ये बंद कर दिया. शर्मा गए.
Maybe his locker was visible.
Good morning, friends.
Good morning.
Morning, Dr. Neil.
कंट्रोल रूम नहीं है, ये तो उनका
Hi,
स्टडी.
Sumit.
Morning, sir.
Hi, Sumit.
Morning, sir.
Morning, UMS, Paresh.
Hi.
Yes,
So, no, I was just asking you, कि where are you sitting?
I'm in my office. What?
हाँ, इसलिए. बढ़िया.
Why?
It looks good. Perfect.
Yeah, I've got all the halls connected.
अच्छा.
So you are in all four, 1, 2, 3, 4, 5.
आप चारों हॉल में हो?
All 5.
अरे वाह. Good, good. So, well
Learn
organized.
learn from me event managing. I will train you.
हाँ.
Me and Sumit are guru. He is also another guru.
We can have someone else.
Okay.
Our course is
ठीक. Okay, so Sumit, 9 o'clock sharp, you can start. 2 more minutes. Stage is all yours. And Achal is there. He's behind the screen. So, you know, you got all the set. You got all the speakers with you. So there is not a problem. Roop Purshani, I think, has sent a recorded talk. So you can ask them to send you the talk. They'll play it on.
Right, sir.
Thank you. Thank you, Achal. Thank you, Sumit, and thank you, Achal.
So just one question. Biodatas of these
They will
speakers.
display the slide to you.
Dr. Achal, would you like to introduce and then be at the backstage? Or?
Yes, yes, we can do that.
Okay, I think that would be better. So you start the proceedings.
Yes.
And we will take it up from there.
ये वाला session is new therapies in PD, na?
हाँ जी.
First one, yeah.
So first speaker you will invite later. All right.
No, you should invite.
So I don't have the list right now.
I am going first, Achal. So you introduce me.
And the topic you will tell by yourself. Okay.
New therapies in PD.
You will have the slide. Yeah.
My topic is new therapies in PD.
Okay.
I think we can go 9 o'clock.
Yes, I think we should start. A very good morning to all of you. I thank the organizers for giving me this opportunity to chair an important session on advancements in the management of Parkinson's disease. Me and my co-chair, Dr. Atul Srivastava, would carry this session forward. And Dr. Achal, may you please introduce the first speaker and begin the proceedings?
Yes. So thanks, Sumit. And again, I will like to thank Professor Nurma Surve sir, who has invited us to be chairpersons at this very important session, which is based on Parkinson's disease therapy. And we will be talking of newer therapies. So let me welcome the first speaker, who is Dr. Meenakshi Sundaram, who does not require any introduction and is very well known to everyone. And currently he is Secretary of Indian Academy of Neurology. And otherwise also he is closely known to me as well as to Sumit and Surya sir, and everyone knows him, I would say. So let me invite Dr. Meenakshi Sundaram for his talk on new therapies in PD.
Thank you, Professor Achal. Thank you, Dr. Sumit. I will share my slide. Okay, I hope my slide is visible.
Yes, they are visible. You are audible, loud and clear.
Yeah, thank you, Dr. Nirmal, the organizing chairman of AOCNR21, and the whole team for calling me over for this talk. It's a pleasure to be here. Thanks to the chairpersons for the kind invite. My topic is new therapies in PD. I've made it new earth therapies maybe. I'm not doing, this is a very vast topic, and I'm sure that all of you would agree that this is worth a conference. So I would, in this brief time that I've been given in 20 minutes time, I will try to briefly touch upon the basics and tell you about what has happened briefly. So this will not be an exhaustive talk, and that's a disclaimer from me. I'm not going to touch on the surgical therapies because I'm sure Paresh is following me and he's going to talk about that, so I won't infringe upon that. So we all know that treatment of PD is about disease modifying therapy, and we are still looking for that elixir which can modify the disease. We have not found it yet, but billions of dollars worth of research is still going on. And then it's about treatment of motor versus the non-motor symptoms, and it's symptomatic therapy. All we have right now is symptomatic therapy, and then symptomatic therapy is based on which stage of the disease we are managing. Is it early? Is it advanced? And then we talk about device-aided symptomatic therapies. So let us look at a few of these updates about new therapies. This is from 2018, the International the IPMDS Evidence-Based Medicine Review. There's an update on treatments for the motor symptoms of Parkinson's disease. And as you can see, disease-modifying therapies, treatments that prevent or delay disease progression. The implication for practice, the max you would see is that it is investigational. There is safety, some acceptable risk specialized monitoring. What is the efficacy conclusion? You don't see anything that is efficacious. Most of them are insufficient evidence, non-efficacious, unlikely to be efficacious. That's all the conclusions have been. And the candidates have included drugs such as dopamine agonist, ropinirole, pramipexole, pergolide, the standard IR formulation of levodopa, peripheral decarboxylase inhibitors, MAOB inhibitors, supplements, exercise. So all these have, as I said, disease-modifying therapies. We are still looking for that one disease-modifying therapy which can really help these patients, really help us manage them better. Emerging therapies in Parkinson's disease, there is this write-up about repurposed drugs and new approaches. Reduction of alpha-synuclein burden can be achieved by two means: reducing its synthesis or increasing its clearance. Beta-2 adrenergic agonists, beta-2 agonists, reduce synuclein expression, the SNCA expression. This is a theoretical possibility. Increase autophagy, increase clearance of alpha-synuclein can lead to neuroprotection. That's a very nice theory, and that's very nice to work upon, but it's not that simple. ABL activation leads to inhibition of parkin through tyrosine phosphorylation and results in neural degeneration from accumulation of toxic parkin substrates. Nilotinib is an ABL inhibitor which is used for CML, and this is called the CML-NILO-PD trial in December 2020. They looked at 76 patients over 6 months, with 150 milligram and 300 milligram. There was an acceptable safety profile. There's a low CSF exposure and negative efficacy versus UPDRS3 on scores. The Pasadena trial in September 2020 was a phase 2 trial. It was the usage of the alpha-synuclein antibody prasinezumab and no demonstrable efficacy on either the motor or non-motor symptoms. It was well tolerated, but efficacy on multiple secondary endpoints, so there is something to work upon still. Year-long extension of the study is underway. The SPARK study in February 21 was a phase 2 study again. Cinpanemab, alpha-synuclein antibody, it failed to meet primary and secondary endpoints. The AIM-PD trial, phase 2, was about ambroxol, which increases glucocerebrosidase activity and removal of synuclein. 17 patients over 6 months, safe and well tolerated. There was improvement in CSF glucocerebrosidase levels and the UPDRS scores. Needs to be replicated with the placebo-controlled randomized controlled trial. So there is some silver lining, but we still need a class 1 study to tell us more about this possibility of ambroxol being used. MOVES-PD is a phase 2 trial again. So venglustat glucosyl ceramide synthase inhibitor. It decreases synuclein aggregation. It's a GBA gene mutation is used in GBA gene mutation, stopped due to lack of efficacy. The study PD3, a phase 3 trial again, used isradipine. They did on 336 patients over 36 months, did not show slowing of disease progression or improvement in motor scores. Sargramostim is a recombinant GM-CSF used in cancer. It is well tolerated. There was no worsening of EPDRS, good, no harm. It improved drug function, needs to be replicated in larger trials. So that's again a candidate that is being looked up for larger trials. Exenatide, the GLP-1 agonist in DM, decreases neuroinflammation and has shown promise. It has shown improvement in UPDRS3 at 12 weeks, but not 48 weeks. So are we looking at just a symptomatic effect? In large prospective epidemiological studies, high plasma levels of urate were associated with a low risk of PD. So SURE PD3 trial, the phase 3 randomized control trial. Inosine, a urate precursor, is used. It is closed early due to lack of efficacy. Talking about gene therapies, Sunrise PD trial talked about PRO7, it's a viral vector with 3 genes, tyrosine 3 monooxygenase, AADC, and GTP cyclohydrolase 1. It increases dopamine production. A phase 2 trial, which is ongoing, the benefits of clinical improvement have been reported. So we all wait anxiously for better results from this trial. The NLX P101 trial, it's an AAV vector with GAD genes, an improvement in the 3 scores again, the UPDRS 3 scores again, and improvement in dyskinesias have been reported. Talking about cellular therapies, mesencephalic fetal cell transplantation, no improvement, runaway dyskinesias happen. Stem cell studies are underway. European STEM PD, the NISTEM PD, the SIRA, and Summit for Stem Cell are all stem cell studies. They all use pluripotential stem cells, and these studies are awaited. Well, we do hear a lot about stem cells being used unscrupulously. Some of these trials might help clarify and put a path on which these can be done quite scientifically. Talking about symptomatic treatments, let us talk about the motor symptoms. So the treatment was symptomatic monotherapy. If we look at all these drugs, the dopamine agonists, ergot and non-ergot, the levodopa, carbidopa, levodopa, peripheral decarboxylase inhibitors, MAOB inhibitors, others, adenosine A2A antagonists, then the one that has been efficacious and clinically useful has been an extended release form. There have been others such as the controlled release, the standard IR formulation. All these have been clinically useful. So these are the ones that we are primarily interested in nowadays. So we are more likely to be using levodopa, carbidopa in these patients. That's for symptomatic monotherapy. But if you look at the other ones, the non-ergots are also efficacious, clinically useful. But then there is a tendency for us to use more levodopa nowadays. That's a viewpoint that has come in, and that is what most of us practice now, to use levodopa early rather than late. But there are other forms such as extended release, intestinal infusions, which is efficacious, definitely intestinal infusion. It's an acceptable risk with specialized monitoring facilities. It is not yet available in India, but we are probably looking at it during the next year at least. It's clinically useful too. There are newer COMT inhibitors like opicapone, which is found to be efficacious and clinically useful. And there are safinamide has already come into vogue, and all of us are using it. I wouldn't call it a new therapy, maybe a newer therapy. That's why I put in that word. Istradifilin is likely efficacious. We do not have definite efficacy parameters for that, but it's possibly useful. There are, of course, surgery is definitely efficacious, and you'll hear about it later. So we talk about extended release. We'll just pick a few and talk. If you talk about extended release, peak plasma concentration is 1 hour and sustained for 4.5 hours. Maximum dose can be up to 2.5 grams, 2,450 milligrams, 3 to 5 divided doses, reduces off time by twice compared to the immediate release, or switching to extended release, double daily dose, and decrease frequency to 2/3. If doses, the immediate release doses, around 5 doses, then we can do extended release in 4 doses. So that makes it a little easier for patients to use. That's something that might be useful, but these are not very easily applicable because some of them can be erratic in the way they act. So it is used very judiciously. The Cordion pill, the gastric retentive, extended release levodopa-carbidopa, retention up to 12 hours, decreases off by 2 hours in phase 2 trial. Phase 3 trials have been completed but not published yet. There is the enteral suspension. I will probably not go through this. It's an intestinal continuous delivery by a PEG J tube to jejunum via the pump. And as soon as it's available, I'm sure many of us would like to use it. But the side effects are due to the procedure or the pump. Liquid subcutaneous infusion under trial. Phase 3 trial is going on. Liquid subcutaneous infusion is about. And this is something that has excited many people. Levodopa inhalational powder. It's FDA approved for sudden super ops. It's like a rescue thing that can be used. It's a rapid onset. A 12-week study, 9.8-point decrease in the UPDRS3 at 30 minutes. Those 2 capsules of 42 milligram, a total of 84 milligrams. Maximum you can use 420 milligrams. There's 10 capsules. Side effects of cough, URI and nausea. Contraindications, non-selective MAO inhibitor use, COPD and asthma. So this is something that many of us are looking forward to be available in India. Apomorphine, well, there is a lot that has been said about apomorphine and discussed. So inhaled form of apomorphine is efficacious in phase 2 trials. Sublingual film has been approved in the USA on at 30 minutes, lasts about 90 minutes. Opicapone is the latest kid on the block as far as the COMT inhibitors are concerned. So 50 milligram per day. It's non-inferior to entacapone. That's, we still don't know about the superiority ratings. It increases on by 1 to 2 hours per day. Safinamide is well known. Zonisamide is used when patients start developing motor complication. It is an MAOB inhibitor, that glutamate release inhibitor plus channel blocker. Used at 50 milligram per day, it improves wearing off. We do use a slightly more higher doses too. 50 milligram per day is known to be efficacious. Amantadine extended release reduces dyskinesias and off time, and it is taken once at night. First and only FDA approved drug for PD dyskinesias. This came in 2017. Daytime plasma drug levels twice of immediate release and 37 to 43% decrease in the dyskinesia scores from pre-treatment baseline. Side effects include, as with amantadine, hallucinations, orthostatic hypotension, and libido reticularus. What are the improvements in treatment for tremors? Anticholinergics we know is limited by cognitive effects. Clozapine, useful for PD psychosis as well as dopamine-resistant tremors. Clozapine may be useful in those patients where we find it very difficult to control with only levodopa, where we can't use anticholinergics, or even with anticholinergics, it may be useful. We all know about the risk of agranulocytosis with clozapine. Beta blockers have a very variable success, but it is invariably tried in many of these patients. Gait improvement, but the gait problems that patients face, rivastigmine in the RESPOND phase 2 RCT and donepezil. They have been found to improve gait stability and decrease frequency of falls. Well, this is a little something that is arguable. There are people who claim that the use of these drugs can actually lead to falls, but this is, we definitely need larger trials. It acts on the cognitive locomotor network. Maybe when there is a cognitive impairment too that causes the gait abnormality, this may be useful. Methylphenidate and atomoxetine, the TAME PD trial, is ongoing. In motor fluctuations, estradiol, as we discussed, is an adenosine A2A receptor antagonist. Meta-analysis of multiple RCTs have been done. It decreased off times and fluctuations and may have some effect on dyskinesias. There are other similar molecules, preladinant and tozadinant, discontinued due to lack of efficacy. Buspirone, so 5-HT1A antagonist, and it has shown definite improvement in some of these UPDRS scores in reduction in the motor fluctuations too. So that might be another drug that might be useful. Symptomatic treatment, non-motor. Orthostatic hypertension, well, we all know about fludrocortisone and metotrin, but commonly used. They're possibly useful and they're insufficient evidence. What is efficacious is droxidopa, not yet available in India, but probably would be available very soon. It's an acceptable risk without specialized monitoring and possibly useful in patients with orthostatic hypertension in PD. Droxidopa is an FDA approved to treat neurogenic orthostatic hypertension, except in diabetics. This is something that we need to remember. Synthetic amino acid that's converted to norepinephrine, the norepinephrine precursor, best efficacy when demonstrated in primary autonomic failure only. Carbidopa may decrease efficacy, so be careful about the combination. Trial in PD, short-term pressor effect, standing systolic DP rise by 6.4 millimeters. Can be dosed once a day, twice a day, or thrice a day, 100 to 300 milligrams. And the side effects include headache, nausea, dizziness, and hypertension. Psychosis, well, we know about many other drugs. The drug that is known to be efficacious, and it's probably used with caution, but definitely useful, is clozapine. There is a lot of usage of quetiapine. There's insufficient evidence, not as efficacious. We know that, but it is a safe drug, so it's possibly useful, has been used. Olanzapine is not useful. It has an unacceptable risk when used. So the drugs that are used commonly, quetiapine, which is not that efficacious, but clozapine is definitely efficacious. The drug that has come in and that is probably will be soon available as nuplazid, as pimavanserin, is efficacious. An acceptable risk without specialized monitoring and has been found to be clinically useful. Pimavanserin is a 5-HT2A inverse agonist, highly selective action, is the only FDA-approved drug for hallucinations and delusions in PD and is also used in the diffuse Lewy body disease. Improvement in its SWAPS PD score for psychosis at 6 weeks. The side effects include nausea, peripheral edema, gait disturbance, and probably hallucinations. There is a risk of QT prolongation that needs to be kept in mind, especially as many of these patients fall elderly. I think I'll stop here. I think I'll finish right on time. Thank you very much for the opportunity.
Thanks, Dr. Meenakshi Sundaram, for this lovely talk. Where are the questions which are going to be put up? I don't find any chat box or question and answers.
We don't see any questions.
Sorry?
We don't see any questions.
We are not having any questions. So may I ask the question just to keep the ball rolling and then carry it forward in the meanwhile, maybe some other questions crop in?
Yes, sir.
Yeah, so my question is about these, when would be your decision to refer patients for deep brain stimulation? When the medical management you feel is reaching a point where you might not be able to modulate it much?
Well, that's a very good question. That's a question that is of primary interest for anyone who manages PD. When do we do it? Even though we have studies like the early STEM, which talks about early DBS, most of us would probably think about a time frame of around 4 years. That is not magical. There is no definite number. Anybody beyond 4 years is generally when. To me, when do they around the number? When would I think of referring the patient? When the patient is still responding to levodopa and they started developing decline ECS. I think that's the stage I start priming the patient that no, I'm going to try adjusting doses and all that, but you are a very good candidate for a surgical option. And we will try medicine, try doing everything, but we should start thinking about it. So generally, we talk to them, establish, and start telling them around that time. The next 6 months, they're mentally ready at least. So it takes that little time for them to get adjusted. So for me, the primary thing is a patient should still respond to levodopa and must have developed dopa-related complications. Of course, there must be the other that I'm sure Paresh is going to tell you what are the contraindications and when you would not probably do DBS. Those are things that we will probably keep in mind.
Thank you, Dr. Meenakshi. I guess there are still no questions. So may I request to be taking up for the second talk. And that
There is one question in the chat box.
There's one question from
the chat box. Yes. Have you ever put on meds? Have you ever put patients on meds when they already have DBS? Sometimes DBS can obliterate symptoms completely. And also, at what point should we stop the medicines? How to balance between the side effects and efficacy?
Right. I think this must be a combined answer for me and Paresh. But what I would probably do after the DBS, I don't think DBS immediately would mean that you stop all the drugs. You go slow with the drug, try to find them. As you keep programming, you know that sometimes a little medicine and then DBS keeps them going better than only DBS. So it depends on the patient. What symptoms? Do they have more gait impairment? Do they have more dyskinesia? Do they have more bradykinesia? I think all this will be taken into account as we assess and as we program the patient for the the frequency and everything else.
Can I just answer as well? Thanks. You have really enjoyed your talk also. Excellent talk. The way I think it's a question of philosophy of what your center is believing in. Since the beginning, our center believed that quality of life is more important than drug reduction.
Okay.
So we aim to improve the quality of life. And since beginning, we had around 40% reduction in our medication. At that time, Europe was able to reduce their drugs on an average by 70%. Later on, it has now been found that this aggressive drug reduction has not been a very useful advantage or strategy. And they are also now coming back to a compromise situation. So what my short answer would be that tailor it to an individual patient's requirement. Discuss it with our neurological colleagues, because there are symptoms that can be better managed with stimulation. The same symptom may be even better managed with a little change in the drug medication. So depending on what it is, you can decide as to what is the best suitable strategy for the patient.
Right. I think
so basically, my addition to this would be that the target of DBS is not to stop the medicine.
Exactly.
It is basically to improve the quality of life with a combined, reasonable approach of both the modalities.
I would agree with it entirely, and also say that from day one, the management of PD, it's about maintaining the quality of life.
Exactly.
When you start, you keep them active and keep them productive, and that depending upon their age. Thank you. Thanks for the info.
Thanks, Dr. Meenakshi Sundaram. And then now we come to the next talk by Professor Paresh Doshi. He is the guy who is known for his excessive work on deep brain stimulation for different indications, specifically Parkinson's disease. He is presently the Director of Neurosurgery and Functional Neurosurgery Program at the Jaslok Hospital and a Group Advisor for Functional Neurosurgery, Apollo Group of Hospitals, India. She is the President of the Neuromodulation Society, past President of the ISSFN, Board Member of several societies. He is the recipient of the first MedSpace India Award for Excellence in Neurosciences and has more than 40 publications and more than 300 invited lectures, and is considered to be an authority on deep brain stimulation in this part of the world. Dr. Paresh, all yours.
Thank you, Sumit, for that very kind introduction and really elaborate. I'll straight away go on to, just give me a second. I'll start sharing the screen. Is the screen clear?
Yes.
Yes,
sir.
loud, you're
Okay.
well audible and visible.
Perfect, thanks. First of all, thanks the AOCNR team and obviously our dear friend Nirmal Surya for having me on this platform. This is always a nice platform to reconnect with a different group of people than we usually address. As I said, this talk is going to be very basic with a little bit of a personal flavor of our experience. We have been doing these procedures for more than 20 years. So we do have little entitlement to put in a little personal flavor. So pardon me if it is too basic for some people, but I think it was important for this audience. So what is deep brain stimulation? It involves implantation of electrodes. We usually have 98% of our surgeries bilateral, especially when we talk about PD. So we implant bilateral electrodes in the brain, and a pacemaker is used to stimulate these electrodes to deliver a specific amount of current to the brain tissue. So which are the three targets in the brain that we commonly use? For PD, we use mainly two of this target, and these are the subthalamic nucleus and globus pallidus internus. I have also drawn the size of this target in a relative parameter. The STN target is half the size of your thumbnail. So it is 7 by 9 by 5 millimeter. It's an almond-shaped nucleus and a double oblique. So it is very tricky target to cannulate your electrode within. Whereas the GPI, the globus pallidus internus, is a target, what we call as a part of the basal ganglia. And the most medial segment of that, which is called globus pallidus internus, is targeted. And you can see that it's a fairly large target, but it has its own tricks and risks. There are two different kinds of. I'm getting some disturbance. The host, please mute your mic. Host, please mute your mic. Yeah. Okay. There are two different types of strategy that we use. One is deep brain stimulation, and second is thalamotomy.
Mansi, will you mute your mic?
Thank you. For whichever surgery you perform, it is important that you have a teamwork. Just a second. This is a setup in our operation theater. You can see the surgeon, and there are several other people, the neurologists, who help in assessing the patient's improvement. We have a navigation system, we have a microelectrode recording system, we have a fluoroscopy. All these have to be there to help you get the best outcome of this surgery. I will take you through a quick 3 or 4 steps of surgery. It starts with a frame fixation. You can see that we fix the frame, and during the frame fixation also, the patient has to be very comfortable, and he is not having any pain. There is no frowning if he was having pain. This is followed by a stereotactic CT scan, because we need to localize the target, and that is used with the help of a stereotactic CT scan. The patient is taken to the CT scanner. And a stereotactic CT scan is performed using a localizer. This is a very important part of the surgery. Once you have located the target, you drill the burr hole and you put an electrode in the brain, a microelectrode in the brain, to record its activity from a single cell. And this is what we call microelectrode recording. It's a particular signature of the STN nucleus. You can see the beautiful firing here and a very poor firing here. This electrode are only separated by 2 millimeters. So even if you are inaccurate by 2 millimeters, you would lose this. Station -4. You can see the rhythmic firing of the tremor cells, and also can listen to the background tremor rhythmic sound. So you can see this tremor, and in the next few seconds, you will see there's synchronous firing of this tremors reflected. The tremor cells fire in a rhythmic pattern, and when you get such kind of beautiful signal in the brain, then you know that you are bang into the target, and then you are happy to check for the improvement. So here I am going to demonstrate what a clinical improvement you can get on the operation table. On at 2 milliamp, station -1, turn your hand. These are the parameters that we are recording. You can see that there is slowness of movement. Some improvement has been there from the baseline, but there is still slow, and there is a ratchet-like feeling in the hand. 40% improvement in rigidity. As I said, some improvement. In pause. Station 0. We are at the target now, and there is complete loss of rigidity. Now nicely turn your hand fully. And you can see there is a full improvement in bradykinesia. So when you reach that, then you know that you are in the right target. We have got a beautiful recording which is confirmed by the clinical improvement, and then you can implant the electrode. Again, as I said, because I wanted to cover several points in this talk, I have not gone into the detail of each and every selection criteria. I'm giving you an overview. Basically, as Dr. Meenakshi Sundaram said, the cutoff time before you offer anybody surgery or anybody who would require surgery, let me put it other way around also. Most of the time, the Parkinson's disease patients you can manage very well for the initial 5, 6, 7 years. So you do not have to think about surgery. Only some high profile people or some specific people you may require surgery early. So usually do not offer any surgery before 5 years. And if your patient or the patient is very disabled before 5 years, then obviously he is not suffering from Parkinson's disease. It is more likely to be Parkinson plus syndrome or an atypical Parkinsonism, whatever label you want to give it. And that requires to be completely avoided as far as surgery is concerned. Surgery is 100% effective in Parkinson's disease. It is 0% effective in atypical Parkinson. So there is 100 and 0 difference. Do not want to put your foot into that 0%. So it is important to use this simple criteria of 5 years. On-off fluctuations, motor fluctuations, significant dyskinesias. This is side effects due to medications. Other medication side effect can also be an indication for surgery. Off-face dystonia and pain, uncontrolled tremors are some of the indications that you require. But if you do not want to remember all that, the simple thing that you can remember, when the symptoms cannot be adequately controlled by the medical management, the quality of life is getting impaired, surgery should be considered. Do not wait for the surgery as a last resort. I have come across several patients who have lost their job or who have taken voluntary retirement at the age of 55 and 56, and then they get surgery at 58. What are they going to do? They will be now back very good, they will be able to work, but they don't have a job. From 58 to 70, how is he going to cut his time? If he sits home, he is going to remember the disease all day and night. You don't want the patient to remember his disease. You want him to get engaged in his work, in his activity, in something that is more productive. So do not wait. Or a patient is 45-year-old who comes to you saying that I have got moderate Parkinson's disease. There is a possibility of 2 advanced increment or enhancement in my job career, but I don't want to take up that position as a manager or as MD because I'm suffering from Parkinson's disease, or my job would ask me to go to another country if I have to progress further, and I'm going to give it up. You should help him by a DBS so that he can continue the progress in his career rather than sitting here back and twiddling his thumb. So that is, as I said, these are all individual beliefs, but supported by scientific data. This was an American soldier who had come. Lovely. Look at the bradykinesia in the right leg. The left leg is slightly better, shuffling gait. So he wanted to get better, and this is him after surgery. So this is a moderately advanced disease. This is not a significantly advanced disease, but obviously his life was difficult and not comfortable. So he wanted it to be improved, and this is what he got. As compared to that, this is a more advanced patient with Parkinson's disease. Unable to take even a single step.
Leave her. She will be able to stand. Ask her to hold that chair, na.
This is her off-period video.
આશાબેન એ જોવાનું બહુ જરૂરત છે. બહુ જરૂરત છે.
So she's not able to take a step, and this is again a few months after the DBS, again an off-period video. Virtually, you knock off a few years of the patient's life. So here she would have been looking like 65, 70. Here she's looking like 60. She was 56, 57 when we operated. It has been almost 7 years. She's coming next week for a second time pacemaker change. So what are the outcome of DBS surgery? We looked at our own data. We published this in Neurology India in 2004, the initial 30 patients, and we had found that the motor score improvement was around 60%. And later on, we published the same results, follow-up of 4 years of these patients. We found that the motor score improvement at the 4 years interval also remains stable. The levodopa reduction, as I told you, we have 30 to 40%. In many patients, we have 100% reduction, but that's not the aim. So this is 36 to 40% reduction in levodopa, which continued to remain stable over a period of 4 years. We'll come to now special periods and time situations. One of the concerns have been about whether we should offer deep brain stimulation to the elderly or not. As I said, we depend on a lot of scientific literature, but we also have our own data that we analyze and continue to publish so that we know where we stand and are we comparative or do we have any scope of further improvement. So a comparative study of bilateral subthalamic nucleus of DBS in Parkinson's disease in young versus old, a single institutional study was recently published. So far, we have a data of 154 patients out of the 417. Now we have finished around 520 or 530 deep brain stimulation for Parkinson's disease. But this is the 417 patients that we have been able to capture the data for. 154 had been 65 and above. Out of that, 143 patients were offered subthalamic nucleus deep brain stimulation. 11 patients were offered GPI deep brain stimulation. This is the comparative graph to make it easy for you to see. The improvement in total UPDRS was 58% as compared to 52% in, there was no statistical difference in short between the motor improvement or the levodopa dose reduction between young and old patient. I will not spend again more time to go into, so then what is different in old patients? We have a separate strategy for elderly patients. We have a separate algorithm of analysis for elderly patients. We have a separate surgical plan for elderly patients. We deal with them totally differently. They are not the same way we deal with them as in younger patients. So, but again, as I said, it's not the time, the space, but I would like to share with you this very interesting patient. This patient would not have been qualified for deep brain stimulation surgery under any criteria. So this was performed with a proper ethics approval and the patient's family approval on an humanitarian ground. This patient was 73-year-old, and the reason for not being qualified was because of his mini-mental score. But this man was completely disabled, and he refused to leave the hospital, saying that either you improve me or I will not go out of the hospital. So this was him. And this is him after surgery, 2 years follow-up. He had a fantastic life. He lived very well. For a few years, I don't remember how many years, he has passed away now, but you can see the improvement and the change in quality of life. His cognition and everything improved because we could reduce a lot of his medication. So those mini-mental scores were really a reflective of his side effects of drugs, which we had been able to analyze it. But here it is him after the surgery, just to show the motor improvement. Now, if you can improve such a quality of life, this is a great rewarding thing for patients. Early STEAM deep brain stimulation surgery, and this is done with a disease duration between 4 and 5 years. An article was published in New England Medical Journal, which was a very exhaustive study by 16 centers, 9 in Germany and 7 in France. 250 patients were randomized between medical and surgical arm, double-blind randomized controlled trial, very strict trial. Based on this trial conducted outside USA, US FDA approved this therapy for early Parkinson's disease motor fluctuations. So you can understand it was a very robust trial done by the leaders in the field. and it was offered to patients with early motor fluctuations. And the follow-up was also good, 2 years. Quality of life was improved by 24% in surgical group, while it worsened 1% in the medical group. UPDR scores significantly improved by 53% in the surgical group, whereas only 1.2% in the best medical managed group. Levodopa reduction was 40%, similar to what we see in our group, and whereas the dose increased in the medically managed group. Conclusion: neurostimulation in combination with medical therapy can therefore improve motor symptoms better than medical therapy alone at this earlier stage. In conclusion, we found that neurostimulation was superior to medical therapy alone at a relatively early stage of Parkinson's disease. Again, for the movement disorder specialists, neurologists, and the neurophysicians, there have been some questions within the trial also, but those will be always there, even in the best conducted study. So you have to take some results with certain criteria and things. We had been offering to select group of patients way early before this trial even started. This is a 53-year-old gynecologist, and I told you, do not wait for your life to be compromised completely. He had a PD for 6 years. He had a tremor dominant PD, and you can see that with that tremor in his right hand, no patient is going to get operated by him. So his life was miserable. So though his Parkinson's disease was not very advanced, requiring surgery, because of his disability, which impaired his quality of life and his profession, we offered him surgery, and he got rehabilitated in 2004. And now he's able to do a hysterectomy. So he can do a hysterectomy comfortably. And this is what is important. What you are wanting is to bring back the patient to the society and give him a few more years of good quality of life, though he's suffering from disease. Then we come to the final part of the talk, and that is post-operative programming. I'll take 1 minute of the time now. I'm just finishing it. Basically, this is an art, because you can put electrode in the brain. You can put pacemaker of the most advanced method in your body. But if you do not know how to program, and that is a difference between a mechanic in a garage and an engineer in an automobile industry fine-tuning your high-end car. So it is different between those two people. Both of them can do the same job, but not as efficiently, and cannot troubleshoot when you end up into difficulties. So it is an art that you have to follow, and that is where it is very important. And that is what I commented initially when we were discussing about the indication of DBS, that basically you have to walk a very tight rope where you have to finally balance the medical improvement versus DBS improvement, and you should not be biased to either. Your aim should be seen central and improving quality of life with whatever means that you have to offer the patient. We have been also very aware about our data for studies and complication. We published in 2011 150 cases of long-term hardware complication. This was followed by 519 cases study in 2021. And what we found that as our experience improved, our rate of complications significantly decreased. Number of hemorrhage has been 0 in last 300 cases. Same rate, the complication rates exponentially decreased as the number of surgeries that we continue to improve. Though we were taking more challenging, difficult cases, more extraordinary cases, like I showed you that elderly gentleman, our rate of complications continued to decline. And based on this, we have proposed, and it has been accepted, that for a center of excellence, it is mandatory that you have around 200 DBS surgeries performed, especially if you are going to have that center of excellence training new neurosurgeons or people offering fellowship program. So unless you have had 200 DBS under your belt, that is not advisable. I think with that, I would stop. Just the last slide. The rate of our complication rate here, you can see is this series has got 1.2 or 0.6% per lead hemorrhage rate, which is one of the lowest in all the major published series in the world, and which is a credit because it's the only single surgeon performing surgeries over years. Thank you.
Thanks, Dr. Paresh, for an excellent talk, as usual. So it's always a pleasure to listen to you whilst we listen something about deep brain stimulation. So my question, while the other questions might be cooking up, where would you not offer a deep brain stimulation, even if the patient is referred to you for a DBS?
significant level of dementia, which we know is organic. So that is one biggest contraindication. And obviously all the medical contraindication which tells us that is contradictory to surgery, like any bleeding disorder or severe medically compromised condition. But if he is a levodopa responsive, and if we have no doubt that this is a pure Parkinson disease, then I don't think age is a challenge. Physical health is a challenge, because you can build up the physical health in 3 months. The lowest body weight we have operated is 35 kilos. Yeah. So no, it is a challenge, but this was a small frame lady. And obviously you continue to give them more medical treatment, but the problem is that the amount of dyskinesia and energy loss they are having, they are not able to build it up. So somewhere you have to take a balance. But yes, the most fearful area is the dementia. And if I can establish that this dementia is not secondary to drugs, then and it's mainly organic, then there is no point. Yeah.
Thank you very much. I don't think there are any further questions. I think the way you presented speaks volume about your competence. If somebody has, the guts to present his complications, that speaks the most about the surgeon. So thank you very much, and congratulations for this program which you're running. I think we'll move on to the next program, the next talk on rehabilitation. Can I have the slides of Poonam Bajaj? So Dr. Poonam is a PhD in rehabilitation sciences at Islamabad. Her current position is the Principal Dean, Professor, Foundation, University Institute.
So that's not my slide. Sorry to interrupt you, sir.
Sorry?
Those are not my details.
I don't know that.
Poonam, I think the details have gotten.
The Poonam, I think there's a mix-up. Poonam is a physiotherapist at HN Reliance Hospital, Mumbai. She's one of the senior most neurophysiotherapists who has got tremendous experience in various neurological disorder, and she has been working with me for last more than 20 years. So she's been a very, very good therapist. Thank you.
So these are all the relative shortcomings of an online event.
Yeah.
So kindly pardon me for this. So Dr. Poonam, kindly continue your talk on the rehabilitation aspect of Parkinson's, which is perhaps as important as DVS and medical treatment.
Thank you so much. I would like to thank Dr. Surya, Dr. Srivastav, Dr. Sumit for the introduction. I am going to share my screen, which is a pre-recorded talk. Sorry, one second. My apologies. Not able to. Yeah. Can you see my screen?
Not as yet.
Okay.
Everyone,
Now?
I am honored.
Unfortunately, no.
Okay, please hold on. Now?
Yes, now it's visible.
Great, thank you. Just going to mute myself since this is a pre-recorded one. So here we go.
Everyone, I am honored to be a part of this international platform of AOCNR 2021. I would like to thank Dr. Surya and Dr. Srivastav and the entire team for inviting me to speak about the subject, physical therapy in Parkinson's. I've been a physical therapist for the last 21 years, and over these 2 decades, I have seen exciting developments in physical therapy management in this subject.
Anything.
Ma'am, the audio is not audible.
The audio is not playing.
Okay,
Different
I will
subsets,
present
for
it.
instance, are the freezing subset, or what
Should I
is
start
known
again?
as the PIGD.
Now we can hear you.
Sorry, can you hear me?
Yeah, now the audio of the recording was audible for some time.
Okay, so let me just play it again.
When they occur, how they occur, how fast they occur, or how much later in the disease they occur can be different. As physiotherapists, we largely deal with the motor system. And while there is a typical set, each patient experiences these at a different time with different intensities. And so the presentation of the disease differs. For instance, as you can see in the graph, there are different times for different patients to experience the balance and gait problems. Different subsets, for instance, are the freezing subset, or what is known as the PIGD, the postural instability gait dysfunction. And hence, these patients fall frequently. We all know the main motor symptoms. I've enumerated them here. And then beyond these main motor symptoms, there is the fallout, the secondary symptoms, the freezing, the falls, the stoop, the pain because of the stoop. Let us examine what these main motor symptoms do, essentially, functionally. There are many evidence-based exercise programs, and my aim for today is not to tell you which one is better than the other, or which is the best exercise that one should give. My aim today is to tell you that therapy should not be subjective to what the therapist is biased towards. Because I have taken a particular course, I will enjoy doing that. Instead, therapy should be objectively applied to the patient's impairment. So let us examine what happens with each of these motor symptoms. What happens with bradykinesia? Both anticipatory postural adjustments and reactive postural control decreases. Now, anticipatory postural adjustments are those that are required in transitions. What is required to move the center of mass in going from sit to stand, rolling in bed, the weight shift that is required to the stance length in gait. Reactive postural responses are those that we need to react to an external perturbation. For example, opening a heavy door or standing in public transport like a bus and the bus braking and starting. We need to be able to maintain our balance in such situations, and this is what is a reactive postural response. Now, as you can see here, the subject is asked to voluntarily generate a movement within the limits of stability. And this is a largely normal trajectory versus the PD patient who can not generate voluntary movements and seems so stuck. This patient attempted as much as the normal, but this is the center of mass trajectory. Similarly, you can see the trajectory in this diagram by Morello. The outermost, absolute outermost is young people. Then the middle one is healthy elderly, how they move their center of mass and gait whilst going from stance to swing. And the absolute inner one is PD patients. They can barely move their center of mass as compared to healthy elderly. An example of an anticipatory postural adjustment, such as sit to stand. In normals, you can see where the center of mass is, how it moves forward, and ultimately when the subject is standing, it still falls within the base of support. Versus in Parkinson's disease, the center of mass, that is the line of gravity, is pretty much behind the base of support at all times. And hence, it is very well known that patients tend to fall, Parkinson's patients tend to fall backward into their chair and they need to attempt to get up 3 to 4 times. And they have difficulty, that's because they have difficulty bringing the center of mass forward. Like a normal person can bring their center of mass forward, Parkinson person can't. What happens with rigidity? The flexed and the stooped posture and the lack of trunk rotation or axial rigidity, which gives difficulty with turns and rolling in bed. And the stoop posture, as we're just going to see, is going to be with a shortened tibialis anterior. And like you see in this picture, this is on the right side is a healthy individual, healthy elderly individual using a cane. Center of mass is well within the base of support, within the limits of stability, within the cone of stability. However, the individual with Parkinson's, because of the flexed stooped posture, the center of mass is at the posterior edge of the limits of stability, already predisposing to a backward fall. Then the shortened tibialis anterior, like I just said, which should technically, eccentrically prevent them from falling backwards, because of being short, doesn't work adequately. And this is again further predisposes to a backward fall. Now, turning in Parkinson's disease, turning by itself needs a lot of weight shifts. There is initially an approach step, then there is a pivot step, and then there is the acceleration step. This needs weight shifts, quick weight shifts from one foot to the other. And this is what happens when a person is normal and can weight shift from one foot to the other rapidly. But like you see, the trajectory of the center of mass or the center of pressure here is asymmetrical. It can barely be shifted to the other foot. And because of this, it makes them unable to shift weight from the approach to the pivot foot. And so freezing occurs. They freeze because they can't shift their center of mass, and falls occur during turn. So turning and freezing and falling are associated with each other because of lack of shift of center of mass. What does impaired sensory integration do? We've been speaking about a lot of motor symptoms, but what does impaired sensory integration do? All Parkinson's patients have impaired kinesthesia. They cannot perceive how much their trunk moves, the amount of trunk rotation, their arm position, and their movement. They tend to overestimate body motion. And hence, very often you see them inadequately turning to sit in a chair and they fall just before they reach the chair. They also tend to overestimate how much they have turned. They think it's adequate, but it's not. And this is one of the largest reasons for a fall. They over depend on their vision because of this, and because of that, this exacerbates the stooped fall. In this experiment conducted by Wright et al. In 2010, it was noted on this circular platform, when the feet move in the same direction as the platform, individuals with Parkinsonism tend to have their hips, pelvis, and shoulders rotate in the same direction as the feet, whereas normals should have counter rotation movements, which are missing because of the axial rigidity. Now, what happens? What is balance dysfunction in Parkinson's disease? What we just spoke about. Imbalance leads to falls. Falls lead to morbidity and mortality. Often the ending event of a patient with Parkinson's or an individual with Parkinson's is a fall and the cascade that follows after. Falls can occur because of a combination of any one of the things that we spoke about. inadequate trunk rotation because of lack of kinesthesia, falling before reaching the chair, inadequate anticipatory postural adjustments, inadequate reactive postural control, any one or more than one of these. Let us see what happens with anticipatory and reactive postural control. This is a failed anticipatory postural control. Similarly, if I had to liken this to a real life example, imagine pushing a heavy door, like a bathroom door, forward. Often they fall flat on their faces because of lack of anticipatory postural adjustments. They're also always in a hurry because of their urinary incontinence. Gait characteristics are very classic in Parkinson's disease. As you can see in the gait analysis that was done in the gait and motion analysis lab at our center, the hip flexor action is inadequate, as is the ankle plantar flexion action. It's also, you can see that the stance phase, which is normally supposed to be 60%, is 80% of the entire gait cycle, and the swing phase is only 20%. So there is no lift off into the swing phase from the hip flexors and push off from the ankle plantar flexors pre-swing. And this is the reason for the short shuffling gait that is characteristic of Parkinson's, wherein the individual cannot swing the limb forward, the festinating gait. As you see here, there is co-contraction in all the lower limb muscles. There is roughly in the same phase of gait, there is co-contraction in all lower limb muscles. And like you see in the gastrocnemius, especially on one side, which is classic of early Parkinson's, there's almost no activity. So no push off from the calf muscle. Let's have a look at an example of an individual with PD. Shorter stride length, inadequate arm swing, inadequate trunk rotation. Prashant, उनके साथ चलो for balance. Physical therapy, therefore, should be aimed at the impairments that are predominantly seen in an individual. The individual we just saw did not have as much rigidity, as she had bradykinesia and she had imbalance and gait difficulties. Would I use the same technique for everyone? No. Exercise in Parkinson's disease is extremely essential because there are so many dopamine insensitive features in Parkinson's. Freezing is not dopamine sensitive. Falls are not dopamine sensitive. Tremors are not dopamine sensitive. Axial rigidity and postural responses are not dopamine sensitive. Yes, bradykinesia and limb rigidity are dopamine sensitive, but exercises can address all the other features. Neuroplasticity is driven by exercise. Let us examine some of the functional methods of addressing each of these impairments. So rigidity responds very well to stretching, as we all know, and also large movements of the center of mass. Schenkman and LSVT and kayaking and postural correction, which will prevent them from falling backwards. Their center of mass will be getting better, will help with all of these impairments. There are bradykinesia is significantly helped with an agility program, which causes quick and large movements of the center of mass, auditory cues such as a metronome, visual cues, weight shifts of the center of mass, which are seen in Tai Chi and boxing programs.
1 minute
I'd
remaining.
like to see what happens to her gait with a metronome. Now the metronome will start. There's an immediate difference in the stride length, the gait speed, the trunk protrusion, and also the stability. Visual cues. There's the line of care. Agility training on unsteady speed. Helps with kinesthetic awareness, increases visual dependence. For dual tasking, you can ask your patient to get on the treadmill and ask them to name 5 letters or 5 countries with the letter S. Strengthening of the hip flexors and the calf muscles, and of course all lower body muscles. There is an evidence-based program, the sensory motor agility program, the high program, the LSVT big, cycling in Parkinson's disease helps improve tremor, strength, aerobic conditioning, cognitive functioning, reduction of bradykinesia. Very recent paper, as recent as March to July 2021 by Suzanne O'Neill, proved that backward cycling will help increase posterior protective responses and therefore help prevent back falls. Yoga, Tai Chi, Wu King Si. Yoga is found to improve motor control and flexibility. Tai Chi, Wing Chun help with improvement of weight shifts of the center of mass and reduction of rigidity. Wu King Si helps with fine motor control. Assistive devices and home modification. We just saw the light beam gain. In this picture is a U-step walker, which has a metronome and a light beam gain facility. It is designed to have backward stability for the patient with Parkinson's. Our goal is to prevent falls and to improve the quality of life for our patients. We have to fight the impairment intelligently, not necessarily use a specific technique. Thank you.
Thanks a lot for your nice presentation. I don't think there are any questions in the chat box. So I think we'll move on straight to the next talk, which is by Dr. Roop Gursahani on bringing palliative and rehabilitation medicine together for Parkinsonism. I believe it's a recorded talk.
No, it's a live talk.
Okay, I was informed that it's a recorded talk. So a pleasure listening to you, Dr. Roop. Dr. Roop is a consultant neurologist and epileptologist at PD Hinduja National Hospital, Mahim, and Hinduja Healthcare Surgical Khar in Mumbai. He's trained at GMC Nagpur and GMC and Sir GGH in Mumbai. He's also working with the Forum for Indian Neurology Education, Lifeline Express, Oblique Impact India, and End of Life Care India Task Force. Dr. Roop, all yours.
Thank you. Am I clearly audible?
Yes, you are.
Yeah. So let me start by sharing my screen. Right. So what I would like to do is take the next 15 minutes or so to tell you how palliative and rehabilitation medicine can probably work together. And at the outset, I'd like to begin by thanking my good friend, Dr. Nirmal Surya, for inviting me to give this talk. Right, here we are. Now, all of us know about the cardinal features of Parkinsonism, and I'm sure you've heard a fair amount of detail on managing the motor manifestations of Parkinsonism, tremor, bradykinesia, rigidity, like in the last talk. What we have to realize is that much of this, and as is expected, did not recognize either the non-motor features or atypical Parkinsonism. And in fact, we have to recognize that atypical Parkinsonism or the Park Plus syndromes, which constitute anywhere between 15 to 20% of all patients with PD, have not only faster progression to disability, higher rates of dementia, poor benefit with therapies, a poorer prognosis with a shortened lifespan, and with PC needs, palliative care needs that are similar to Parkinson's but more concentrated. We all know that Parkinson's is essentially a progressive disease. The old Hoehn-Yahr staging for Parkinson's disease takes us through unilateral to bilateral disease with loss of postural stability, with severe disability, and eventually to somebody who's wheelchair bound or bedridden unless aided. What most people do not recognize is that Parkinsonism causes reduced life expectancy at all ages of onset. Nevertheless, we often say that patients with Parkinsonism die with it and not from it. That is not entirely correct. This is because over 70% of Parkinsonian patients die due to complications directly related to Parkinsonism. These include sepsis, respiratory failure, wasting syndrome, choking aspiration. And once somebody reaches Hoehn-Yahr stage 5, survival is just about 2 years. You can predict mortality in 6 to 12 months, especially in somebody who has accelerated weight loss and the BMI drops below 18.5, or because dopaminergic medications can no longer be used because of neuropsychiatric issues, as happens if they get dementia, or with dysphagia, or with accelerating immobility. So this is a quote from my friend, Dr. Benzi Kluger. He's the president of the International Neuropalliative Care Society, and I happen to be on the board of directors of that. And this quote is pretty recent. For years, the message delivered to Parkinsonian people with Parkinsonism has been optimistic, focused on how to live well with PD. They are told that you die with PD, not from it. Although these messages are intended to foster hope, people may feel a sense of personal failure or betrayal when their PD progresses and families are unprepared for the challenges of advanced illness. And we as clinicians miss chances to improve end-of-life care. So as a community, we must acknowledge and support people at all stages of PD, not just those who are doing well or who can be made to do well. So that our contract of hope must balance the realities of disease progression with the potential for living well and adapting especially in chronic disease. And this quote says it all. Yes, someday we will all die, but on all other days we will not, and we have to live life to the fullest. Now, what does palliative care do? It's not very different from what we've always done, except that it makes the pivot from cure to care explicit. Remember that in curative medicine, which is what we've always done, we seek to return patients to their own lives so that they can do what they want on their own. But when we change to care, it means that we assist patients in leading their lives and we support them in the pursuits that they wish to prioritize in the time that they have left. And as neurologists, we do both together sometimes for decades. And you saw in the earlier talk on physiotherapy how you manage to do this. And palliative care is an active total care, which actually is applicable from the time of diagnosis. It focuses on improving the quality of life of the patient and the family, basically by preventing and relieving suffering from pain and other physical symptoms, as well as any other sources of suffering, psychological, social, spiritual, even financial. And as you can see, these are clearly overlapping domains of care: palliative care, rehabilitative care, and curative care. We do everything together. Now, how does palliative care do all of this? The first, of course, is that because these are complex interventions, you need to have a structure and process. Then you look after the physical aspects, the physical symptoms, the psychological and psychiatric aspects, the social aspects. You do not ignore the spiritual and existential concerns. There are ethical and legal issues, especially when you come to the end of life, and all of this needs to be culturally sensitive. So you will wonder how palliative care manages to do all of that. It does. And there is a shift from the way palliative care has looked at working with other specialties, because palliative care, in a sense, is a horizontal specialty. It cuts across different specialties. When it works with oncology, you can see that disease management and palliative care, rehabilitation, all of them kind of work in a bow tie model. We realized that this does not make sense in neurology. In neurology, we are involved from the diagnosis and onwards, managing patients through their various transitions as they decompensate, as dependency and symptoms increase, down to the terminal stages, and the family after that. Now, the important thing to remember is that as a doctor, you know, or you should know, what is going to happen inevitably. If you are aware, then you have the map and you are the navigator. The patient does not. And we need to keep that in mind. So how do you integrate palliative care into the care of patients with neurodegenerative illnesses? And actually, PD becomes the classic model for this. You have three. There's a consultative model in which you have specialized palliative care on the side, and you refer individual patients for specific PC needs. But then that leads to fractured care. Then in academic and research centers, especially in the US, you have PC specialists who are integrated into movement disorder teams working on Parkinson's. This is a little resource intensive, but for high need patients and for research, this is the way to go. But for the vast majority of our patients, we will need primary palliative care, which means those of us who are not palliative care clinicians, especially neurologists, would need to train and use PC approaches, palliative care approaches in our routine management. So that requires that bit of training. And this is not rocket science. It doesn't really, it requires an open mind and acceptance that palliative care can. And as somebody who's worked in this, I know that my palliative care approaches are now beginning to be applied to my patients more and more upstream, closer to diagnosis. And I'm now able to do that more comfortably. So what are the skills that we need to pick up as neurologists? Providing diagnosis and prognosis in a compassionate manner, anticipating safety concerns. And sorry, when I said neurologists, I mean the entire community who takes care of Parkinsonism and these patients. You need to have these skills. You need to be able to discuss and set goals of care. When you set goals of care, advanced care planning comes in. The caregiver is especially important, and you need to know how to identify their issues. There are always distressing medical and psychiatric symptoms. There are emotional and spiritual issues, and when required, you go on to palliative hospice. That means end of life care. Um, about 3 or 4 years ago, the Patient-Centered Outcomes Research Institute in the US funded implementation of a project which is going to be working in Parkinson Foundation Centers of Excellence. These are identified by Parkinson's Foundation, about 12, I think, across the US. And palliative care is going to be implemented in a team-based fashion to provide uh, research evidence for actually doing this. And one of the first things that they did was bring patient advocates, patients, caregivers, together with clinicians, palliative care people, to find out from patients what they wanted palliative care and Parkinsonism experts to do together. They wanted help with preparing for the future. They wanted a greater focus on non-motor symptoms. They wanted screening and support for psychosocial and spiritual issues. They wanted support for care partners, and they wanted planning for end-of-life care. So when you prepare for the future, there comes this concept of a roadmap. Not every patient will want it, but there are enough patients, and you can judge this as you are talking to them. Who are the ones who want this? And it seems, at least in the US, this is stuff, this is information that we don't have here. But I will be surprised if Indians are any different. We are not that exceptional. In the US, the vast majority of patients and caregivers do want to know. What am I going to need in the future? What comes next and next and next? What is early? What is late? What is last? How do you know in my case? Am I faster or slower than others? Do we have a plan to deal with it if the disease progresses to a certain point? And how will I get support? So if you look at the various domains of care in palliative care, when you look at physical domains, both the patient and the care partner need resources for medication and healthcare coordination. And the main focus is on safety and support. And you'll realize where rehabilitation comes in. There's some amount of hands-on assistance required. If with psychological issues, they require peer support groups. As their professional role changes, as social interaction changes, they need to think about retirement, residential changes. Of course, you know that stopping driving in the US is like becoming paraplegic. Well, not so much for us, but still cultural. How do people navigate medical symptoms? What happens if the care partner, that's the spouse and the spouse passes away? How does that work out? And towards the end of life, comprehensive advanced care planning. They also have issues like financial counseling and so on. All that needs to be done. And these are quotes from this article that I have shown. I think it would have been helpful to have been given some idea of what was to come. It wouldn't have been such a surprise if I had known what to expect. We are all in the advanced stages of it. We are dealing with dementia, but none of us are equipped to deal with death. Nobody has talked about it until last November. 14 and a half years of having Parkinson's before anybody talked about death. So these are, if you look at this paper, it's free on the net. You'll see all these quotes. So you get the sense that people do want to know, in spite of occasionally, some family members, especially in India, feeling that the patient does not need to be told. No, that's not really so. Okay, let's look at non-motor symptoms of PD. These are perhaps not too familiar to people in the rehabilitation community, but autonomic dysfunction impacts mobility. A constipated patient is not going to cooperate with you in your physiotherapy. Pain, yes, there is something that physiotherapy can help with. We've already talked about some sensory abnormalities, but you have to realize that they go beyond just proprioception. Bulbar dysfunction, yes, speech and swallowing therapist comes in, but towards the end, the thing that dominates is neuropsychiatric issues. Fatigue, apathy, pseudobulbar effect, and dementia. A lot of patients with Parkinsonism have pain, and the pain can be musculoskeletal, it can be dystonic, you can get neuropathic or radicular pain, which is unrelated. Then there is central or primary pain, and some patients will complain of pain but actually have akathisia. And all of these need to be identified and addressed. The next, the neuropsychiatric symptoms, the biggest thing is dementia. About 80% of Parkinsonian patients develop dementia before death, and you need to address goals of care well before they get significantly impaired. They will have behavioral disturbances like psychosis, agitation. These are strong predictors and contributors to caregiver burden and distress, with both abuse, financial risk, wandering behaviors, and a good number of them respond for at least some period of time to treatment reversibly. Psychosocial and spiritual issues. Now, this is literature that is coming up pretty much right now. And you will see that these articles I have quoted are both pretty recent. So people who have higher spirituality, and that doesn't mean religion, will have higher quality of life, lower anxiety, depression. And you can actually address this. But if you fail, then you end up with patients who are demoralized. A psychological state that is characterized by helplessness, hopelessness, sense of failure. It is distinct from depression, but it overlaps with it. And it basically refers to an individual who thinks of himself as incompetent and unable to influence what is happening to him. This can be identified, and again, it needs a fair degree of counseling to handle. One of the major issues in PD is isolation. So there's reduced social interaction, partly because of limited mobility, but also because of neuropsychiatric changes. And the management can be done, especially by educating friends and family. This seems to be the most useful way to handle this, and support groups. And then comes the caregiver. I identify three roles here. The first is the care partner, which is often a spouse or an adult child who takes care of the patient or comes with the patient to give logistic support. Then comes the caregiver when the patient needs more and more supports. And in India, we are fortunate to be able to afford paid caretakers. So the context is, what is the relationship with the patient, the socioeconomic status of the whole family, and so on. How does the caregiver feel the patient's health and functional status is? This specifically applies to their assessment of the activities of daily living. What is the caregiver going through? And caregivers face challenges, but they also often get the satisfaction of learning new skills, of taking care of somebody that they cared for. There are potential resources available. And again, in this paper, the core themes that came up from the caregiver interviews is need for individual attention and support. The caregivers say, recognize me. I'm a person too. We often do that. We say, relative of Mr. Kulkarni. That is not okay. So we need to educate and give them access to helpful resources and address their concerns about the future. And as the end of life approaches, advanced care planning becomes more and more important. Now, some of you will say that this is not still acceptable or valid in India. It is not enforceable, but it is completely valid. So it consists of two processes. One is documenting their wishes. This is the living will. And the second is identifying a proxy. This is the healthcare decision maker or surrogate decision maker. Ideally, this should be included and normalized in routine care. And you need to address this, especially when people are falling, having dysphagia, or they have an unplanned hospital admission. And if you do it right, even people with Parkinson's can aim for a good death. Now there are
Dr. Roop, may I kindly request you to sum up?
Yeah,
we are
30 seconds.
running a little
I know. So there are PC. You can, as you understand, this is obviously a complex assessment. So there are tools that are available for doing this. And palliative care actually starts being needed literally from the time of diagnosis. There are trials which have shown that when this kind of team-based palliative care was provided, quality of life actually improved, and the Zarit burden inventory for the caregiver actually improved. So I'm going to end by leaving this slide here. Look at these references. These are all free on the net. I've identified those that were free on the net. These are actually all from the last 1, 2, 3 years. There is a lot of literature coming out. Remember that when it comes to palliative care and neuropalliative care, we in India are have the opportunity of joining a new subspecialty right at its beginning. And I invite you all to, I should have included a slide. This is called the International Neuropalliative Care Society, inpcs.org. You can email me. We invite anybody who's interested in this field, not just neurologists, palliative care physicians, anyone. Please join. For Indians, as of now, membership is free, at least for the next few years. Thank you.
Thanks, Dr. Roop. With this, we come to an end to this session. I don't see any questions. Any panelist has any interaction to be done with Dr. Roop or Dr. Poonam? If there are none, then may I kindly hand over.
We are running late, so 5 minutes.
Yeah, so we hand over the session back to the organizers. Thank you very much for all the participants and my co-chair, Dr. Achal, to be there, and Dr. Nirmal Surya for giving us this opportunity to be present with all of you. Thank you very much. Have a good and a safe day.
Thank you all. Thank you all. Have a good day.
Thank you, everybody.
Bye.
Thank you, Meenakshi. Thank you, everyone. So, can I have the Ujjwal and Somaya Nayak to kindly chair the next session on Symposium on Dance, Art and Music Therapy?
Hello, sir. Good morning.
Yes. Morning, Somaya. So can somebody put the introductory slide of Dr. Somaya Nayak? So this special symposium is on dance, art and music therapy in neurorehabilitation. Dr. Somaya Nayak is a neurologist who has been very much active for public forum and neurological awareness. He's from Odisha and Bhubaneswar, and been very active IAN member and very closely linked with me for past many years. So I welcome Dr. Somaya Nayak to the IFNR platform.
Thank you, sir.
So can you take over, Dr. Nayak?
Yeah. So thank you, sir, for your kind words. So we start today's session on dance, art and music therapy in neurorehabilitation. So the first speaker is Shantala Hegde, and she will be talking on neuroscientific basis for music-based interventions in neurorehabilitation. So can I have a little introductory slide from Shantala ma'am? Yeah. So a very warm welcome to Shantala Hegde. She is Associate Professor, Clinical Neuropsychology and Faculty in Charge of Music Cognition Laboratory in the Department of Clinical Psychology, NIMHANS, Bengaluru. She is also a Fellow of the Wellcome Trust of India. And she's trained in neurologic music therapy. So we'd be very much interested to hear her. She has a lot of presentations and publications, at least 50 in international and national journals. And her areas of interest are clinical neuropsychology, neuropsychological rehabilitation, and functional neuroimaging or neuromusicology. That's very interesting. So we'll love to hear from her. And she has been awarded and lot of achievements starting from 2018, the Wellcome Trust Alliance. She has received fellowship from the Helsinki Summer School in 2016 and a Young Researcher Award in 2012, to name a few. So I'll not take much time. So over to you, ma'am, Shantala Hegde. We'll love to hear you.
Good morning, all. Namaste. I'll share my screen and begin. So, thank you, the organizing committee of this wonderful conference, and my heartfelt thanks always to Dr. Nirmal Surya, who considers me as part of the family of the Indian Neuro Rehabilitation Forum, and it's an honor to be here. So, every time I come on this platform for neuro rehabilitation, I try to add something new, although some of my slides may be what I would have shared if the audience have been before in my talks on this platform. Today, in the next 15 minutes or so, I'll predominantly highlight some of the challenges of a neuro researcher to carry out research in the field of music. Because whenever we say I'm working in music, there is a thin line because everybody listens to music, everybody is a musician, and that's true. And but when we say therapeutic aspects of music, everybody acknowledges it. It's very, very powerful medium when we say music is appealing. And more so during this pandemic, we now have so many surveys that has been done. Music listening habits have changed. And based on cultural background, the pattern in which people have been indulging in music to help themselves cope during this pandemic also has changed. So music is a universal behavior. It's appealing to everyone. But when we are really talking about in therapy, not therapeutic, but in the field of therapy and especially in the neuro rehabilitation, I think we all clinicians and young researchers should put a little more in-depth thinking as to how we are going to implement this abstract phenomena, which is which is part of our human behavior, as to how we can utilize that in rehabilitation settings. So that's my broad overview of what I'm going to talk about. So basically highlighting the need for evidence-based therapy, the difference between therapeutic and therapy, the importance of formal training in any form of therapy, that's very, very important. And more so when you're talking about neuropsychological rehabilitation or neuro rehabilitation. And brief glimpse of the neuro perspective of music. If there are young researchers here and for whom this field, if it's new, I thought I'll give a broad picture of how music is being viewed in this field of neuroscience and what are the challenges in carrying out evidence-based research and what could be the future direction. So this is, for the next 20 minutes, a quick overview. So we all know, as I said, music is an age-old art form. It's antiquity, it's ubiquitous. Every known culture has it. There is also universal features of music, just like language, right? So even when we say there are cultural differences because of music, but like in language, there are different dialects, different languages. But when you break it down, the phonemes and the morpheme, the components of which builds, constructs, and makes it the whole language. Similarly, in music, there are certain features that are universal. So we have the swaras or the notes or the pitches that are equidistant, and it has a very strong biological basis also as to why our auditory system perhaps is comfortable with these discrete pitch levels, starting from the tonic note, which is a stable note, that is a sa or a shadj, or the pancham, which is a dominant note. Universally, these two are considered as unshakable notes, versus around them, there are many notes that could vary, which we call as semitones in the Western music, or in Indian classical music, we also talk about microtones. So that there are some cultural variations, but nevertheless, it's an age-old art form, and there is enough evidence to say that it is a biological phenomenon, and it's just not there amongst humans for just mere entertainment. Yesterday, Michael Todd also highlighted this point, and he even showed the evidences that are coming through from anthropological studies, how there are flutes made of bird bones. Even in other cultures, we have enough evidence to say that music perhaps plays more than just a role of entertainment. And today, from the neuroscience point of view, we have a lot more evidence to say, which I'll come to that a little while later. Again, coming to the the healing aspect of music, again, it's acknowledged. You take Indian history or the Greek history or the Native Americans, the Egyptians, you go back to the history, part of the healing traditions did have the nada or the music or the sound, vibrations. In fact, Plato and all talked about the impact of vibrations. There were Greek philosophers talking about how the mathematical correlations between these pitches, the sounds, and the harmony that it generates can have healing effect on the body and the mind. So once again, this is a widely acknowledged phenomena. Coming to our Indian traditional system, and that's true, whenever I have a discussion with therapists or scientists or clinicians, they first talk about, what about Indian music? What about the chakras? What about the ragas? There are innumerable ragas, and our textbooks talks about each raga being associated with a given clinical condition. You have pentatonic, hexatonic, that is more than 6 notes in a raga, or a sampurna raga, that is all 7 notes or variation of these 7 notes. Or in the Ayurveda itself, if you go back, not just music, but just the sound vibration, the primordial sounds like Om or other sounds rather, or with syllables attached to it, like mantras or single mantras, which also are called as the bija mantras. People still use those as therapeutic techniques or as form of therapy. So this basically means that there are different schools of thought, and what we need, the need is why it works, how it works. That's the biggest question, right? So if you go back to music as a profession, whereas in India currently, what perhaps I'm hoping and dreaming that in the next decade or so, we will have music therapy as a formal curriculum, along with a formal training in a clinical domain. Unfortunately, what is happening, musicians are doing therapy. Musicians are not clinicians. Musical training is not therapy. So there has to be this clear-cut understanding of what we are dealing with when we are saying music therapy. Western point of view, if you go back to the history, music therapy began along with the world wars, and many subjects, including psychology, neuropsychology, we owe a lot to the world wars, and the research and the science, that movement that came up like literally boomerang after that, grew exponentially. And music was again used as more from a social science model, more like, a feel-good phenomena for war veterans who were in the hospital. It was not formally thought of that, okay, let's decide this technique we will use and then there will be an outcome. What it did was, the war veterans who were admitted in hospital listened to music, felt good, their mood uplifted, they felt that they could handle the pain, for example, and then began this whole field of music therapy in a more formal way. Until then, whatever I shared was more historical and more cultural phenomena. Today, we have come a long way, at least in the Western world. We have, registered association, training program, certification program. So we clearly know that a music therapist, if they call themselves as therapists, they're formally trained, they have credentials, they know that they're not just doing music for the feel-good factor, but they have a specific clinical outcome. So we all know when we are rehabilitationists, we target what behavior that we are interested in. Are we targeting the physiological aspects? Are we talking about the language aspects? Are we talking about the cognitive aspects? What is our outcome interest, and thereby using the techniques in a more systematic way. So it has to be transferred to their real life functioning, and not just say, I'm just doing musical training and patients can sing a song or patient can recite something. That cannot be really considered as an outcome parameter. So in that sense, you're actually working even in music therapy, just like in any other form of holistic therapy. You may work with not just the clients, but also the family members, addressing various psychological, emotional, socio-cognitive needs of the individual. So this question of why does music therapy works, people in the field of music therapy kind of lean back on the schools of thought of psychology, because you are dealing with mind, the effect of music on the mind and the behavior. So theoretically, people talked about psychoanalytic school of thought, music helping to bring out the unconscious, and bringing it to the conscious level, bringing out the emotions, more imagery, the guided imagery techniques, which are still being used in the field of music therapy. Then came the behavioristic school of thought, looking at, how there are techniques like cognitive behavior music therapy techniques that are, again, still being used. Humanistic school of thought, looking at bringing meaning in life, giving a larger meaning to the therapeutic techniques that are being added to it, like creative aspect of music, giving a larger meaning to one's own conflicts and issues. So leaning back onto the humanistic schools of thought. The recent ones, of course, is the neuroscience point of view. That's the frontier area, giving us evidence as to why music therapy is working. If you use a given technique, it could be as simple as listening to music. I'm giving my patients a task of listening to their own choice of music. And there are now so many studies looking at, even in, let's say, patients with stroke, patients with infectious disorders, dementia, helping them recover autobiographical memory, recollect autobiographical memory. We know that happens, but why it happens, what is the process behind it, how does the mechanism work? All that is now being answered through the research that's happening in the field of neuroscience and music, also called as the neuromusicological research. Now, yesterday, Dr. Michael Todd discussed about the neurologic music therapy. It's the school of thought that he kind of brought together in terms of looking at the neuroscientific research, putting it in the evidence form, and some of the techniques that were already existing, like rhythmic speech cueing or melodic intonation therapy, that was existing there. He modified it, collected all the neuroscientific evidence, and brought these 20 techniques under the umbrella of neurologic music therapy, which is wonderful because at least we are now discussing about universal way of using the same technique, no matter where the clinician is from, which part of the world the clinician is from. And then the communication between the therapist is very scientific in nature. So you use the same jargons, you use the same outcome variables. You're saying, this is the technique I used, and you know what really I have done. So how does it work is the biggest question. And this is something that all science has to go through. It's like the litmus test, right? So we have enough evidence to talk about from case reports. There are innumerable case reports in the field of music therapy. There are journals on music therapy, art and music therapy, art psychotherapy. So you have enough of case reports. And today we have kind of come back to the circle in the way that today even Journal of Cognition says we accept case reports. We are back to saying that there are a lot more that we can understand through single cases, undoubtedly. Yet we also need a lot more large sample size. We need RCT trials, we need randomized controlled trials, only because we are all humans, even though we are scientists, and there could be bias in our own techniques and methods. So if you say, I have used this litmus test and say I've done double-blind study, or I have done this, active control or a control group study, it has more value to say, okay, how much does it benefit? For example, being a neuropsychologist, and I read literature on neuropsychological rehabilitation, cognitive rehabilitation, the effect size is, somewhere with mild to moderate. We have not reached like significantly high levels of effect sizes. Why? Because the techniques are different, the methods are different. So we are leading the whole field towards the point where we could find techniques and methods that can help us with large effect sizes. The second, in rehabilitation, I'm sure no matter what technique you're talking about, the biggest challenge is generalizability and sustenance of the improvement you've seen. How long will it sustain? Will the individual have to continue some of these techniques till they are alive? So these are the biggest challenge. And I think even in the field of neuroscience and music, this is where we are heading towards. And when I say neuroscience evidence, it need not always be, you just use music in the form of music. So many people ask me, so which raga do you use for therapy? I say, no, I break it down and I use techniques where I look at components of music. So I may use just the rhythm. I may use just the metronome. I may use just the songs with just the lyrics, which have functional usage for a given patient. I would like to see which patient I'm seeing and which technique I'm going to use for what. So there is this difference between when I say something is therapeutic versus therapy. So if someone comes and says, would you suggest your patients to listen to music? I say, please go ahead, because listening to music can be therapeutic. It's like telling your patients, please have good food, please have good diet. So please do some exercises. But exercise, just doing exercise is not physiotherapy. I'm sure physiotherapists will appreciate it. So it is like saying, definitely listen to music, indulge in music, actively engage in music, no matter what your age is. But when I say therapy, let it be done by a trained clinician with a specific outcome goal and what needs to be used in terms of not just feel-good factor, but a specific techniques. So music therapy is a clinical and evidence-based intervention program. And I have been trained in NMT, but I am a neuropsychologist. So I use music NMT techniques to improve language functions, neurocognitive functions, and associated motor functions, not someone in so much in rigor as a physiotherapist, but definitely some motor functions. So this neuromusicology, new field, literally, growing in exponentially in the field. Recently, we had a conference, ICMPC, the international conference, India Hub, and we had about 700-800 papers dealing with different aspects of musical behavior. So there are enough evidence now in the field. I have 5 more minutes and I will wind up, is that you have enough evidence now with EEG studies, fMRI studies, studies on acquired conditions like head injury, epilepsy, dementia, or studies done with very rare conditions like congenital conditions, which are saying that music is definitely a biological phenomena. It engages your entire brain networks, multiple brain networks. So it has the capability to translate these underlying neural functions to the non-musical domains of functioning. And that's what, as therapists, we want, is that you're not, as I said, you're not expecting your patients to become good musicians or good pitch, with good pitch perception or good rhythm perception. But you're saying, by improving these functions, am I able to translate it to the functions that have more functional adaptive value in a more obvious way, until unless the patient themselves are musicians and they want their musical skills to be retrained. So as we know today, music engages host of networks, so emotional network, the motor network, there's the entrainment. So that is the reason why music therapy techniques are beneficial in conditions like Parkinson's disease, in conditions where motor pathways are extremely involved. But today we know motor symptoms are also so closely associated with non-motor symptoms. Like it could be their emotional processing, neurocognitive functions, sleep disturbances, and so on and so forth. So the idea is music can engage multiple networks at one go by retraining, because you're tapping to this core nature of the brain, that is the neural plasticity. Whether you do neurorehabilitation or whether you don't do neurorehabilitation, the brain will continue to adapt to the environment and change itself because of its nature. But with rehabilitation, with focused rehabilitation, you're actually fine-tuning this brain process to make it more adaptive plasticity or positive neural plasticity. So key thing is, one, music is beyond entertainment. Then there is enough evidence, of course, today over the last 3 decades, but there's a lot more need to do high stringent, RCT trials to exactly say why this transfer effect could be happening. For example, in this particular image, which may look complex, but I'm just trying to highlight that the
Shantala ma'am, can you just wind up? Actually, we are running short of time.
Yes. So we are basically looking at the basal ganglia structures and how it could translate to the frontostriatal network of neurocognitive functions. All right. So let me end up saying that.
Our hospital, we have
so let me wind up saying that there is. Am I hearing someone's voice? Sorry. Okay. So there is
the other participants.
Yeah. So there is need definitely for evidence-based research. There is enough now coming through meta-analytic studies in certain conditions. There is need to be aware of this difference between therapy and therapeutic. and need for formal training in any field that you take, but definitely be a clinician and then take up the application of music-based intervention. There are challenges, of course, when you bring it to Indian classical music because of its complexity itself. And especially when you want to do basic experimental research, there are innumerable challenges which one needs to cross. So thank you so much for the time. Yeah. Thanks to my team and thanks to my collaborators.
Somaya, may I request to invite Dr. Humberto to talk on pet therapy, because he has got another lecture in the Hall 1.
Yes, sir. Sure. Thank you, Shantala ma'am, for your amazing talk. We'll have a few questions for you at the end of the session. Hope you'll be staying with us. And it was very enlightening. And we would actually like to know about the objectivity of this music therapy, how long, the duration, and anything, any scores or any studies where we have some objective evidence of patients doing well, either Parkinson's or TBI. So we would like to hear that from you. But now I'd like to welcome the next talk is by Dr. Humberto, sir, or Dr. Purnima Gauri.
Yes.
Humberto, please. He
Yeah,
has to go to Hall 1.
I'm going to be sharing the
fantastic lecture, not just the journey of
So can we have Dr. Humberto's CV, please?
Okay.
Okay, he's on top. Okay. So welcome, sir. And
thank you very much. Thank you very much for giving me these opportunities. Just 1 second, please. Okay. I would like to thank the AOCNR Secretary General, Professor Dr. Nirmal Surya, for the invitation. And of course, the head of the Spinal Cord Injury Unit at Craig Hospital, Dr. William Shelsa, for giving us the opportunity to be here with you today. I would like to apologize with the organizers because I'm basically substituting Dr. Lisa Elder and Emily Aldrich, CTRS from Craig. Just 1 second, please. And that I'm substituting them because due to unexpected problems, they are not able to be here today with us to present pet therapy in neurorehabilitation. Now, for the correct people, and I guess for all of us, during this period of time of COVID consideration and general of COVID, of course, you know, the assisted therapy with pets in a hospital needs to be taken care. And as such, you know, as for any sort of screens that for people coming inside the hospital, the Craig Hospital basically, as you can see, have some sort of general guidelines. First of all, self-screen prior to arrival to the Craig campus. They need to screen the animal for signs of illness, which is very, very important. Upon arrival, they check into the front entrance and first to get screened and sign in. Once you receive a volunteer sticker, they report it to the therapeutic recreational service. And just 1 second, work mask all the time when on campus and in patient care areas, both indoors, outdoors, regardless of the vaccination status. So for correct people is safety first, as for all of us. So clean all materials before and after the patient interaction, leash, collar, vest, harness, toys, chairs, tables, etc. Prepare barriers like towel, blanket, if animal will be on patient lap at any time. Handler is responsible for instructing patients and staff to maintain social distance. No more than one patient at a time with their assigned caregiver and a care therapist. restrictions. Animals are prohibited from the following areas: food prep kitchens, laundry facilities, clean utility and supply rooms, medications prep areas, procedures rooms, patients rooms under precautions. And before and after any human and animal interactions, pause, which means please always wash and sanitize. And this is correct recommendations. Regulatory requirements. Animals must be under control of handlers. And when we talk about animals, we're talking especially about dog therapy at REC. So leash needs to be 4 to 6 feet in length, appropriate responses to voice commands, annual proof of vaccination against rabies, distemper, lepto, parvo, bordetella. Animal must be clean and have no open source of wounds. These regulatory requirements are indispensable for dealing with the pet therapy. Handler is responsible for animal cares. Any animal that bites a person will be removed from the hospital and not permitted to return. It needs to be cleaned, the bite immediately with soap and water, refer to the person to medical care, complete the event report. So in few words, animal-assisted interventions provide a recent treatment alternative, which is showing promises results in neurorehabilitation. In the United States and most of all in Northern Europe, this type of therapy has begun to be implemented in a regulated and systemic way to deliver. I have to be honest with you. In my hospital in Italy, Northern Italy, we don't have pet therapy. In Italy, very few centers, maybe 1 or 2 neurorehabilitation centers do have pet therapy. It's not so usual to have pet therapy in Italy yet. The term neurorehabilitation describes the process aimed at reducing the impairment, limitations on activity, and restrictions experienced by a patient with a neurological disorder. The ultimate objective is to reduce the patient degree of functional impairment, and several therapies can be used to this end. And assisted animal interventions is only one of these possible options. So animal-assisted activities are activities that involve support from animals that meet specific requirements. Since activities are informal, they are characterized by a certain degree of flexibility and spontaneity. Their purpose is to achieve interaction between the patient and the animal, thereby stimulating the patient's social skills, motivation, learning, and other areas that may have a positive impact on the quality of life. Instead, animal-assisted therapies is a formal intervention with precise therapeutic objective in which the animal acts as a co-therapist. It is targeted for a specific diagnosis and forms part of a rehabilitation program coordinated by a multidisciplinary team that records the patient progress in his or her medical history and assesses the results. And as you can see here, basically the animal-assisted therapies, it's very well goal-oriented, very well structured, and it's a multidisciplinary interaction with PTs, OTs, recreational therapies, speech pathologists, psychologists. So as we said, the benefits are basically to reduce the stress of the patients, to lower their heart rate, especially in brain injuries. You know, it's a very important issue. Reduce anxiety, increase motivation, address goals directed. And as we know, in neurorehabilitation, neurological disorders are basically famous for promoting as a complication to deal with neuropathic pain and discomfort. And so this type of therapy may assist distracting the patient from this. And it decreases, of course, loneliness of the patients and many other benefits. Now, animal-assisted activity is done, as we said before, in PT rooms, and they must be scheduled ahead of time to control contact and follow hospital guidelines. These will occur, these room-to-room visits will occur in the evening after the physical therapy hours. Patients will be given the opportunity to sign up for room visits by choice. Room visits will be scheduled basically on your availability. You will receive a list of rooms to attend prior to your arrival. It needs to be checked by a nurse prior to entering into a patient room. And the people from the correct staff, the patients and family are so excited to have you back at the hospital, regardless of the excitement. Please, it's very important and for correct staff to reinforce the fact that the current restrictions in the case that unscheduled patients, staff, or family are approached. As we said, it co-treats the animal-assisted therapy with PT, OTs, recreational therapists, and psychologists on a scheduled base. These therapy sessions will occur during therapy times and will occur in therapy gyms, psychological office, or PT rooms, or therapeutic recreation rooms. The therapist will sign up the patient for this appointment based on PT goals, needs, and progress. You will receive necessary appointment details prior to your arrival. And as we said, you know, it involves a multidisciplinary activity with other disciplines like the therapeutic recreation, the physical therapy, occupational therapy, speech pathologists. And the goals of course, of the discipline of therapeutic recreation is to promote confidence, independence, and overall well-being. And so by increasing quality of life, returning to leisure education, community reintegration, education on appropriate adaptations for leisure and recreations. And so the animal involvement, basically what it does is reduce the stress while trialing new devices and equipment, pet care, pet exercise. It makes the patient be involved in the upper extremities and lower extremities, strolling in community, wheelchair skills, animal-related art activities. The physical therapy service basically is to, of course, to maximize functional independence and mobility. And basically the goals are to have a progression in the walking, training, balance, stretching, upper and lower extremity strengths, upper and lower extremity range of motion, ambulation, and endurance. And so with the animal involvement, you have walking with leash and dog, throwing ball for fetch, obstacle courses, facilitate participation, be distracted from pain. And for the occupational therapy scope of assisting this type of therapy is to maximize independence in daily living skills. So upper extremity control, body awareness, self-care. And so this is done through pet care tasks, motivations to reach occupational therapy goals, through animal involvements, rewards, encouragement, step-by-step recall. Those are practices that are helped by the animal involvement. And for the speech and language pathologists, therapists, to facilitate growth of the cognitive and behavioral skills and to learn new strategies, to improve abilities in communication and also for swallowing function. So basically, you know, the goals for speech pathologists are basically improve verbal expression, comprehension, initiation of activities, generating thinking, writing, reading, or attention to task. And with the animal involvement, basically how it's done by patient basically saying commands, the animal following the commands, patient basically generating lists of interview type questions even for the volunteers, patient reading aloud to the animal, patient throwing ball, petting, giving treats to dog to sustain attention for longer periods of time. So in conclusions, the efficacy of animal-assisted therapy depends, of course, on the type of animal use. You can use dogs, you can use horses, different animals you can use. But it's important also the setting where the sessions take place, the duration of the intervention, the type of disorder and age of the patient, and whether the sessions are individual or in group sessions. Evaluating the effects of animal-assisted intervention is really not a task, an easy task to do. In terms, AAAs promote social skills, reduce stress, anxiety, loneliness, improve mood, increase well-being, and help patients develop leisure skills. This is the result of a natural tendency by which some animals forge strong bonds with humans, thereby creating intense no-verbal communication. All animals associated with pets therapy are health and temperament checked, and for inpatient visits, our unit, so the CREC unit follows strict precautions, including no exposure to patients with open wounds, animals, not to go into patient areas, rooms where the animals are seen are thoroughly cleaned afterwards. Naturally, those patients with animal fears or allergies should not be exposed, and there is a risk of trauma, including bites or even infection transmission. Well, I need to thank you for your attention. Sorry for my intervention. I tried to do my best trying to interpret the message from our friends from Craig Hospital in Denver, Colorado. Thank you.
So, thank you, sir, for your wonderful presentation. And it was very enlightening to know about how you manage pets, and especially the precautions which we take and how important it is for neurorehabilitation. So thank you for giving us your valuable time, and we would move on to the next session.
Thank you.
Yeah, so we'll move on to the next session, which is on art therapy and neuroresilience by Dr. Purnima Gauri. So can I have a CV, please?
Digital team, kindly share the Purnima's CV slide. You have shared it before. You can share now.
Yeah. Yeah. So we have Dr. Purnima. She's DNB Medicine and DNB Neurology and a visiting fellow epilepsy at Melbourne Hospital. And she's based in Pune, Nagpur. She's working on health, wellness, and fitness industry. And her areas of interest are headache, epilepsy, sleep disorders, stroke rehabilitation, and cognitive and behavioral neurosciences. She's a social engineer, and she's also working with the Advocacy Foundation for a lot of advocacy units and self-growth fitness. So I invite Dr. Purnima to give her talk on this art therapy and neuroresilience. So kindly stick to your time.
Yeah, sure.
We'll have questions later.
Yeah, thank you so much. At the outset, let me thank Dr. Surya and his team for such a wonderful conference and for making me a part of this. It's a little challenging topic because just like music, art has been in the very background of being used for medical purposes. So, though we know that artistic and scientific creativity have promoted the development of our human civilization, now, art, when we look at it, it is broadly performing arts and visual art. Performing arts, the audience will take enjoyment from the artwork while the performance is going on or from a recording, and that experience ends there. But visual art remains there for the observer to perceive and interpret it for till that artwork perishes. So that's the difference between performing arts and visual arts. And the Cold War is ending. The Cold War between the scientific approach to art and the artistic interpretation of the world, they are in ending. Though till now, this is from a book published in 2011. Neuroscientists may not consider aesthetics worthy of inquiry, and some aestheticians or even artists, they consider neuroscientific inquiry into aesthetics as an abomination. But only recently the two fields have come together, and I, being a parietal lobe neurologist with sensations and perceptions of my own, I find myself as now an advocate of art as well as neurosciences. So I'm a neurologist based in Pune and Nagpur and an artist myself. And this is our NGO, Niche Advocacy Foundation, where we promote neuroplasticity for individual and community health education. We advocate for it through our various projects. Now, I will be talking on visual art and neuroresilience and little about the therapeutic aspects. My first half is about the visual arts and the neurobiology of it. So, art and the human life are very much intricately interconnected, just like music, what Shantala ma'am spoke about music, the same much of it goes for art as well, visual art as well. And very beautifully highlighted, motivation was very beautifully highlighted in our inaugural function speeches, and internal as well as external motivation was highlighted in this, and art can be a tool for motivation as well. So these are the cave paintings or cave drawings from prehistoric times, where these paintings or these drawings are living on to tell us the stories of even that era. And at that time, we don't know how much language was developed, but some hunting was going on definitely. And this value of hands, and there is a lot of literature about the interpretation of these drawings. And India is a country of elaborate art forms everywhere. We have centuries old carvings and caves which tell us a lot of how life was at that time and the depth of intelligence that the people had at that in those eras. And this is the Egyptian script, where in their transformation into a written script, they went through a phase of logographic scripts. And I had read a blog many years ago where the photographer had wondered, what if we had developed language through pictures rather than through symbols which represent sounds. So what if we had done that? It would have been a different algorithm of evolution of the human beings. So it's a point to ponder, that what if this particular kind of a script had gone forward rather than our symbolic representations. Now, graffiti, art in life around us, basically. So graffiti is a very, very spontaneous form of art. Art, visual art, can be very, very planned and organized, or it can be just spontaneous. So one of the very public forms of spontaneous art, visual art, are graffiti, and graffiti has aided in revolutions as well, and even teenagers use it as a form of self expression. And my friend has done a PhD in graffiti. He's an artist, and there is a lot of psychodynamics behind this whole graffiti, where they want to be seen for their work, but they don't want to be known for who they are, so they are incognito. So this is a boy from Nagpur now. He's working as a graphic designer somewhere, from born in New Zealand and came to Nagpur, and he found all the walls empty for his work. So he features again in my talk after some time. And graffiti has been on the fringe of the art world. Artists didn't want to accept it as art, but now graffiti is becoming an organized art form, and it is being used for beautification of cities. And if you go to New York, or if you go to certain countries or cities where graffiti is very prominently used, we find that the large part of the beauty of that city is because of the graffiti in that particular city. This is on the wall. So another form of spontaneous visual art is something we all resort to. These are doodles by my school friend who is working in finance. So he doesn't have much of art training, but this is what he does when he is in a boring meeting or in a boring lecture. So graffiti is something that doodling is something that we all do. And these can be very detailed. These are very detailed doodles that he has done. So it must have been an extremely long and boring meeting. So what I'm trying to argue about is that art is an indivisible part of our life. And this is again a folk visual art form. It perishes within a few days, but it remains there to add beauty to our life. And we cannot imagine our festivals without this visual art form of Mehndi, which is again planned and an organized kind of a form, which will come under folk art. And now this is again another kind of a visual art which can range from romantic and beautiful to rebellious. So this is a form of expression. Visual is art is not only a celebration of our cognition, it is also a basic need and instinct. So visual art is a part of our higher functions. It is a part of our higher cognitive function, because a lot of abstract thinking goes on, and then there is this need from inside which arises for an individual to express that whole thing into a visual art form which can be visible to another person. So it is a form of communication as well. And art and the human brain, let us see the neurobiology. Now it is very difficult to assess the neurobiology of art, because doing a functional MRI of an individual while he is doing all this. So this is from my teacher from whom I'm learning watercolors right now. So he's going through, now he has selected one picture, something clicked in his parietal lobe that this is what he needs to paint today. And I've chosen the watercolor video because it is the fastest form. A good artist can finish a good watercolor in 25 to 30 minutes. So now he's making a thumbnail. So his fine motor areas are working, and he's planning and executing so he's reducing that photograph into his own plan of action. So a lot of prefrontal and frontal lobe work is going on, and that prefrontal lobe is coordinating with his parietal lobe and with the fine motor. And now he's going to the phase 1 of his actual artwork. So here again, he needs to know about how the colors work, how they interact with the paper, how the paper responds to the color, which color should he take first. So as a neurologist, when I started learning watercolors and I was observing him, I was wondering that what is happening in his brain. I can see what's happening in his hand, but what is happening in his brain? And it's very difficult to assess the biology. We can right now, I can assume, and if some techniques can be developed to study this, it would be fantastic to know actually which part of his cerebellum, which part of his frontal, which part of his prefrontal. And he's just giving the wash, and constantly his brain is interpreting. There is a lot of feed forward and feedback going on between his prefrontal, frontal, his premotor area, supplementary motor, and his parietal lobes, which are deciding, okay, what I've done is right, what I've done is wrong. Now, this is the phase 2 where he is giving the second layer of the color, which is a thicker color. And now he is deciding from his thumbnail and from the picture. He has lost track of the original picture. Now, this is his own painting. It is no longer a copy of the photograph. And here now, the artist has become cognitively engaged. He has become emotionally engaged in his artwork. And that is the magic about art, that cognitive engagement, emotional engagement, and at a level spiritual engagement. It is an immersive technique. He is immersed. He is completely immersed. He has possibly lost track of the rest of the world around him, whether his wife is shouting or daughter is crying, all that he has lost track of right now. Or if he has some financial worries, he has lost track of them right now. And that is the part of artwork. And here now he is coming to the last part, detailing. Now a lot of prefrontal work will go on in detailing, and a lot of fine motor. The size of his brush is reduced, the paint has become thicker. So all the association cortices are working to help him with the knowledge base that he has. And here he comes to the ending of his picture. And at the end of this, we have a beautiful painting ready, which is perhaps more beautiful than the photograph that he had chosen. So it's a very, very immersive technique. It is time intensive, and watercolor in the right hands is one of the fastest way of creating absolutely beautiful artwork. So now he's just giving the finishing touches, and we have just 16 seconds of the video left, and the painting is ready here for us to view. So he's a student of our very well-known international artist, Mr. Milind Mulik. He's the artist whose video is here. His name is Mr. Virendra Tikhe. So different brain structures are associated with artistic and scientific creativity. They studied they did volumetric studies of artists and non-artists, and they found that the gross gray matter volume in scientific creators was significantly positively correlated with left middle frontal gyrus and left inferior occipital, whereas artistic creativity was associated with the salience network, which includes the insular cortex as well, and some amount of involvement of cuneus and precuneus, and the parietal cortex on the right side, of course, we all know, for visuospatial and fine motor activity. Now, drawing on the right side of the brain, a voxel-based morphometry, this also we have, and they found that artists have structurally different brains with higher volume. So they also had the same conclusion. So basically, it involves various regions in the brain. We saw the process. Otherwise, we sit in our rooms and we feel, okay, artist means right parietal. But no, there is a lot of planning involved in art, and the engagement, the way it involves you in the whole process is extremely important, and it can be very important for creating motivation. And there's an interplay, or there's an orchestra of synapses, and as we are learning the skill in a fresh manner, so newer synapses are happening. So the immersive nature of art is extremely important, and different levels of consciousness can be achieved. There are videos pertaining to this, that the artists know how to take themselves to a different level of consciousness to be able to imagine what they are going to put up on the canvas. And now there is more data available for this, the neurobiology of interpreting art. So who interprets art? Are only the elite critics the interpreters of art? No. Even if you see now so many paintings, I've tried to make my presentation extremely visual. So whenever you see a painting, something is going to arise in your mind. Even if my talking is going on in the background, you're going to think of something, you're going to sense it, you're going to perceive it, you're going to interpret, and at the end of it, you're going to feel it. Feeling is different from emotions. Feeling is a mixture of emotion and cognitions. There are books written by a neurologist on this, who is doing functional MRI studies on emotions and feelings. So for example, this artwork of mine is hanging in my living room, and I saw my maid stare at it every day. She sweeps the house, she's staring at this. And one day I asked her, what does it make you feel? Why do you watch it so much? And then she gave me a whole paragraph about what this painting makes her feel. So all of you can also take some time to see this painting and just feel what it just think about what it makes you feel. So at multiple levels, your mind is working, you're remembering things, you're remembering places, you're remembering photographs, and you're perhaps remembering moments you have spent. So it's a very engaging experience interpreting art, and they have done studies for there is this whole book written on sensation and reward, in which there's a whole chapter on visual art, and they have found that a cognitive framework and visual aesthetics. So now this whole field has been born after the Cold War has ended, about neuroaesthetics, about being able to understand the neurobiology, about how humans react and respond to visual art. So this is again that same from where I had put that sentence about the Cold War being ended. So they have found that artists like visual neuroscientists, they endeavor to uncover important distinctions in the visual world, and in doing so they discover modules of the visual brain. And recently Kavanagh in 2005, he has claimed that the artist's goals resemble those of the nervous system. So what our nervous system is aiming for, the artists are aiming for that. And he observed that paintings often violate the physics of shadows and reflections, colors and contours. Rather than adhering to physical properties of the world, these paintings reflect perceptual shortcuts used by the brain. And I was wondering as a student from my art teacher, oh my God, this is not how shadows look. And he explained to me, no, but this is how we draw them, because this is how the eyes see them. So artists, in experimenting with forms of depiction, have already discovered what psychologists and neuroscientists are now identifying as principles of perceptions. So they have reached there faster. So the debate continues whether the creative artists are superior intellectually and spiritually to the core scientists. So it is open for interpretation. So resilience, I come to the second part of my talk. I'm going a little faster because of the time constraints. So resilience basically is a preventive process. Resilience is something we should be giving our children, we should be teaching in schools, so that the networks of the brain become strong enough to withstand stress, so that whenever there is disease, the person can bounce back faster. So resilience is essentially a preventive process, but in recent times, we have found resilience as a tool for rehabilitation. Now, motivation can be internal and external, and art, being an immersive process, is an important tool for motivation, because art can keep a person engaged and motivated to want to do that particular activity. So the person should be engaged by the journey and should want the destination. Only then rehabilitation is going to work. I have recently had my own fracture, and I found, I'm sorry to all the physiotherapists around here, I found physiotherapy extremely boring. So I had to include rhythm in it to add motivation for myself. So remaining motivated to do the therapy is important, and discipline is daily motivation. And without motivation and discipline, we cannot rehabilitate anyone. And art can be an immersive tool, an important tool, because of its immersive nature. How to teach art? The way we were taught in school as an optional subject, nahi kiya to bhi chalega, iske marks nahi pakde jate. So instead of that, if we can tell people the importance of art, and so that their right and left brains are developed in equal measure, so that resilience can be very much available when the time comes. So resilience and rehabilitation, a lot of research has been going on in resilience as a factor in rehabilitation. So enabling the person to bounce back to a sensible life after that particular incident in the person's life. It may be a sudden illness which is of a short duration, or it may be a chronic illness, just like Dr. Rup Gursani said, like Parkinson's disease, or the whole session we had, which was beautiful right now. So resilience becomes important in that, and resilience becomes a big part of palliative care, because we need the family to be resilient, we need the caregivers to be resilient, and we need the patient herself or himself to be resilient. So these are some of the researches going on resilience, and they have found that there is not just emotional resilience, not just spiritual resilience, not just physical resilience, also socio-ecological resilience in rehabilitation programs and returning back to work. self-efficacy and stress mitigation is also a part of the whole resilience building. And there are implications for rehabilitation for individual resilience, and individual resilience is an important factor promoting functional recovery even after traumatic injury. And resilience rehabilitation programs are effective in enabling patients to return to work and increasing their self-efficacy. So we have done this workshops in Bharti Hospital for COVID warriors, frontline workers, actually people working in ICU and managing patients on ventilators and all, who are absolutely stressed out during the COVID times. And we did this simple acrylic pouring workshop. Lot of these videos are available on Facebook, Insta, YouTube, everywhere. And they are extremely engaging videos because the process is simple. Sorry. The process is simple, and you don't need to be trained for any formal art and, oh no, my drawing is not very good. So we just layer some this workshop was conducted by me only. So that's me holding the canvas. And this is what I taught the set of 10 doctors and COVID frontline workers. And it was a 2 hours workshop. So, and everybody's response was that they did have a great time. And we did come up with a lot of great artwork. And those of you who know Sonal Chitnis, her artwork is also a part of this workshop. So this was a relaxing technique. So therapeutic. Now measuring change is something we are going to need to do to put this into a perspective and make this into a particular technique which can be taught and can be replicated. And perhaps 4 years down the line, I will be presenting an actual scientific paper on the use of art in different sets of disorders. We have yet to come to. So these were made by, and now many of them have put these up in their homes for viewing by people. So yesterday we had a watercolor workshop for, again, these are the COVID warriors, surgeons and intensive care people. So art is basically therapeutic. Now these are mandala artworks by a young friend of mine who has gone through depression, and she started doing mandalas as a part of a therapy, and she's sharing her experience here.
My name is Rasika Durge, and I am a mandala artist.
And can you please wind up?
Back in 2018, when.
So I'll just skip her sharing. This is another artist who has who resorted. She's an established artist. One artwork of hers is sold for 60,000, 80,000, and she has also been kind enough to give her video. So she was not an artist before her illness started. She became an artist after her illness. Now, art for socio-economic resilience. We had a shop where we sold artwork done by patients. People with epilepsy, and these are umbrellas painted by my patient of epilepsy here. And this is another artist who has been discovered as a kind of a artist, and he has taken training now. And psychosocial resilience, these are artworks done by, she got trained for this artwork by a patient of Parkinson's disease. So fine motor, we have been discussing motor, non-motor. See, these have been done by a patient of Parkinson's disease. And this creates a social impact for that patient. This is a project we had done for 4 consecutive years with patients and our hospital staff for fort making competition. And the patients also enjoy these activities. And art for advocacy, most important. So just a few minutes left. Art for advocacy, because art can remain on the in its place. Visual art can remain in its place and go on talking for a long time. And therefore we had this artwork. These artists were taught about epilepsy, and they presented their data. Then we had an exhibition, and people who came also saw this artwork. These are some of the prize winners. This artwork is right behind me right now. And so some of the patients who come, they also say that, oh, this is what is actually happening in my mind. This is what is happening in our homes. So absolutely beautiful artwork we had. And we got a lot of publicity, which publicity takes this advocacy message towards people. And we need to advocate to people who don't have epilepsy, not just to people who have epilepsy. So visual art is a powerful tool to convey messages and information. And we got, for one of our events, we got this particular flash graffiti artist to do a live graffiti artwork for us in a public place. And this was a very well appreciated event in Nagpur city when I was based there. And this particular graffiti work, we kept on having it in most of our events after that. So visual art is, so I conclude here by saying that visual art is a powerful tool for psychological, cognitive, spiritual resilience, and also a very impactful tool for effective communication. So whenever we are designing our posters for any event, we do think of artwork and see the impact of that artwork depending upon the posters that we have made. So yes, more and more work needs to be done in this field, and I hope to pursue this in both manners. As an artist also have featured in this International Spiritual Art Festival, and you can visit that page and see my painting there as well. Thank you so much for giving me this opportunity, and thank you for considering this as a topic for discussion in our conference. Thanks a lot.
Thank you, Punima ma'am, for this real presentation. And it was just out of mind experience, and we just enjoyed your presentation. It activated so many areas of our brain, starting from the right to the left. And overall, you touched all aspects, including advocacy, patient care, and whatever opportunities the doctor has to take to make his patient better. So we'll get back to you, but since we are running short of time, we'll go on to the next presentation. I think Dr. Ujjwal is there. He's a co-chair. So I'd like Dr. Ujjwal to have a few words for the next speaker, Devika Mehta. Ujjwal, are you there? Dr. Ujjwal? Okay, so yeah, Ujjwal. So kindly co-chair and have a few words for Dr. Devika.
Thank you, Dr. Soumya. Thank you for, and I thank Dr. Nirmal Surya for giving me this opportunity, because music, art, and dance is something which is close to all of us actually. And so our next speaker would be, sir. Okay. So our next speaker would be Dr. Devika Mehta. She is basically MSc in dance movement psychotherapy from the United Kingdom, and she is MA also in clinical psychology, and she has affiliations with professional license member of Association Dance Movement Psychotherapy in UK, and she would be deliberating in dance movement therapy today. So, handing over the dais to Dr. Devika Mehta.
Thank you so much, sir. I'll just quickly share my screen if that is okay. To just start off with is dance movement therapy and neuro rehabilitation. One of the things that I think I'm grateful for to be the last on the panel is because all the nuances and the basics of it are covered by Shantala ma'am and by Purnima ma'am. What I would like to go into is how the body comes into play, right? Because a lot of neurological work that we do really focuses on movement, focuses on body rehabilitation, focuses on speech. And what dance movement does is it gives you an opportunity to bring in elements of music therapy, which is your rhythmic entrainment, your cueing that can happen, along with elements of visualization, which also come through the visual art aspect of it. So very quickly going into what do DMTs do, right? What are dance therapists? Dance movement therapy is a creative process, primarily a creative process, which also therapeutically intervenes to integrate the physical aspect, the social aspect of doing something in a group or moving with another person, the emotional aspect where a lot of times those who are neurologically impaired do not have the words for their experience. It might be a completely new experience. The emotional understanding and the awareness is also slightly, poorer as compared to the other functions of the body, and cognitive functioning. So the way I work essentially is based in the triangle, is that we rely on the neuroscientific evidence that is emerging from the space of dance, right? And the psychological frameworks that Dr. Shantala Hegde ma'am already spoke about, where it started from psychoanalytic to behavioral to developmental, to now going into understanding that there is neuroscience behind this. It is not just something that we do primarily as a hobby, or it's not something that can be taught, right? Along with the dance movement therapy techniques, which are very specific to the profession. Just like Shantala ma'am said, dance versus dance therapy, right? She spoke about music versus music therapy. And when we are talking about dance versus dance therapy, we are essentially looking at, if you're looking at only dancing, right? Dance as an intervention is structured. It is directive. I am teaching you or I'm allowing you to improvise. The process is different. The techniques are different. The intention of going to a dance class is very different from that which we look at in a dance therapy intervention. So what are some of the techniques that we use in a dance therapy intervention for looking at a psychotherapeutic benefit or a neurological benefit? Is movement improvisation, rhythmic entrainment. We use a lot of symbolic movement. We allow for metaphors and visual imagery to come in, but also remembering that in a country like India, you cannot remove it from the cultural context that we live in, where dancing is a part of the social functioning. Most of us, if they ask, they'll say, I've never gone to a dance class, but मैं wedding में dance कर लेता हूँ, or I dance in the shower, or I'm a bathroom singer. So all of us have these curiosities towards different art forms as maybe hobbies. But when we look at it as an intervention, there has to be a training that has to facilitate that process. There has to be a therapist on the other end, and not just a dance teacher. So what is the DMT research that supports the neurological work? There is a lot of dance-based neuroscientific evidence that exists in this place, where we look at cerebral palsy, we look at autism, any kind of neurodevelopmental disorder. We are looking at stroke, Parkinson's, dementia. We're looking at multiple sclerosis. But all those are looking at elements of dance and how dancing can help neurorehabilitation. We now have research in dance movement therapy, essentially looking at what that looks like. So if we look at Beryl's work since 1990, is in the work of traumatic brain injury, and she's found significant improvements in physical motility, in balance, in social and in cognitive domains as well, in decision making and short-term memory. If you look at Parkinson's disease, it's proved beneficial across multiple studies, but DMT specific to the Natal and Zhang work, that is, it improves in motor and cognitive function. An RCT trial, this is one of the most recent studies that was published by a very dear colleague, Rainbow, and her team, it is an RCT trial. If we remember, Shantala ma'am showed us the triangle where we have had case studies, we've had cohort studies, and now we're looking at the litmus test, which is the RCT trials, right? So they did a RCT trial that was investigating the impact of DMT in comparison with exercise on psychophysiological domains of older adults with mild dementia. And they found there was a decrease in depression, in loneliness, and the negative moods, which we are also, the psychological aspect of having any kind of illness. And it improved daily functioning. And the best part about this is they did a 1-year follow-up after it, and it continued to be, there was improvement and there was sustained change in the individuals that were a part of the study. Looking at the work that I have essentially done, I've worked across the developmental age span from 6-month children to those who are early in the early intervention programs, with cerebral palsy, with autism, with amputation, with dementia, with Parkinson's, with Alzheimer's, with Alzheimer's, with dementia, with Parkinson's, 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 with Alzh with spinal cord difficulty, with in congenital, when they have the, sorry, I can't remember, I'm just blanking out. But it is when they have the bone disorders, where the bones constantly break and the movement is highly restricted. So if you're looking at one of my first works, and this is, I'm like deeply grateful for Dr. Barreto and Dr. Singhal here, because in 2009, they said, okay, why don't we work with movement and with dance as a way of adjunct therapy that we are going to provide. And we looked at community-based intensive therapeutic dance programs. It wasn't dance therapy at that point because I wasn't trained in it. So we were only looking at dance. And we found there to be significant impact in areas of stigma around Parkinson's, cognition, mood, and a sense of belongingness to the community. So in a community-based design that we do, and we are looking at adapting DMT, we have to look at how is the word dance perceived as. So a lot of times I end up just saying I'm a movement therapist because people feel like, oh, I don't do dance. Or we go on the other spectrum where they want to dance, right? So that we have to be very careful of how we do that. We also have to look at the gender differences where men and women who are not married to each other, they might not want to dance with another person of another gender or a sexuality, or they may not want to dance in front of the others. The third thing that we look at is the instructions and the sharing that followed has to be translated so that it can be understood by the entire community. And that bit, the sharing, is really important because you've gone through a whole process. And then, if you just have to keep all of that inside, then it's not as beneficial. And this is why we need a therapist to facilitate that sharing. If you look at my work with neurodevelopmental disorders, stroke, dementia, we've had similar anecdotal evidence as well across hospital and rehabilitation setups. Now, the thing is, in most of the places I work, we work in a multidisciplinary team. So it's very difficult to identify and state very objectively that, okay, this person has improved because of dance therapy, or this person has improved because of music therapy, which is why a very multidisciplinary, holistic kind of approach works much better rather than isolating. And I do understand that that's one of the biggest challenges that we face in trying to create evidence for the viability or for the accountability that we hold to the outcomes that come. But we've definitely, we've had caregivers who come back and said, this is something I've seen him do in dance therapy and he's doing it at home. Or this is something that the patient was talking about, and they were talking about their dance therapy sessions versus the other conventional therapy sessions that they go for. So there's a very clear experiential element to it that differs it from physiotherapy or occupational therapy. Going to the next slide is the neuroscience behind this, right? What is it that makes dance therapy work? So when we are looking at a lot of dance evidence and what we call interoception is the processing of internal sensory stimuli. So a lot of the work that we do is understanding what kind of resources does this person have? Is this person able to breathe well? Is this person able to sense that breath? Is this person able to understand the space around them? So we call it dancing with the sixth and the seventh senses, which is proprioception and interoception. When we look at the work of Stephen Porges' polyvagal theory, we look at Antonio Damasio's work on somatic markers and how they're connecting implicit and explicit memory processing. We understand the role of the nervous system as well in how we experience different events, because so much of it does not even reach the cerebral areas. It gets processed at a very dorsal, ventral, and a ventral vagal space. The dance mechanisms that really help are synchronicity, social interactions, brain predictions, integration of movement and cognition, sensory motor integration, skill development, brain plasticity, and neuroaesthetics. All of this in some forms have been covered in the previous sort of presentations. I won't go deeper into it. But what we do realize is that dance engages multiple areas of the brain: motor regions, prefrontal cortex, corticospinal excitability, and action observation network. Now, what happens is that dance, there's not just one way to move, right? There are multiple ways to move. So if we are looking at neuro rehabilitation, we find different ways that feel more natural, feel more emergent rather than taught to the client that we are working with, whether it's a child or whether it's a person who's gone through traumatic brain injury, and we are creating new synapses and engaging with more neuroplastic work with them. One of the other elements that we really look at it from the therapeutic aspect is the mirror neurons, which are implicated in the development of empathy. So, like all of them have said, why do we use the therapeutic elements of Indian dance forms, right? If we look at, we have so many rituals, festivals that make dance way more accessible in our daily functioning. We look at the kind of spatial formations if we are doing it as a social dance. If you look at the top two, there's a line as well as there is a circle. There's a certain rhythmic familiarity that comes with engaging in forms which are very specific to our own culture. There is easy accessibility. If you can look at it, you can see older generation, younger generation, all of them being connected through dance. There is a sense of belongingness and identity, but also it gives us a space to tell our own stories, to own our narratives of our recovery. And sometimes that helps to sort of, supplement the work that the physiotherapists are doing, the occupational therapists are doing, the speech therapists are doing, because the psychological aspect gets taken care of along with enhancing, or we almost call it like you're prepping them to engage better in other therapeutic forms. Most importantly, since the theme is from hospital to home, I would like to, acknowledge that how COVID has changed therapeutic settings for so many, individuals in either the accessibility because they're immunocompromised, or in terms of major rehabilitation centers also having to improvise and do work online. So if you're looking at how do we go from in-person to a telehealth format in a dance therapy space, which is supposed to be very interpersonal as well, we are looking at creative improvisation. So the therapist as well as the client has to creatively find ways of how to move together, how to engage in movement. Yes, there has been a lot of anxiety in and around COVID, and what dance helps is to regulate that. And when I say dance, I'm being very mindful of the word that I'm using right now, is because of the limitation that we have, there's a limitation in the therapy side of it as well. So yes, there's a sense of community. We've been able to involve more families, which otherwise wouldn't come to the center. So we make sure that, if a child that I'm working with, if a parent is close by, we do dyadic movement. Their communication has improved massively. We're looking at reducing risk, essentially in terms of physical access, right? There are so many clients who weren't able to come to the centers, and because of this virtual setup, we've been able to access them. So we are reducing their risk of catching COVID if they are immunocompromised as well. Because of this, they've found independent expression, right? Where they're not coming to a hospital setup. They've found a space within their homes, which can be their safe space, while also having access to therapy. So yes, as much as I'm a massive proponent of in-person therapy, because the feeling is different, the more we can see, the faster the process of therapeutic rehabilitation happens. But there is transfer of training, because what we can see now across the screens, across the cameras, is that the things that we did together in person, the clients are able to transfer that within their home space. It gives us a more holistic understanding of what is it that they're navigating in their personal lives as well. These are some of the references that I have looked at in this presentation. And I'm just going to quickly, if we have do we have 3 minutes, sir? If that is okay. Then I can share a video as well, because sometimes the visual impact is much larger than just the talking aspect. So I'm just going to share like 2 minutes of the video, if that is okay. Would that be okay, sir?
Yeah, absolutely.
Okay, so just give me a second. This was shared in the IFNR symposium when I was invited to speak in 2015 with Dr. Barreto. We do have permission for this from the Parkinson's Disease and Movement Disorder Society. And I'm just gonna play it.
Journey to open people with Parkinson's to dance and to movement. It was scary for me initially and for the group to not trust their movement capacities and yet have the responsibility of keeping them physically and emotionally safe. What was inspirational was their willingness to come together as a community to move, to create, and to express themselves. During this process, their trust in me has helped us to overcome the feeling of being stuck in movement. And it has certainly changed the way I look at movement and dance. And what started as a tentative exploration has now become a celebration of potential.
So what I would just like to conclude with is, I have seen that DMT can actually change across the lifespan. That's one of the biggest myths, that it's only for old people, it's not for caregivers, it's not for people who don't have any kind of mental health or physical health disorders. There is a very clear distinction between dancing and dance therapy. And I would like to thank Poonam Bajaj for recommending my name, but as well as HN Reliance, Bombay Hospital, SRCC, Children Development Center, and all the schools that have sort of allowed for alternative forms of therapy to come in. So thank you.
So thank you, Devika, for this wonderful talk, and the video was really enlightening. We saw your work. We saw how much passion you have for your work also. And since we are running short of time, we need to end the session. And Ujjwal, if you have any comments or anything to say, kindly share in a few words for all the speakers.
Thank you, Dr. Soumya.
Yeah.
I mean, next time when we meet, definitely we will have some music and dance. That is what I want to say.
And also art also.
Yeah, art, yes, art also. The jokes apart, actually, this session was very, very enlightening, and it has created a new, even When I was there in Delhi, I was working with Dr. L.C. Thakur, eminent neurologist in UCMS and GTB hospital. So there we used to have these kind of things in line. And I remember very well when we talk of this music therapy. I'll just take just 2 minutes, Somya. So basically, when we talk of music therapy, actually it activates the cortical and subcortical pathways both. And the maximum research about this music therapy is in depression. So when we talk of dementia, it is actually cognitive, behavior, emotional, and the social. All the aspects are impaired in these patients, in dementia patients. And the maximum research, as far as neurology is concerned, has been in dementia. The next is Parkinson's, and then is stroke. So maximum research has been in actually dementia, and now the music covers all the aspects, including the cognitive, behavior, social, and emotional aspects. And the max, as I said, the maximum this research has been on dementia. Especially I remember a case, a few cases actually, when Dr. L.C. Thakur had invited some music therapists there, and we used to discuss, because I have some knowledge in music, a very less, but still I have some knowledge in music. So when we used to discuss, then that Rag Desh, there is one rag in Indian classical music, everyone knows, Rag Desh. So when we go from in RO, we have the
Ujjwal, I will keep your lecture next time in the session, but we are already 10 minutes late. Dr. Sudhir Shah is right there.
Last thing I'd like to say. For dementia patients, I have seen, sir, because it's my personal experience, Rag Desh has helped like anything actually. Because when we go to RO, it's like Shuddhani, even in RO it's Komalni. So when we come to the Komalni, so it's like some miracle that happens in these patients. And plus one more point, that music therapy is just like tablet, because what research says is that it cannot be just one time.
My dear friend, you missed out on yesterday's lecture by none other than Michael Todd, who has been father of music therapy in rehabilitation in the world. I will have to interrupt because I cannot allow the international meeting run too late. So I want to thank both Ujjwal and the Suma Nayak, and I would have a 15-minute next time lecture from Ujjwal in the music therapy session, along with Shantala and Michael Todd, so that we can take it forward. I really appreciate. I know time is less, but we need to go on to another very interesting session, which is on traditional therapy in rehabilitation. And may I request Lee Fang and Professor Sudhir Shah to kindly take over this session. And can I request the team to Nishita to kindly take in the panelists? Is one of the speakers. Professor Sudhir Shah, introduction, if I may have. Professor Sudhir Shah is a very close friend of mine. He's HOD at the head at Ahmedabad for the NHL MMC Hospital. He's director of neuroscience at Sterling Hospital. And the most important thing is he has not only been recognized by the neurologists, but he has been recognized by Government of India, and he is the recipient of BC Roy Award and the Padam Shri, which he received in 2016. He's personal physician to our top 2 minister of Government of India. So nothing more to say. He is one of the neurologists who can influence the whole country. May I request Sudhir Bhai to be here, and along with him, Professor Louis Fang. Can I have the slide of Lee Fang also? Lee Fang is not there. Sudhir Bhai, kindly take over.
Right. Thank you, Nirmal, for this wonderful opportunity. I hope I am audible. Am I audible? Yeah.
Yes, you are.
Okay. So this is a very fantastically designed symposium on traditional therapies in rehabilitation, which will take care of chronic healing for neuropathic pain management, yoga and neuro rehab, new strategy for stroke acupuncture with rehab, and Ayurveda and neuro rehab. All these topics are very dear to my heart, and I have worked on at least 2 of them and published some papers, that is yoga and Ayurveda also. Now, may I have the pleasure of introducing the first speaker, Professor B. Tell, chronic healing for neuropathic management.
Yes.
I'm here.
Oh, yes. Thank you. Actual bad, or she is a resident doctor for rehab. She has been educated in Mongolian Russian Joint School in 1999 till 2011 in Middle Educational School, then Mongolian National University since 2011 to 17 as a Bachelor of Medical Doctor, then International Cyber University of Medical, now still studying, and of course, Sustain Third State Central Hospital, now studying as a junior resident doctor for rehabilitation. She has a work experience of, she's working on Shine Erin Medical LLC General Manager 2018 onwards. The company imports medical devices, products, implants, official distributors of anthrax, etc. So with those small little words of introduction, may I invite Dr. Iqtel Bad for her presentation. Welcome, Doctor.
Thank you. I am so grateful for participating in this Congress, and my topic was pranic healing. Now I share my screen. Is it?
Make it a full screen, ma'am.
Full screen?
Yeah. Go to
yeah.
Or do cup.
Okay. Topic was.
Tech team, guide them.
Yes, sir. Ma'am, can you please go to the slideshow mode?
Yes,
yes,
that's
now it is full
perfect.
screen. Yes, perfect.
This is okay. Yeah.
Yes, you
okay.
can.
Yeah. What is pranic healing? Pranic healing is a super powerful healing system that uses energy to treat physical and psychological ailments. As of today, is being practiced in our 120 countries worldwide. It is based on two principles. The first, the first principles is the first principle is the principle of self-recovery, which means that the body is capable of healing itself. Imagine you have cut a wound or a burn. Even if you don't treat it, you notice that in a few days the body has healed itself. For this healing to happen, the body needs some kind of fuel. That fuel is energy or prana. This is capable. Brings us to the second principles. The second principle is a principle of life force, which means that for life to exist, the body needs energy or prana. This also means that if your body has more energy, the rate of healing is highly accelerated. Pranic healing can be used to heal all kinds of ailments, ranging from simple to severe or chronic. Pranic healing is also effectively used to treat psychological disorders. Do you hear me?
Yes, go ahead.
Okay. The founder of pranic healing is Grandmaster Cha Koksui. He is a global pranic healing IAS. Master of Chao Koksui was the founder of modern pranic healing and arhatic yoga. He was born in Cebu, Philippines. After years of experimentation and studying esoteric practices such as Chui Kung, Kabbalah, and yoga, yoga, he came up with an energy healing system that is so simple yet so powerful and effective. Years later, the science of pranic healing spread from Southeast Asia to the rest of the world. There are two techniques in pranic healing. First is cleansing or cleansing is mean that removal or dirty diseases energy from the affected area. The second is energizing, that is replenishing the affected area with clean, fresh prana. You don't use your own energy. In fact, in a pranic healing, they teach you about different sources of prana or energy, like the sun, the air, and the earth. Earth means a ground. In this day and age, our lives have become so busy that few of us have enough time to sleep and eat regularly, let alone meditate and soul search. As a consequence of our hectic lives, our physical, mental, and emotional well-being are taking a toll. If you believe that physical health, inner peace, and tranquility have become luxuries only the privileged can afford, we can assure you they are not. The technique and prana healing can be help you restore the life energy your body needs to function properly and live a happier and healthier. This is just a picture. The origin of pranic healing is the roots of pranic healing can be found in China. Grandmaster Chao Kaksui, China's Filipino spiritual teacher, is known as the father of pranic healing. After years of experimentation and studying esoteric practices such as Qi, Kung, Kabbalah, and yoga, this was the word prana originates from the Sanskrit language and means life or spirit. It refers to a universal life force hidden form of energy that exists in all living things, animals, plants, even air, sunlight, earth, sky, rocks. Prana is the energy that moves the universe and keeps all of its creatures alive and healthy. All living things absorb prana through sunlight, air, and earth. Their health and well-being depend on the amount of prana in them. Sources of prana in the world. The major prana are solar prana, air prana, and ground prana. The solar prana exists in the sunlight, sunbathing, sun gazing, and drinking water, charged or exposed to sunlight are all good ways to absorb it. The second prana is air prana. We can absorb it through the pores of our skin. Slow rhythmic breathing in nature. Prana exists in the ground. It can be absorbed through the minor chakras or yeah. The sites in the ground, it can be absorbed through the minor chakras or pressure points located on the soles of our feet. A simple way to do is walking barefoot on the ground. What is pranic healing? The two pillars of pranic healing are two essential loves. The first love is the love of self-recovery, prana or life energy. As the science healing studies anatomy, Namely, there is an energy field that surrounds every being and call it the energy body, the etheric, the plasmic body, or the aura. This field can be into the around for 2-5 on average. It's on average and acts as some sort of shield. The size depends the person's health. Unfortunately, there are many things in life that can disturb sadness, loneliness, fear, stress, and anxiety. All affect our health and the environment affects the other two. Consequently, we develop long-lasting physical and psychological issues. Pranic therapy heals the etheric means energy body, which serves as a protective layer covering the physical body. Any malady, dark thought, or unhealthy emotion gets in contact with this aura. First, before manifesting physically. Each physical can show up in a major disease has come in contact with the person's aura but hasn't the body. Maintaining our inner balance and keeping our body, our mind in good shape requires implementing healthy habits and taking good care of this energy body. This ancient art of healing helps us identify problems and eliminate them. The therapy is based on the channeling of pranic energy from the source through the healer towards the one who's being healed. Practitioners channelize the life force or prana around us and use it to heal our minds and bodies. The healer acts as a channel or medium while the energy acts as a healing tool. Numerous testimonials and researchers from around the globe prove that it truly works. The energy body has 11 major chakras. They control and energize our vital organs and affect our mental and spiritual well-being. Pranic healing helps cleanse, stabilize, and energize all the major chakras and various minor ones we need. Cleansing helps remove the unhealthy energy from the person's body, eliminates blockages in the energy channel so it can suck up fresh energy coming from the healer. Energizing might do more harm than good unless the cleansing is done properly. Build healthy habits means people who often have an aura that's healthy and vibrant. These activities regulate the flow of the pranic energy, keeping the chakras free from blockages. With a cleansed energy body, you can enjoy an active physical body that's free of diseases and easily cope with everybody's problems. So if you aren't doing it well, get in touch to pay personal trainers, give yoga a chance. What are the benefits of pranic healing? The key benefits of pranic healing include greater happiness, inner peace, higher degrees of intelligence, fewer problems, helping others, higher degrees of sensitivity and awareness, improving your intuition. Is it difficult to become a pranic healer? Anyone with an open mind can become a pranic healer provided that they are willing to learn. Anyone with average ability to concentrate and average intelligence can master the basic techniques and principles of pranic healing in a few sessions. It is like learning how to drive a car, for example. So if you fall in love with these healing techniques, you can take it a step further and become a healer yourself. Morning meditation. Nowadays, being stressed out of a veil of life, people constantly feel pressured about money, family, relationships, jobs, schools, and who knows what else. What's more, most people accept this stress and an unavoidable part of life. Because of this and their current fast pace of life, you see people who are unhappy, judgmental, unkind, and most importantly, use people who do not have peace of mind. Luckily, all of this can change. Peace of mind can be achieved with a simple morning meditation. If you meditate in the morning, right before your day starts, you will be able to achieve calmness and change your perspectives. By the same token, you will start feeling more positively yourself, others, and your day to come. According to a recent study, 18% of the people today start checking their social media as soon as they open their eyes. And in many cases, this action clouds our minds. Also, morning are when we most think they tend to get out of control. Temperamental children, missed call, emergency emails, spilled coffee, and when all these things happen right at the beginning of the day, it is not a surprise why people spend the rest of the day in bad mood. Yes, most of the things are unavoidable.
Dr. Edgar, kindly wind up. Your time is getting up now. Yeah.
Okay. Now, what? What?
You can take 2 minutes, please. Take 2 minutes to wind
There's a obviously understood what you should wear is wear the clothes like that. This is a clothes for yoga and prana healing. Who can and sitting position. And lap. After some practice, the positions shown in the picture will become natural. Stay motivated. When deciding to meditate, the most important things motivated. Some days it is going to be really hard to sit in silence and think about nothing. When those days happen, think about why you started meditating in the first place. That is always a good motivation. Thank you. Various pranic healing meditation techniques. Now have gained extremely popularly among people. However, you can try this out only after you have mastered the basic procedures. Archaic yoga, sexual alchemy, super brain yoga, and meditation on 3 hertz. Om Mani Padme Hum means Om. Provides heart rate. This is a chakra name. There are 11 chakras. This is the end of my Thank you.
Thank you for finishing in time, Victor. I know it's a wonderful presentation, very lengthy subject, but you tried to give the glimpses in a very short time in a very nice way. So we could get the overall idea of what is pranic healing, what are life forces, and how does it help. And you emphasize the importance of meditation so well. Thank you. Dr. Surya, is the...
Thank you.
Yeah. Can we now move to the next speaker? Yeah. So yoga in neurorehabilitation, Nishita Justi. Yes. Nishita Justi, she is a BNYS MSc Yogic Sciences and also PG CSEP in Acupuncture, Scientist B Yoga, Department of Integrative Medicine, National Institute of Mental Health and Neuroscience at NIMHANS. She is a yoga and naturopathy physician. Completed her post-graduation yoga therapy from Suvasya from University of Bengaluru, and she has 2 years of experience in yoga and research. She also holds a postgraduate certification in clinical acupuncture from IGNOU. May I invite Nishita Justi to justify the subject of yoga and neurorehabilitation.
Thank you very much, sir, for the kind introduction. Can I share my slides?
Please.
So very good afternoon to everybody. So today I'll be talking briefly about yoga and its role in neurorehabilitation. So myself, I'm working as Scientist B in the Department of Integrative Medicine at NIMHANS. So in today's presentation, I'll give you a brief overview over these topics. First, introduction towards what is yoga. And then yoga, how will it be useful as a rehabilitative therapy? And then role of yoga in neurorehab, the current evidence that is available, and the ongoing work. So what actually yoga is? Is yoga equal to performing complicated physical postures? Is it something that is only meditation? Or is it something that is only for advanced spiritual people who seek spiritual advancement? So let us understand first what is yoga. Yoga comes from a root word called yuj, which means to join or unite. In a simpler sense, it is bringing a unison in your body, breath, and your mind. From the philosophical understanding, it's basically to unite with the subconsciousness, with the individual consciousness. Now, according to the sage Patanjali, he defines yoga to be yoga chitta vritti nirodha, that is the termination or the alleviation of the agitations of the mind. That state of the mind where there are no agitations and it is completely calm, that state is known as yoga. So how do you achieve that state? Sage Patanjali has devised 8 methods, 8-fold method, which is commonly known as Ashtanga Yoga. So in Ashtanga Yoga, as we see, there are yamas, that is the first limb, then comes niyama, then asana, pranayama, pratyahara, dharana, dhyana, and samadhi. So yama is basically the individual code of conduct that basically enhances the individual mental health and emotional well-being. Niyamas are the social code of conduct, So in yamas, we have ahimsa, satya, asteya, brahmacharya, and aparigraha. They are basically non-violence, speaking truth, practicing celibacy or non-stealing and non-hoarding. In niyamas, we have saucha, that is cleanliness, santosha, that is being content with whatever you possess, and tapas is having the the fire of practice or sadhana. Swadhyaya is the introspection after you practice something, and then Ishvara Pranidhana is basically surrendering yourself for the practice to a higher principle in life. Then comes the asana practice. Asanas is basically using the physical body postures to bring stability in your mind. Pranayama is the method where we use the breath as a tool to bring calmness to your mind. Pratyahara is a procedure where you basically turn all your senses inwards, and it's basically a step that you do before the meditative and concentration procedures. Then comes dharana, where there is a single pointed focus. This is the method with which we start a meditative technique. Then comes the dhyana, which is a procedure or the method that happens on its own after the practice of dharana. And last is the state of samadhi, that is the state of oneness or the self-absorption. So now, how yoga can act as a therapy or a rehabilitative therapy is from the Taittiriya Upanishad. There is a concept called Panchakosha, where we see our existence in 5 domains. The first one is the physical layer, that is your body. And then there is the layer of life force or prana. And then comes the layer of your mental processes. Then comes the layer of insight or intellect. And the last comes the layer of bliss or your inherent being. So in this theory explains on how an illness occurs and how yoga can reverse it. So what happens at the layer of insight is there is a confusion on what is right and what is wrong, that we generally see in terms of lifestyle, that we have wrong lifestyle practices that leads to turbulence in the mind or the mental layer. In the mental layer, when the turbulence is strong, it penetrates down to the pranamaya kosha or the layer of life force, and it manifests on the body. So here, yoga again uses the body and the breath to again bring stability at the mind that can help to bring the insight at the layer of intellect and ultimately bring happiness or joy within a person that promotes healing. So here, a basic example that we can see is when a person is agitated or angry, we see that there is a rush in blood towards his face, there is flushing, and then there is increase in their heart rate, respiratory rate. So this is how this is the same theory that we propose to explain this, saying that the turbulence in the mental layer brings in the manifestation in the physiological processes and then manifestation at the body level. So these are the different methods that we use in the therapy. Here, as you see, that there are props that we use especially for older individuals as well as people with certain compromises after any neurological diseases. And then we use pranayama and mudras and relaxation techniques and meditative techniques and chanting. These 2 components, that is the relaxation techniques and the meditative techniques along with mantra chantings, are the major and they form the major basis of our rehabilitative care. Now, what can yoga provide in for neuro rehab is in terms of physical mobility and to improve the day-to-day functioning and social functioning, to reduce pain, to improve cognition, to improve the mental and the emotional health. These are the basic domains where yoga has found to be useful in the neuro rehab. See, the probable mechanisms could be improving the vagal tone, down regulation of HP axis, lowering the cortisol, and attenuating the oxidative stress, increase in GABA levels, in BDNF levels, and also the cerebral gray matter. The essential components that we use in yoga therapy is we have validated yoga modules that have been validated by the experts working in the field for each disorder. So these modules are generally given to the patients with specific disorder, but the use of the module is always graduated, especially in the rehabilitative care. And special emphasis is put on breath awareness, mindfulness, and the sensory awareness. And the use of guided imageries and visualization techniques is a very important component in the yoga modules, especially where the movement or use of physical body is compromised, and use of props to support the body, especially where there is a problem with balance or there is sensory component involved significantly. And there is also a component where we train caregivers on how to assist the patient during the therapy. And the positive reinforcement and yogic counseling are also a very important part of the therapy, where positive reinforcement meaning every small change or improvement that is seen by the therapist has to be told to the patient, and it should act as a positive reinforcement for the patient to come back to the therapy every day. And yogic counseling is also a method where we have principles that we use from the Patanjali Yoga Sutras and Hatha Yoga Pratipika to specially motivate the patient again to come back to the therapy, because there is a lot of stigma, and then they go through a lot of mental turbulence and stress to accept the new self after the episode of any neurological disorder that has happened. So the general precautions that a therapist takes is to discourage overdoing of any practice and avoiding frequent changes in the modules and frequent change in the body posture, and to avoid strenuous practice in the first 2 weeks. Always to ensure empty bladder and bowel before the practice, and light stomach conditions before the practice of yoga. So now we'll look at the current evidence base that is available. First, these are the few disorders in which there is good evidence of how yoga can help: a stroke, Parkinson's disease, multiple sclerosis, migraine, dementia, traumatic brain injury, and Guillain-Barré syndrome. So in stroke, there have been studies that have shown improvement in balance, where they have shown reduction in the fear of falling, in reduction in pain. There is improvement in the range of motion, especially in the head and the neck, hip, and improvement in the upper extremity strength. And there is improvement in gait, overall quality of life, and the ability or ability of a person to accept the current self. And it also improves calmness. And in terms of the coordination and cognition, they've shown improvement in visual attention, improvement in hand-eye coordination and fine motor control, and also improvement in mood and reduction in anxiety. This is pertaining to stroke. In Parkinson's disease, they began shown improvement in the stability, improvement in bradykinesia. It helps in reducing rigidity, improving power, muscle strength, reduction in tremors, improvement in balance, again reducing the risk of falling, improving the other gait parameters and functional mobility, improvement in other physiological functions such as diastolic blood pressure and forced vital capacity, and reduction in depression, as well as improvement in quality of life. And there are many studies even in the for studying the role of yoga for multiple sclerosis. There are large number of studies which have reported reduction in fatigue, improvement in gait parameters, especially the spatiotemporal gait parameters, improvement in their endurance, improvement in their ambulatory function, body awareness, balance, promotes muscle relaxation, improves the strength and tone, reduction in pain, also improves the bladder function, especially the overactive bladder. We have seen good improvement with the practice of yoga, especially the anal lock and the a practice called Ashwini Mudra. Improves the peak expiratory flow rate and the lung capacities, especially in the domain of mental health. Improves confidence, low mood, improves quality of life, as well as social functioning. It also has shown to reduce anxiety in patients with multiple sclerosis. In the domain of cognition, these studies have shown improvement in audiovisual reaction time, selective attention, short-term and verbal working memory in the patients with multiple sclerosis. In the patients with migraine, studies have shown reduced frequency, intensity, and the duration of the migraine episode, reduction in the need for medications, reduction in anxiety and depression, improvement in vagal tone, and improvement in overall quality of life. In patients with epilepsy, again, the episode frequency has reduced, and improvement in quality of life, improvement in autonomic functions, especially the heart rate variability, improvement in visual contrast sensitivity, reduction in stress, and also the reduction in the requirement or the dosage of medication required. In the patients with dementia, not specifically with Alzheimer's, with other variations of dementia, there have been improvements in the immediate and delayed verbal memory, improvement in verbal fluency, in immediate and delayed visual memory, and improved body awareness. In the cases of traumatic brain injury, improvements in respiratory functions, physical and psychological well-being has improved, improvement in cardiopulmonary fitness, improvement in flexibility, muscular strength, endurance, and balance have been reported. And apart from that, there have been significant improvements in the quality of life and mental health. This is one study that has been, this is one RCT that has been done, pilot RCT, in 2013 in patients with Guillain-Barré syndrome, where they have reported reduction in pain, anxiety, depression, and improvement in quality of sleep. So these are the evidences that are available currently for the use of yoga in rehabilitative care. Now, at NIMHANS, we have carried out some work where we have developed and validated few modules for Parkinson's disease, epilepsy, multiple sclerosis, migraine, low back pain, stroke, and traumatic brain injury, where now we are initiating pilot trials in these areas. And the ongoing work is in developing the modules for Hirayama disease and Alzheimer's dementia. So these are a few references. Thank you.
So thank you, ma'am. You had a wonderful disposition of the various aspects of yoga, but what I would have liked to know from you before we move on to the next session quickly from you is how do you train your subjects for yam and niyam? Do they follow that in your modules? Number one. And second, What are the putative mechanisms through which yogic things have influence on the physiological and neurological functions? Is it the subcellular level, genetic level, neurotransmitter level, synapse level, pathway level? Where do you find the changes?
So the first thing is about yama and niyama. We basically in the yoga modules, we as such do not include yama and niyama. Apart from, we generally use them in the counseling module, where we basically educate the patients on yamas and niyamas. And one aspect that we see is each counseling session, we ask them for a diary of if if they're following what we have asked them to, like especially in terms of.
Right, that's true. What are the mechanisms through which this works?
So the mechanisms, especially the putative mechanisms that we try to we have proposed is from the current evidence is probably it's because of the improvement in the vagal tone, and then downregulation of HP axis that reduces cortisol levels, and especially reduction in the oxidative stress, improvement in GABA levels, and BDNF, which acts as a neuroprotective mechanism, and also the cerebral gray matter. The in-depth genetic studies are still to be evaluated for the use of yoga in neurorehab.
I thought some PET studies or SPECT or fMRI and some genetic studies would be useful. Anyway, thank you, ma'am, for your wonderful talk and answers. Now we move on to the third talk, and that is by Luwen Zhou on a new strategy for stroke, acupuncture combined with neuro rehabilitation.
This will be shared by Peter from my place.
Is my co-chairperson around now or still not there?
Good morning, everyone. My name is Zhu Luwen. I come from China, the fourth affiliate hospital of Heilongjiang University of Chinese Medicine. Thanks for inviting me to this conference. Thank you, Chairman, for my introduction. This is my topic, a new strategy for stroke. Acupuncture combined with rehabilitation. This is my CV. Zhu Luwen, Professor, Vice President of the 4th Affiliate Hospital of Heilongjiang University of Chinese Medicine. Deputy Secretary General of Heilongjiang University. Rehabilitation Medical Association.
Thank you
Now,
very much for
I am going to start my topic from these 5 things. 1, introduction. 2, subject.
This is recorded talk.
3, results. 4, conclusions. 5, discussion. Introduction. Nowadays, stroke this is stroke patients. Stroke diagnosis and treatment has made great progress. The mortality of stroke was significantly reduced, but the rate of disability is still high. The stroke patient has motor and scarring. Therefore, to reduce the rate of disability and improve the quality of life of stroke patients, the comprehensive progress of stroke prevention and rehabilitation will be established, which has become hard research at home and abroad. It has been stated that acupuncture and rehabilitation may ameliorate neurological impairments after stroke. In our experiments, we will observe the effects with scalp acupuncture combined with rehabilitation therapy was used to treat stroke. This is my Professor Tang use scalp acupuncture to treat stroke patients. We will establish a standardized comprehensive treatment plan. Subjects and methods. 1. Subjects. There are 300 stroke patients coming from the Department of Rehabilitation, the general aging, and condition of the patients in each group were comparable by scientific analysis. 2. Experiment groups. All patients were randomly divided into A, B, C, D 4 groups. There are 75 patients in each group. A. Rehabilitation group. B. Acupuncture combined with head group. 3. Scalp acupuncture group. D. Control group. 3. Intervention methods. Acupuncture group. According to the 7 reasons, scalp acupuncture created by Professor Yu Zhishun. We use this acupuncture stroke. Yu Zhishun 7 reasons scalp acupuncture. In this experiment, we chose the top reason and the top front reason to acupuncture. We chose the top reason and the top front reason to acupuncture. This is 百会, acupuncture. This is 前顶 acupuncture. This is 信会 acupuncture. Our needles were rated on 7 or 9 hours. 30 days after acupuncture, 200 per minute. We chose rehabilitation therapy and carry on the lumbar function training in account with Babas. This is Babas. We all use this therapy to treat stroke. Babas have 5 key points. Control key points. Reflex inhibition. Positive response transfer. Equilibrium reaction. Stimulation of science. In clinical, we also use Babas to treatment to use for stroke patients. In this paper, this is my my doctor used Babas to treat stroke patients. In this, we use scalp acupuncture to treat. Acupuncture and function treating will carry out at the same time. In the paper, scalp acupuncture, we use Babas. The technique of Babas, scalp acupuncture combined with the rehabilitation. 4. Evaluation method. According to the evaluation standards of the 4th Cerebrovascular Disease Conference, near call, remarkable improvement, not improvement, and deterioration. Fundamental score, 100, normal movement. The neural function defect score, light, light, medium, heavy. The ideal score according to the Basel exposition integral. 5. Statistical analysis. Assess static software or applied TOT test applied in measured data. Count data analyzed by confound test, running test applied in reading state. Result 1. The comparison of samplable female motor score of the score patient in each group. This is acupuncture combined with rehabilitation. This is skull acupuncture group. This is rehabilitation group. This is control. From the paper, we found acupuncture combined with rehabilitation is better than this in acupuncture group and rehabilitation group and control group. Compared with pre-treatment, there were significant differences with simplified female motor scores after treatment in each group. Compared with the control group, there were significant differences across acupuncture with rehabilitation group, the scalp acupuncture group, and the rehabilitation group after treatment. In this experience, we found acupuncture and rehabilitation also can increase the ADR, the female motor score. However, acupuncture with rehabilitation group was better than the scalp acupuncture and rehabilitation. 2. The comparison of neurological deficiency scores of stroke patients in each group. This is acupuncture combined with rehabilitation. This is pre-treatment. This is post-treatment. From this paper, we found after the stroke patients after acupuncture combined with rehabilitation, the neurological deficit score reduced more and more. Compared with pre-treatment, there were significant differences with neurological deficit score after treatment in each group. Combined with the control group, there were significant differences among acupuncture with health group, scalp acupuncture group, and the rehabilitation group after treatment. Acupuncture with rehabilitation group were better than the scalp acupuncture group and rehabilitation. 3. The comparison of activities of daily living of scalp patient ADL in each group. This is post-treatment. This is pre-treatment, post-treatment. From the picture, we will find the acupuncture combined with group, rehabilitation group can increase the ADR. It's very high. Compared with pre-treatment, there were significant differences with activities of daily living after treatment in each group. Compared with the control group, there were significant differences among acupuncture with healthy group, scalp acupuncture group, and the hand group after treatment. Acupuncture with rehabilitation group was better than the scalp acupuncture group and the rehabilitation group. 4. The comparison of total curative effect of stroke patients in each group. There were significant differences between control group and other group by the analysis of reading. Acupuncture with rehabilitation group was better than the scalp acupuncture group and rehabilitation group. Conclusion: the acupuncture combined with rehabilitation is positive and effective. This is effective treatment method of stroke. The acupuncture combined with rehabilitation can remarkably increase the female motor skill, improve the function of the body kidneys, and ADL. The acupuncture company can remarkably remove the neural function of the patients. The choice of acupuncture. Acupuncture is a transnasal treatment is widely used in clinical neural rehabilitation. The class needing of scar points is found by acupuncture expert Professor Yu Zhishun. After a lot of clinical experience and scientific research, the head acupuncture district 7 rule law was present. In this paper, we chose the reason and reason from the Yu Zhishun 7 reason. The factor of class needing of scar points. The class needing of scar points can be operated and a candidate area which is safe and effective. So we found the class needing of scar points is safe and effective and used in clinical neural rehabilitation. This method may reduce the number of daily acupuncture, the pain which acupuncture brings to patients. It's easy for class scalp acupuncture to combine with rehabilitation therapy. The choice of rehabilitation. The treatment of stroke has formed a relative compensator in modern rehabilitation method. It has been stated that rehabilitation can advocate the function reconstruction. The bypass is the major rehabilitation method in this research. Bypass is a major rehabilitation method. In clinical, we use the bypass to treat stroke, motor. The clinical value of the acupuncture combined with rehabilitation. This is stroke patient. This is stroke patient. The scalp acupuncture and we use bypass carry out at the same time. The acupuncture combined with rehabilitation located easily rehabilitation and the size of the best time of treatment, which encourage, developed, and innovate the class needing of scar point, revelates the advantage of dynamic stroke treatment. The acupuncture combined with rehabilitation can prevent and reduce complication of stroke, which can not only improve the clinical effectiveness of stroke, but also treat the cerebral palsy, the brain injury, and other diseases. This cerebral palsy, this brain injury, and other diseases. In my hospital, every stroke patients, we used the acupuncture combined rehabilitation to treatment, and these patients will improve the ADL more and more. Thank you very much.
Thank you. Thank you, Professor Lorenzo, for your concise talk and a wonderful discussion on acupuncture and combined neurorehabilitation. I think it was very useful, and at this juncture, I really felt very necessary to acknowledge and thank and congratulate AOCNR for holding such a massive conference, taking in view various aspects of neurorehab And I wish one day the whole neuro rehab comes under the one umbrella where a stroke neurologist takes help of Ayurveda, yoga, acupuncture, art, music, dance therapy, and treats the patient as a whole, as a holistic therapy. I think that day will be a very golden day for the medicine. Anyway, with that, I would like to invite Dr. Kishore Kumar R, the professor of Ayurveda, who will speak on Ayurveda and neuro rehab, an untapped paradigm. Kishore Kumar is MD and PhD in neurophysiology, Bangalore, NIMHANS, and he has several national, international publications. He's member of so many societies, including member of International Brain Research Organization, member of International Neurophysiology Association, and whatnot. He had a lot of awards to his credit: Young Scientist Award for Clinical Research and Second Prince Gold Award, and so many. So rather than discussing about his awards and merits, which will take a long time, let us hear from him, a very great expert in the field, that is Kishore Kumar, on Ayurveda and neuro rehab, an untapped paradigm. I think it's going to be a very interesting session. Dr. Kishore, please.
Thank you so much, Dr. Sudhir. Can I share my screen? Okay.
I've been told, Dr. Kishore, that we have only 17 minutes left, so I hope you will be able to finish on time. Thank you.
Yes, I can. Okay, are my slides visible?
Yes, please.
Yes.
Okay, thank you. Thank you for those kind words. Thank you, the organizers, for organizing such a wonderful conference. More than anything else, it is like it's very nice to see various systems of medicine being brought together in one platform. Very rarely such endeavors are undertaken. So thank you very much, and I congratulate you for this great initiative. Okay, I'll quickly go through the. What I'll be doing is just to present an overview of what Ayurveda and neuro rehabilitation has been doing since quite some time now. Now I think most of the scientific community are aware of Panchamahabhutas and Vata, Pitta, and Kapha, which form the foundational aspects which describe the physiology as well as pathophysiology of various disorders. So here, this is the combination of Vata, Pitta, and Kapha. These are not a specific quantifiable, in the sense materially quantifiable elements. They are metaphysical as well as conceptually quantifiable parameters. And Vata, Pitta, and Kapha represent three doshas which are known to which regulate the mechanisms of physiology as well as pathophysiology, and that is how it has been understood. Just to give you a brief overview, in the sense that Ayurveda generally has been considered to be a sort of hearsay or something, but WHO has classified it as whole medical system, wherein we have descriptions of anatomy, physiology, as well as descriptions of particular disease and the treatment in a very systematic way. Most of them are in Sanskrit. So this is, I wouldn't go into details of each and every terminologies. Like for example, one or two, Vayuhu Tantra Yantra Dharaha is the description of Vayu. Now all the neurological disorders fall under Vata Vyadhi in Sanskrit. So Vata is the dosha that controls the motor, sensory, many of the functions, basically originating from brain and the spinal cord. So Tantra Yantra Dharaha is the, it holds, Vata holds or shelters the functions of the body, which are specifically neurological, neurological, sensory, motor, and so on. Then pravartakas cheshtanam uchavachanam. So initiation of all movements. The niyanta praneta cha manasa. Manas is also regulated by vata. Sarva indriyanam udyojakaha. All the indriya, sensory and motor, both. Initiation of all activities of sense organs. Sarva indriya arthanam abhivodha, which means helping the perception and comprehension of all the indriya arthas, which means sensory objects. So things like that has been described. Now, the explanation of Shiras, that is the brain, and its role in causation of neurological disorders have been very explicitly mentioned. Shiras has been considered as the most important of 108 marmas, which are vital points in the human body. Among them, there are three: Shiras, Hridaya, and Basti. Shiras is the head or brain and spinal cord, central nervous system. Hridaya is the heart, and Basti is the urinary system. And the Shiras also has been described as to shelter all the indriyas, sensory and motor faculties, all the neurological functions which have been described. And Shira Marma Abhighata is the terminology that is mentioned to represent head injury or anything that happens, not head injury as we know, but head injury that can happen due to trauma or head injury that can happen due to internal causes. Any neurological, focal neurological deficits in the brain leading to various symptomatology in the body. So, Shiro Marma Bhighata is the terminology that is used. As per the Ayurvedic descriptions, the pathophysiology is Vata, Vata Vyadhi, and Vata gets impaired due to two, in two ways. One is due to degeneration, so that is, degenerative disorders, and another is due to obstruction in the movement of Vata. To understand this, it would be like a cerebrovascular accident, like thrombosis or anything like that. So when you have an obstruction to the function or the channel of circulation, then you have the diseases of, so cerebrovascular accidents are a perfect example. So impedance. And the site can be central where Shiras is primarily involved, or peripheral where the nervous system is involved, peripheral. The approaches, neurological approaches, Ayurveda approaches to neurological disorders are in two broadly and can be understood in two approaches. One is the internal measures, where purificatory procedures known as Shodhana, and then external measures, the Panchakarma procedures, wherein the use of oil and many other medicinal, liquid preparations used in the treatment, and then internal medicines that are given. The purificatory procedures are many. Virechana is one procedure where purgation is induced using certain medications, and then Basti is the rectal administration of medicinal, medicinal decoctions, and Nasya is nasal instillation of medicines. Now, these are some of the pictures where Abhyanga, the oil massage, Sweda, the sudation is the steam, Shashtika Shali Pinda Sweda is use of rice medicated with herbal decoctions, which is used on the body. Patra Pinda Sweda is, use of certain medicinal herbs which are processed and then used as a poultice on the body. Churna Pinda Sweda. So Pinda Sweda is, a poultice based fermentation or a poultice based heat therapy. Udvartana is powder massage. So these are just some of the examples. These are therapeutic modalities, and the herbs or medicines used in these modalities change based on the prakriti of the individual, based on the presentation of the individual, disease, and so on. Some of the treatment procedures that we use in cerebrovascular accidents: oil massage, fermentation, rice poultice massage. In motor neuron disease, we use oil invariably, sedation, rice poultice massage, and enema. Entrapment neuropathies, also we use Patrapinda Sweda. In Bell's palsy, Nasya is used, oil massage and local sedation is used. In diseases like muscular dystrophy, enema is another addition that is used. So this is just to give an overview of how things, the modalities are also adopted in treating certain disorders. There have been some literature currently, although I wouldn't boast of many publications in this domain, but still we have been able to look at some in ischemic stroke, the effect of virechana karma, that is induced purgation. Then induced purgation also modulates dyslipidemia. It improves metabolism, reduces dyslipidemia. Neuropeptides influence the activity of gut microbiota and its interaction with the gut-brain axis, and then cleanses this is virechana karma. It cleanses the gastrointestinal mucosa and may improve functional status of biologically active neuropeptides, acting as neural and endocrine messengers in orchestrating microbiota, gut-brain axis in health and disease. Now, currently, I've been listening to some of the questions wherein the therapies are sort of comprehensive. You do a therapy and try to take the serum or try to notice a kind of change in the particular target area. It's very difficult to notice. It is probably initiating a cascade of metabolic changes in the body affecting the target organ, let's say the brain, and then bringing about the changes which have not been studied very comprehensively. But still, the effect of these therapies on various disorders have been certainly studied. Now, Basti Karma is medicated enema. Now, the talk around in neurology or medicine is about gut-brain axis. So we have seen that the Basti or Virechana is induced purgation, and Basti is rectal administration of medicines. Basti, just like orally, some medications are given. Similarly, those herbs which need to bypass the digestive mechanism are given through the rectal route. And these, have been shown to alter the microbiome, obviously, but then the effects are long lasting. And then the effect on the disease or the improving the symptomatology has also been very good. So it has been shown to act over the receptors, to alter the gut microbiome and enhance vagal activity. One of these study was also conducted in NIMHANS. These are some of the publications where therapeutic massage and its effects on the various aspects of neurology has been seen. Like, it acts as a physical therapy, improves muscle strength, improves voluntary motor control, is represented in several brain regions, including amygdala, hypothalamus, improves cardiovascular autonomic regulation, also known to promote growth and development, enhance muscle power, improve performance in balance parameters. So much of these studies have been, a couple of studies have been conducted at NIMHANS also, when we have seen this happening. So the Svedana or fomentation, which we generally use in the Panchakarma procedures, they have, studies have shown that it causes vasodilation, flexibility, improving muscle activity, increases muscle mass temperature, antispastic effect. Passive stretching with prior local head treatment increases muscle extensibility, reduces spasticity, improving cardiac function, enhances parasympathetic activity, enhances antioxidant functions, then nourishing effects on the muscles. So there have been quite a number of studies on the Panchakarma therapies these days appearing. So in DB syndrome, we have seen remarkable improvement in muscle strength. In spinocerebellar ataxia, there was very good improvement in dysarthria, fasciculation, axial tremor, and then scale for assessment of ataxia with Ayurveda treatment. In ischemic stroke, we have seen that it effectively modulated cardiac autonomic dysfunction. This was conducted at NIMHANS. And progressive degenerative cerebral ataxia, we have seen that it has showed considerable improvement in balance on dynamic posturography. So I was able to collect some of these studies. I should admit that there have not been much extensive studies on these aspects, but then in the Department of NIMHANS, in the Department of Integrative Medicine in NIMHANS, we have now started the paradigm of integrative health approach, where an Ayurveda specialist, a yoga specialist, a yoga expert, and a modern psychiatrist and a neurologist, we look at the patient simultaneously and optimize the treatment. And when we optimize the treatment, we the consultants, at the level of the consultants, we decide as to what treatment would be best and what to combine with what. Let's say the patient with depression might go with yoga and some Ayurvedic therapy in the mild in mild presentations, and in neurology where there is extensive motor deficits, then we admit them, put him on panchakarma therapies, start yoga, and also supplement it with physiotherapy. So we have seen that when these are integrated together, the improvement is much better. We have our inpatient department. We are treating most of the neurological disorders, and we have seen considerable improvement with patients coming to us. Although the department started in 2019, the inpatient has started just 4 or 5 months ago, and we have seen a very extensive response to patients who are attending especially neurorehabilitation at NIMHANS. So, and we also in the domain of research, we would like to, we have already initiated RCTs, standalone as well as add-on therapies along with yoga, and trials to evaluate probable mechanisms of these therapies and standardize these therapeutic procedures. The blueprint is ready. We have just started. We have been applying for projects, research funding, and we have also got some funding for certain projects. So we hope to take this forward in a robust way, so that this gets integrated into neurorehabilitation in the mainstream medicine. So yeah, that's where I end my therapy. If you would like to see 1 or 2 therapies, which how it looks like, I can display 1 or 2 videos.
Be brief.
Is it
sure? We have about 1 or 1.5 minutes at the most.
Okay, then fine. Then if there are any questions, I can take them.
You can quickly show 1 video or 1 minute. That's it.
Yeah, sure. 1 minute. Sure.
In the meanwhile, if somebody has questions to any of the panelists, keep them ready, and either you send it in the...
Is the video visible?
No, sir. No.
1 second. I think I should stop sharing this screen and then...
No.
I think I can get now. 1 second. Can you see the video now?
Yes.
This is Nadi Sweda. This was a patient of Bell's palsy. And then he has been given oil massage, and after that there is Nadi Sweda, where the steam is delivered through a tube with a certain force. So it's like this. So that is me who's doing it. This was taken quite long back, around 20 years ago. So this is how in Bell's palsy the treatment is done.
What is the scope of this treatment in current era? Because in modern medicine, we have a very good treatment option for the Bell's palsy. So where exactly in Bell's palsy you will fit this in?
Yes, sir. Modern medicine, there are quite good treatments, but we get a lot of patients who do not respond modern medicines. Yes, so that is when we actually do it. Just one more maybe. This is the
while you play that, I would make a comment that Ayurveda has a great role in prevention of neurological disorders also. So the role of Ayurveda in preventive aspect has been totally under-recognized and under-tapped, particularly diet, lifestyle.
yes. This is where we use the medicated rice. Rice is processed using lot of herbs and then applied over the body. Yeah.
For what disease?
This is a patient of hemiplegia.
Okay, great. I wish there are lots of peer-reviewed papers. Are there any peer-reviewed papers for Panchakarma or?
Yes, sir. I think I have been able to present some things here for Abhyanga, Virechana, and Basti. We have had some publications there. Basti is now currently the understanding of Basti with gut-brain axis is picking up quite fast. The theories connecting the processes are now on, and Basti is known to modulate a lot in microbiome, gut microbiota, where we use various decoctions to be administered into the colon. Then Virechana Karma has known to produce a lot of other effects, but then to look at exact mechanisms that are leading to change in the symptomatology and pathways. These are studies which we now have to take up. Not many publications in that area.
Wonderful. I'm very happy that you are all moving in a correct direction.
Yes, sir. And preventive aspects, yes, as you might have mentioned, preventive aspects, the diet, is one of the very important aspects where we actually give them dietary advices in the OPD and also in the IPD. Now we also supply Ayurveda-based food to the patients who are in our inpatients. So they get that. So that is a very important part of our advice. Thank you.
And I don't find any questions in QA box or anybody who has raised hand. So I would like to conclude with Dr. Surya's permission. Dr. Nirmal, I must thank you profusely. You have been the father of neuro rehab in India. You have been working so hard, my friend. I am really very, very happy and proud that this wonderful thing you have brought to us in this Asian Oceanian Conference, and all the delegates, speakers, as well as the mentors and the organizers. I must thank them profusely. My concluding remark is that, as I mentioned, I am looking for that brighter day when all these different therapies will come under one roof. And rather than antagonizing each other, they all make a cohesive effort, because after all, patient and its system are one. And we have to help the person heal. And like lifestyle and diet of Ayurveda, medical and diagnostic and validation aspects of modern medicine, acupuncture, acupressure, and other allied therapies, pranic healing, Reiki, and other healing systems. So different levels of healing, right from the cell to system, from gut to heart, and from chemical to genes. Everywhere we can intervene to come out to help patient come out of a disease. And I am fond of Ayurveda and yoga, and I've been international advisor that I would like to end my talk with a quote. Naro hitahar vihara sevi data samah satya parak shamavan samikshakari cha vishayesu asakta aptopasevi cha bhavati aroga. Ayurveda mentions, Maharshi Charak has mentioned that the one who is having perfect control in his diet and lifestyle, hita har vihar se vidata, the one who donates and does lot of charity, the one who is truthful, satyapara, the one who is kshamavan, the one who forgives and forgets, the one who is samikshakari, who looks after everything as a whole, and who is not very much attached, Vishayasu asakta, the one who does not have hatred, and the one who is in connection with the experts of different field like this type of conference. Aptopasevi, the one who are enlightened people, the one who remains in touch with them, that person becomes free of disease physically, mentally, emotionally, and spiritually. So with that remark, once again congratulating all the organizers, particularly Dr. Surya and all the speakers and panelists. Thank you very much for giving me this opportunity. Thank you very much. I'm really enlightened by this panel. Thank you.
Thank you,
Thank you very
Sudhir
much.
bhai. And it is indeed was a great to have. And you would have noticed as you came a little bit early that you were into the art, music, and dance therapy, which is followed by the traditional therapy. So we are trying to, bring all the people who are involved with the rehabilitation for the human neurological problem all together. The time has come when we need to work in collaboration. And I think I'll come back to you, Dr. Kishore, as we run a very big epilepsy clinic and we work with National Health Mission, Government of Maharashtra. We would certainly collaborate with you to add on the Ayurveda therapy with our patients with epilepsy across the Maharashtra and in
Only one
We'll
request.
be more than happy, sir. We'll be more than happy.
One request before I leave, that if you are planning to have a compendium or the write-ups of different topics, I would be very happy to go through that. Thank you.
Absolutely. I will certainly send it to you. Thank you. So, Dr. Kishore, we are already doing the yoga in epilepsy, so I'll come back to you. And
Sure.
I'm always keen to start a collaborative study to help the people, and we will come back to you. Thank you.
Yes, sir.
With
Thank you
that-
so much.
Thank you. With that note, we break for the lunch and we come back at 2 o'clock. There will be a symposium on pain management at 2 o'clock. So we look forward to see you all at 2 o'clock. Thank you very much.
Hello.
Hello. Hi.
Good afternoon. I'm Dr. Vishnu. This is Hall 4.
Yes, this is Hall 4.
The next one is a symposium on pain management, right?
Yes.
Okay. I'm a chair. I will be a chair for this session and speaker. So I don't know who are going to be the joy for the chair.
I'm going to join. You are the chair?
Hello. Yeah.
Hi, Dr. Vishnu. I'm Dr.
Nice
Navita.
to meet you.
Very nice to see you here. Very nice to see you too.
Yeah.
Okay,
Are you Dr.
Navita.
Nalita? Okay.
Navita. Yeah.
Nalita.
Navita.
Navita.
Yes.
Okay. All right.
Oh, nice to meet you. Nice to see you.
Yeah. I don't know if you have CD of you have CD?
Hi, Sonal. Yeah, I think so. They have it.
Okay.
Yeah.
All 4, you have that? Oh, so
so
you don't need me to be a chair, right? You have 2?
Yeah, we have. Sonal, we have 2 chairs, right?
Yes. Yes.
Okay.
Yes, Dr. Datta.
We have 2 chairs. Yeah. Hello.
Oh, I don't need to do anything. Okay. Because at the beginning
sir,
I was.
Can you please flash the session details slide?
Pardon? My slide?
No. Fine. Just flash this slide. Yeah. We will start in 2 minutes, sir.
Oh, okay. Right.
So there are 2 chairs, Dr. Datta Nadgiri, right? And me, myself.
Yes.
Okay.
And I think so. Dr. Palande and Dr. Sonal. Dr. Palande and Sonal, you are moderating, right? Hi, sir.
Yes,
No, Sonal will be coordinating.
Sonal will be coordinating. Okay.
Yeah, I will be just supervising the whole thing.
Okay. Okay, sir.
In case something is there.
And then we can introduce the speakers.
The speakers will be introduced by the chairs.
By the chairs.
Whereas the chair will be introduced by Sonal.
Okay.
Yeah.
So yeah, that's good because I have some kind of a miscommunication a bit because I have been confirmed to be a chair of this session, but no problem. I'll manage just only myself. All right.
Oh, is it?
I'm a second speaker. Yeah. That's okay.
Vitsanu, Dr. Vitsanu?
Yes. I'm Vishnu.
We can have your concluding remarks and a moderation, sir. Would you be? It will be a pleasure to have you as a moderator.
Please say again.
So yes, sir. We have 2 chairs, Dr. Datta and Dr. Navita. So it will be good if you can have you as a moderator.
Oh, okay. Yeah, I'll try. Okay,
yes.
Thank you.
So it's 2 p.m. post-lunch session. Welcome to Symposium on Pain Management. I welcome all of you to Asian Oceanian Day 3 Symposium on Pain Management. We have 2 esteemed chairs. May I have the slides, please? Dr. Navita.
So for this session, please manage to take a picture after the session. Okay. For all together.
Sure.
Okay.
Yes, we will do
Thank
that.
you.
Dr. Navita's slide, please. Yeah. Good afternoon, ma'am. We welcome you as a chair of this session. Dr. Navita Vyas is a PMR specialist in pain sonology, and she is working at Kokilaben Ambani. She is specialist in pain medicine palliative care. First woman in India certified interventional pain sonologist. She had received advanced training in pain management at Harvard Medical School. She's trained in cancer pain and palliative care at Tata Memorial Hospital. And she has many credits to her, many awards and international credits to her great career. So may I request next chair's slide, please, Dr. Datta. Welcome, Dr. Datta Nagir. Dr. Nadgir is consultant neurologist, brain and nerve clinic at Blimker Complex Club Road, Hubli. He is MBBS from Pune University, MD from Pune University, and DM Neurology from Mumbai University. He's worked as associate professor, neurology in Karnataka Institute of Medical Sciences, presently working as chief consultant neurologist at Brain and Nerve Clinic. He's got great publications to his credit in cavernous sinus syndrome, biphasic demyelination, and Parkinson's in North Karnataka. Welcome, sir. I request Dr. Vitsanu to moderate this session, and I request Dr. Datta and Dr. Navita to chair this session. Could I have Dr. Vitsanu's slide as a moderator to be flashed?
Just a little bit.
Dr. Vitsanu, on
Yes.
Oceanian Congress, we welcome you, sir. Thank you so much for being with us. So cheers, on to you.
Yes.
Thank you, ma'am.
Okay. Thank you so much for your introduction. So I have my slide to share a bit for the
Dr. Navita, would you like to introduce Dr. Vitsanu?
Yeah, hi. Thank you, Sonal, for the kind introduction. And very good afternoon, very good morning, very good evening to all the global people present in this symposium. And I have the privilege to introduce Dr. Vitsanu, who is Head of Department of Rehabilitation Medicine in Bangkok, Thailand, in Mahidol University. And he is the President-elect Thai Rehabilitation Medicine Association and the Royal College of Thailand, Chairman of Thai Society of Neurorehabilitation, and he's also Regional Vice President for WFNR. I welcome him as a moderator. And without further ado, can we start the session so that we don't waste any time and we are in time. So there will be 4 sessions, I think, so 4 talks in this session. And this is a symposium on pain management. The first talk would be on neuropathic pain and nociceptive pain. So I request Dr. Datta to introduce the first speaker, Dr. Rinaldo. Can we have his slide, please? Can we have the slide of the first speaker, CV? Dr. Rinaldo Matias. Okay, these are the 4 talks which we are going to have in this symposium on pain management. Okay. So I request my co-chair, Dr. Datta, to
good afternoon, everyone. Good afternoon, everyone. It is a pleasure to chair this important session on pain management. First of all, I would like to thank the organizers of AOCNR and Dr. Nirmal Surya for giving this opportunity to chair this important session. And we have 4 important topics. And the first topic of neuropathic and nociplastic pain will be delivered by Professor Rinaldo Rey Matias. And he is a prominent present is the president of Asia Oceanian Society of Physical and Rehabilitation Medicine, chairman of ISPO Philippines, and he has many laurels to his credits. He is Doctor of Medicine from University Faculty of Medicine and Surgery. He's a chairman of Professional Regulation Commission Board of Physical and Occupational Therapy from 2007 to 2013. He is currently the chairman and associate professor of St. Luke's College of Medicine. He's a diplomat of Philippine Board of Rehabilitation Medicine and Philippine Board of Pain Medicine. He's a fellow of Philippine College of Geriatric Medicine, master degree in Human Movement Science from University of Philippines. He's also a member of US Association of Academic Physiatrists, Impact on Education and Excellence Award. And he has many awards, outstanding Pearl Jubilee in University of Santo Thomas Alumni Association of America in 2018. Most outstanding alumni, University of Santo Thomas College of Neuro Rehabilitation in 2014. He's been recognized as top 100 doctors and St. Luke's Medical Center in 2012, and number 1 doctor in rehabilitation medicine in St. Luke's Medical Center in Global City. So I would like to welcome Professor Rinaldo Rey Matias to deliver his first talk on neuropathic and nociplastic pain. Welcome, sir. Sir, I think you have to unmute yourself.
Please share computer audio.
Yes. There's no audio. The tech team.
I think he has to unmute himself.
Unmute.
Among others, and describe the evolution of nociplastic pain and the difference from that of neuropathic pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. The Joint Commission on the Accreditation of Health Organization also recognizes pain as the three vital signs, which means that pain should be regarded as a vital sign and should be monitored along with other vital signs like that of temperature, respiratory rate, pulse rate, and blood pressure. There are many emerging definitions in terms of pain. The 1994 IASP definition of pain has a lot of ambiguities and led IASP to propose a new definition last 2019, which states that pain is an aversive sensory and emotional experience typically caused by or resembling actual or potential tissue injury. There is a change of the unpleasant to aversive, and instead of actual, the word resembling was added. It is important also because some pain do not rise from actual damage, but also those that resembles the actual damage. This definition is still being finalized, and another proposed definition, which is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components, is very important because it captures the psychosocial component that's important in the rehabilitation of patients with chronic pain. You can see here that pain has several stages, both ascending and descending. Transduction, which is the translation of noxious stimulus into electrical activity at the peripheral nociceptors. Transmission, which is the propagation of nerve impulses to the nervous system. And modulation, which is the modification of nociceptive transmission by inhibition of the spinal dorsal cells by endorphins. And perception, which is the final conscious, subjective, and emotional experience of pain. Pain is also a multimodal experience. There's peripheral sensitization when there's decrease in threshold leading to increase in nerve excitability, mostly found at the site of the tissue damage. Exaggerated response leads to hyperalgesia and spreads beyond the site of injury, leading to secondary hyperalgesia and central sensitization. Peripheral maintains the central sensitization, which is defined as increased responsiveness of the nociceptive neurons in the central nervous system to their normal or subthreshold afferent input. Inflammatory mediators like that of bradykinin, serotonin, prostaglandin, cytokines, and histamines are released from the damaged tissue and can stimulate nociceptors directly. This process is called primary or peripheral sensitization. Continuous activation of muscle nociceptors leads also to co-release of your L-glutamate and substance P at the presynaptic terminals of the dorsal horn. In addition to activation of the alpha-amino-3-hydroxy 5-methyl-4-oxopropionic acid or your AMPA receptors or AMPA receptors by the glutamate at the postsynaptic terminal, substance P facilitates activation of previously dormant NMDA receptors. This leads to maximal opening of the calcium permeable ion channels, which hyperexcites nociceptive neurons and causes apoptosis of inhibitory interneurons. So from nociceptive terminals, due to increased vascular permeability, inflammatory mediators are released, and foremost of which will be that substance P, which can all lead to lowered firing threshold and ectopic activity. Along with substance P, there is what you call your PAR2 or your proteinase activated receptor 2, which enhances expression of your pro-inflammatory cytokines, bradykinin, TNFs, and interleukin. So substance P and the PAR2 can be said to be potent biomarkers of neurogenic inflammation and sensitization. So this shows us that pain can exhibit profound neuroplastic changes, altering neuronal excitability and architecture in structures of the pain matrix, which can be viewed as that of sensitized pain. So in several studies, such as this study in visceral cross-sensitization, in a rat model, they induce colitis, and after 24 to 72 hours, there's inflammation in the bladder by neurogenic inflammation triggered by central sensitization with increased inflammatory response and mast cell infiltration. There's also some neurogenic inflammation with the primary pathology orthodromically sensitizes the dorsal horn, where there's apparent depolarization which releases antidromically neuropeptides in the somatic and visceral tissues or any tissue linked segmentally to the primary pathology. So we can see that the primary pathology resides in the region of the primary hyperalgesia as the cause, or the neurogenic inflammatory response resides in the region of the secondary hyperalgesia, which is more of the effect. There are also studies in which an experimentally induced spine osteoarthritis produces neurogenic inflammation within neurosegmentically linked skeletal muscles. So here in this study, there is the production of substance P and PAR2 in the neurosegmentally linked skeletal muscle, which is that of the quadriceps muscle. So neuropathic pain is defined as a pain initiated or caused by a primary lesion, dysfunction, or transitory perturbation of the peripheral or central nervous system. But the new definition emphasizes that it's a cause by a lesion or disease of the somatosensory system. 5 to 20% of the general population may suffer from that of neuropathic pain. More frequent in women, 8 versus 5.7, greater in 50 years of age, more on the lower back, followed by the neck and upper limbs, and the lumbar and cervical painful radiculopathies are the most frequent causes. We can also show here the burden of illness, which is increased healthcare costs with neuropathic pain, as well as reduced function and productivity. As you can see here that it can produce impairments, activity limitations, and participation restrictions. For the causes and the distribution of neuropathic pain, which can be divided into your central neuropathic pain, like that of cerebrovascular diseases, neurodegenerative diseases like Parkinson's, spinal cord lesion, and demyelinating diseases, and peripheral neuropathic pain, like the lumbar and cervical painful radiculopathies, diabetes mellitus, prediabetes, and other metabolic dysfunction, infectious diseases like HIV and leprosy, chemotherapy, immune and inflammatory disorders, inherited neuropathies, and channelopathies. We can see here that from etiology, the pathophysiology, from the specific etiology, which can lead to individual pathophysiology, just like sensory nerve damage, ectopic activity, sensitization, both peripheral and central, and altered brain connectivity. You can see here that there's a production of the wide dynamic range neurons. There can be some apoptic transmission and sprouting of new terminals or fibers. Symptoms of neuropathic pain can be positive due to excessive neural activity or negative due to deficit of function. So among the positive symptoms like pain and allodynia or hyperalgesia, dysesthesia, or paresthesia, negative symptoms like that of hyposthesia, anesthesia, hypoalgesia, or analgesia. Sensory abnormalities
Twin City of the South in the Visayas region. Diagnosis will go through our usual history, physical exam, and confirmation tests, including the following to confirm the diagnosis of neuropathic pain. We have the quantitative sensory test, or laser evoked potential, the blink reflex, nerve conduction velocity, somatosensory evoked potentials, skin biopsy, and corneal confocal microscopy. The original taxonomy of pain, which is nociceptive, when there's a normal functioning somatosensory nervous system, or pain experience when the somatosensory nervous system will produce abnormal function or neuropathic, is quite problematic. This strict binary classification of pain leaves a sizable proportion of patients unclassified, specifically patients who present clinically with substantial overlap of the nociceptive and neuropathic symptoms, and patients who do not exhibit signs or symptoms of any actual or threatened tissue damage nor evidence of a lesion or disease of the somatosensory system. This diagram by Freinhagen et al., the current understanding of mixed pain, shows to us that there's the mixed pain concept, which can be a combination of nociceptive, neuropathic, and nociplastic pain. So nociplastic pain is pain that arises from altered nociception despite no clear evidence of actual or threatened tissue damage, causing the activation of peripheral nociceptors or evidence for disease or lesion of the somatosensory system causing the pain. It can be divided into your allopathic, which is used to describe a pathological perception or sensation of pain not generated by injury, and nocipathic, which is to denote a pathological state of nociception. So these are all supported by findings of demonstrated changes in cerebral activation, connectivity, and even in specific cerebral structures in certain clinical pain states where there's no consistent evidence of a lesion or disease of the somatosensory system as the primary cause of pain. As compared with healthy controls, complex regional pain syndrome patients would exhibit increased gray matter volume in the dorsal putamen and hypothalamus. Conversely, the patients had less gray matter volume than controls in the cingulate, primarily in the posterior mid-cingulate cortex, but also in the bilateral anterior cingulate, orbital frontal cortex, and the left posterior insula. All patients group would show decreased connectivity in the medial prefrontal cortex, anterior cingulate cortex, and your anterior insula and inferior frontal gyrus, as well as chronic back pain and complex regional pain syndrome patients display increased connectivity in the precuneus compared to healthy controls, and osteoarthritis patients and in the right lateral parietal region compared to healthy controls. So again, this shows us the emerging definitions. And the last one of that proposed definition, which is a distressing experience associated with actual or potential tissue damage with sensory, emotional, cognitive, and social components, captures the biopsychosocial aspect of pain, which is very important in the rehabilitation of patients with chronic pain. So we should not forget that in the rehabilitation of patients with chronic pain, the International Classification of Functioning and Health, which includes body function and structure impairment, activities and participation limitation and restrictions, as well as personal and environmental factors, should always be considered and playing a role. So for summary, the definitions of neuropathic, nociplastic, mixed, and
Thank you. Thank you so much, Dr. Matthias, for an elaborative description of a neuropathic and nociplastic pain. And now I invite our second speaker, Dr. Vitsanu, who is the head of Department of Rehab Medicine and Faculty of Medicine in Mahidol University, Bangkok, Thailand. He is also a President-elect Thai Rehabilitation Medicine Association and Royal College of Medicine of Thailand. He's chairman of Thai Society of Neurorehabilitation and also regional vice president of World Federation for Neurorehabilitation. I welcome Dr. Vitsanu, and he will be enlightening us with his talk on central post-stroke pain, which is very important and very challenging. Dr. Vitsanu, please.
Okay, thank you very much for your kind introduction. Yes, today can I share the
yes.
my screen?
Yes, please.
Could you please stop another share? Okay. Oh no, here. Yes. Here we go. Right. Can you see my PowerPoint?
Yes, we can.
Okay, thank you. Today I'm talking about the central post-stroke pain is quite rare condition, but sometimes it's mixed up with pain after stroke. This is I have no conflict of interest about my talk and nothing to declare. This is a scope of my presentation. I'm talking about the overview of central post-stroke pain, diagnosis and management. And as you may know, is pain after stroke is common, but it's kind of nociceptive pain. Some have like a neuropathic pain, and sometimes it's mixed. The common one is musculoskeletal pain. For example, is shoulder problem. It's very common. If it's about 40%, like adhesive capsulitis and pain from other cause. For example, spastic related pain also is common with the shoulder pain. And what else is in musculoskeletal pain is lower limb like OANE, because stroke is usually take place in happen in the elderly, so it's common to have a knee osteoarthritis and headache also. And for other difficult pain, in particular for the upper limb, is a complex regional pain syndrome or shoulder hand syndrome that we are familiar since past. And today we are talking about the central post-stroke pain. It's kind of a neuropathic pain that divided as a central. It's usually chronic and also combined with other chronic pain after stroke that you need to think about, and sometimes it's quite hard to treat, and it's mixed together between nociceptive and neuropathic. By definition of a central post-stroke pain is a central pain syndrome occur in a direct consequence of a stroke. Most commonly is ischemic stroke, but it could happen in a hemorrhagic stroke, like including intracerebral hemorrhage or subarachnoid hemorrhage. Naturally, is a chronic neuropathic pain with a central origin, and the pain is very severe, and sometimes it's under-recognized because it can mix up with other pain, and it can develop severe complication after stroke. For this condition, is quite hard to treat, and usually it's not responded well by medication, particularly for routine painkiller. It's not work for this because it's not a nociceptive pain, it's a neuropathic. If you see the definition by ASP in ICD-11, they divide chronic neuropathic pain as a peripheral neuropathic pain and central, and CPSP is chronic central neuropathic pain. The prevalence is by the classic and originally cited is a study of Anderson. You estimate CPSP about 8% of stroke patient or more, but the range of study is from 1% to 12%. In USA, there are about 700,000 new stroke patients, and they expect at least 56,000 cases of CPSP. In Thailand, I try to calculate. Our prevalence of stroke is 1.88%, and there are about 70 million population. So probably the number of stroke patients with CPSP is about 100,000 patients. Originally, central post-stroke pain is sometimes we call it thalamic pain syndrome, that first described by the Jolene Lucy, is that is manifest as one of the most spectacular, distressing, and intractable pain syndrome. But a picture of thalamic syndrome is the pain. The clinical show that is that patient should have a mild weakness on the hemiplegic side with a hemianesthesia, hyperesthesia, or persistent abnormal sensation. And some patients have a hemiataxia and definitely have a severe persistent constant or paroxysmal pain on the hemiplegic side. And the classically, patient will have a choreoorthoid movement on the weak side as well. That a classic thalamic pain syndrome, and some use CPSP as a thalamic syndrome, but in fact it's not like that, because in other brain lesion involved in spinal thalamic tract, it could develop central post-stroke pain. Clinically, CPSP can begin days or weeks after the onset of stroke. Some studies say that about 60% affected within the first month, and another 18% is within 6 months, and about the same proportion is after 6 months. And the characteristic of pain is and sensory abnormality is disabling, chronic. The pain could be moderate pain, mild to moderate pain. It could be constant or recurrent pain, sharp pain, stabbing pain, burning pain, and some say it's kind of freezing. And pain usually is in the area of a sensory deficit. Some patients have a spontaneous pain or evoked pain. For example, when we try to move or touch or just test with a temperature, with a cold or warm things, patient complain of pain. That clinical pain should be hyperalgesia, dysesthesia, or allodynia. CPSP can develop either in ischemic or hemorrhagic stroke, but this is a classic. We have like a thalamic infarct on the left side, and the right side is a hemorrhage in the thalamic lesion. The pathophysiology of CPSP is very complicated and unclear. And some say that believe that there are some network reorganization disorder in the brain with a maladaptive central pain. Some talking about central disinhibition, because in the thalamus, there is some part of thalamus that can inhibit pain, and when there is some brain lesion, there cannot control the pain. Or some says mention about imbalance of the stimuli and central sensitization. But of course, inner pain, like central pain, particular for chronic, there are some interaction between biological, psychological, and social factor. And nowadays, like other chronic pain condition, we believe that genetic could be predisposing factor to develop central post-stroke pain, because when we have a look at a stroke patient with a lesion involving thalamus or other side of a spinothalamic tract, why some develop pain, but the other is no. Some say some genetic could be the precipitating factor. The location in terms of anatomy of a lesion of stroke that can produce CPSP could be, can you see the slide on the right side? The number one, the sensory cortex or thalamocortical projection, or thalamus, midbrain, pons, or medulla along the lesion with the spinothalamic tract. It can carry the sensory fiber and develop pain in such lesion. And by study of by published in Anderson, they said that thalamic lesion, it could develop in thalamic lesion, extrathalamic, supratentorial or infratentorial region along the pain pathway. Timing of development, I just mentioned the breath is common within a few months. About 50% is developed within 2.5 years. And 3/4 of CPSP is gradually increased pain. It's not just a sudden onset. So if you see the patient complain of acute onset of pain, you have to try to find the other cause rather than blame it as a central post-stroke pain. For distribution and location of pain, of course, it should develop on the hemiplegic side with a sensory abnormality, but it could be a hemibody from include upper limb, lower limb, trunk, or even face. But if the patient complains just only upper limb pain, you have to think about, because upper limb pain after stroke is very common as a inflammatory pain or nociceptive pain like shoulder pain. Is common for adhesive capsulitis, or spastic pain also can develop in upper or lower limb. But some central post-stroke pain could be multifocal. Just for example, some area of arm, some area of trunk, some area of leg or face. The impact of central post-stroke pain could make a patient suffer from pain with anxiety, depression, and disturbed sleep, and interfere of activity of daily living, and finally reduce well-being and quality of life. The diagnosis of central post-stroke pain. The first one that I just mentioned, you need to try to find the cause. What is the cause of pain? Because if you generally by concept of neuropathic pain, the first step we need to find the cause first. If we can treat the cause, for example, like radiculopathy, radiculitis associated with cervical disc syndrome or lumbar disc, if you can find the cause and treat it, sometimes pain is gone. But also this is the same. If a stroke patient complains this, you need to rule out the possible cause of pain. If you can find that and treat it, it should be go away. And for the sign and symptom of central post-stroke pain, it's not so clear-cut, but it's quite similar to what I said in the beginning. But supporting sign should patient should have a sensory deficit. For example, impaired light touch, impaired two-point discrimination, impaired proprioception of vibration, or even pain sensation. That is quite strange. Patient is a complaint of numbness, but he also complain of pain. I see a few patients come to see me with a central post-stroke pain. I remember is exactly one lady is about 60 something. Her husband bring her to me, and he was curious so bad that why her wife complain a lot of pain. Even he feel nothing on the hemiplegic side, and sometimes she cry out all the time, at the daytime and at nighttime. And she brought her to see a many clinic, and patients still complain of pain, even taking a medication. And you know, they visit allow to see the like complementary alternative medicine. And just one interesting that they bring to the camp, and the Chinese medicine doctor, they put like a baton to hit her arm and leg, and she feels better. And her husband is not believe that. And he said he thinks his wife is a psychic or malingering. But after he see me, and I try to explain, okay, I know it's because of a bad brain impulse is produce a pain by itself. It's not a malingering, it's real. And after advice, and I treat them with medication, with other rehab intervention, both of them is happy. But anyway, pain is still there, but it's just somehow relief. For CPSP, no lab confirm to diagnose CPSP, but just only imaging that may be helpful if there is a localization of the lesion. Management of CPSP. The goal of management is to reduce symptoms. It's quite impossible to get rid of the symptom because it's kind of a scar in the brain. But anyway, we can treat and relieve it. And also, we have to try to improve or preserve the function and prevent further complication like a contracture or functional decline. Because if the patient suffer from pain and do nothing, not cooperate in the rehab program, some is have like a deconditioning. And by treatment, we should improve quality of life and minimize interference with participation. The management of central post-stroke pain is this could be pharmacological and non-pharmacological. For medication, the drug that can relieve pain is antidepressant. For example, tricyclic antidepressant, amitriptyline, usually a drug of choice. SNRI, like duloxetine, venlafaxine, is could be used, but the evidence is not support yet, not so strong yet. Anticonvulsant, for example, gabapentin, pregabalin, carbamazepine, or carbazepine, or even lamotrigine, topiramate, phenytoin. This is a list of anticonvulsant that you should try. If a patient still have a severe pain, opioid or weak opioid can be used. It can relieve pain sometime. And some use a topical agent like lidocaine patch, capsaicin, but by evidence it's not good for the central post-stroke pain, but just for the peripheral neuropathic pain is probably yes. So by medication is in fact is kind of a trial and error. Even there is some support evidence, but it's not so strong about antidepressant and anticonvulsant. And medication alone is, but sometimes it's not work. We need to combine with non-pharmacological, including rehab, in a physical therapy program. We have a distractive way, like biofeedback, like what else? TENS, massage, acupuncture, and psychotherapy should be helpful for like cognitive behavioral therapy. But we have to therapy to the patient and the family member as well, including psycho support. And recently, there are like a interventional therapy. For example, motor cortex stimulation. Some claim that it's work, but it's invasive. And by evidence, outcome is quite variable. Some try less invasive cortex stimulation, like transcranial magnetic stimulation, but it's some patients work, others no. And for deep brain stimulation as well, the evidence is not so strong and not support. There are some evidence, systematic review among the neuropathic pain with various intervention, but we cannot recommend such thing. For example, like 10 TMS is also weak recommendation. Also, the TDCS as well. For physiotherapy program, deep brain stimulation or rehab technique is inconclusive. Exercise is beneficial in terms of to reduce immobility, reduce deconditioning, and improve participation. And psycho support and CBT is effective in terms of mood and like a psychological improvement. So this I would summarize that central post-stroke pain is a chronic pain condition, and it's recalcitrant to treatment. No any single treatment intervention effective for it. We need a combined therapy of pharmacological and non-pharmacological treatment, and we need a further study to find a new intervention to treat it. Thank you very much. That's it for my presentation. Thank you.
Thank you, Professor Vitsanu, for an excellent review on central post-stroke pain and its management. We now go on to the third talk, new trends in the neurorehabilitation relevance to nociplastic pain by Professor Martha. Can I have a slide, please? It's a pleasure to introduce Professor Martha, who is Associate Professor of University of Sao Paulo School of Medicine, Department of Legal Medicine, Medical Ethics, Social and Work Medicine, Discipline of Disability and Impairment. She has received a medical degree from Sao Paulo School of Medicine from Brazil in 1987. She has specialized in physical and rehabilitation medicine after completing 3-year residency program at University of Sao Paulo School of Medicine. And she also had a master's degree and doctorate degree at the same university in 1994 and 98 respectively. Her research predominantly focused on the functional assessment and rehabilitation management of chronic disabling pain, She's a member of Pan American Health Organization Collaborating Center for Rehabilitation. And she's currently the associate editor of Acta Physiatrica Journal. Professor Imamura has authorized and co-authored more than 50 peer-reviewed publications, and she has served as a president of the Brazilian Association of Physical Medicine and Rehabilitation. So I now welcome Professor Martha for her talk on nociplastic pain and new trends. Welcome, madam.
Thank you so much for the kind introduction. On behalf of the University of Sao Paulo School of Medicine, I would like to deeply thank my dear friend, Professor Nirmal Surya, for the honor of the possibility to speak in this very important symposium on pain management. So by focusing on the new trends on neurorehabilitation, I would like to, as Professor Ray Matias already emphasized, the relevance of nociplastic pain, which is somehow nearly defined, trying to contextualize chronic pain in global health, provide an overview of the physiology and pathophysiology of nociplastic pain, trying to more in the clinical arena associate those physiopathological mechanisms into physical findings, then hopefully to try to introduce the rationale for updated interventions to control nociplastic pain. So by 2011, we all were aware by this important publication for the World Health Organization that about 1 in 7 people worldwide would suffer from disabilities. That prevalence at that time on the rise. And more recently, actually at the beginning of this year, people benefiting from rehabilitation is much, much more than those figures. So about 2.4 billion people, this is an underestimated figure. So, which means 1 out of 3 would benefit from rehabilitation. And as strikingly as it could see or mean, there was an increase by 63% since 1990 on this very important indicator at the global burden of disease, which is the years lived with disability. And what the main health condition related to those in need for rehabilitation is defined by chronic conditions, non-specific painful conditions. So as very well highlighted already by my dear friend, Professor Ray Matias, we have this state of the plasticity, even in a very simple nociceptor, which is, by the way, a free nerve ending. But due to a prolonged or non-treated or persistent bombardment of nociceptive stimuli in this nociceptive free nerve ending, we will have a change in the plasticity of these structures, which by the follows the afferent neurons to the dorsal horn of the spinal cord with increased response to nociceptive neurons to its normal thresholds, or also with the recruitment of responses to sub-threshold stimuli, causing a spontaneous neurodischarge with an increase in the receptive field that could even go from the periphery to the dorsal horn of the spinal cord and ultimately reaching areas of the brain, which has also increased receptive field. So this nociplastic pain, which has been introduced by the ICD-11 and the World Health Organization, is a third category of pain, which is characterized by an altered nociception with no clear evidence for an actual or a threatened tissue damage that could be causing the activation of peripheral nociceptors, and also in the absence of disease, potential for disease or lesion in the somatosensory system, which we know as neuropathic pain. The main mechanisms, as already stressed, is this possibility of a central sensitization, where when we compare a normal nociceptive processing, there is somehow an harmony between the input, the nociceptive input that reaches the system by the presynaptic nerve ending. But then when it goes through the postsynaptic area, there is the same kind of amount of stimuli. When we are talking about an abnormal nociceptive processing that is occurring in the nociplastic environment, what happens is, for example, from a physiological activation of the somatosensory system, you will have at the pre- and postsynaptic membranes a facilitated state, an increased excitability of these structures, even at the dorsal horn of the spinal cord. From the neurobiological mechanisms in this altered nociceptive scenario, we will have an increased strength in the synapses, both from the presynaptic membrane, but also at the postsynaptic membrane, with increased responses and also with increased membrane excitability. So to be concrete, for example, let's say your patient with any neuropathic or neurological condition has some pain arising for a structure. It's very important to know the structure that is causing the pain, or has in the beginning caused the pain, because then we can know where in the central nervous system or where in the dorsal horn of the spinal cord those nociceptive stimuli will enter the dorsal horn of the spinal cord. So for example, if the pain is coming from the knee, we know by anatomy, neuroanatomy, that this will reach the dorsal horn of the spinal cord at L3, lumbar 3, L4, and S2, sacrum 2, from the posterior part, and then from there to the brain. And also remember, there is this close connection between the somatosensory system with the sympathetic chain. So every time we see a patient with pain, it's important to think if at that moment, for that specific patient, the central nervous system, for example, in the dorsal ganglia or even the dorsal horn of the spinal cord, is already plastically changed. So, for example, in the beginning, these changes are somehow only functional, with increased number or amount of neurotransmitters, excitatory, painful neurotransmitters, but to an end, it can be a plastically structure, anatomically changed by a state of increased or appearance of abnormal neurons with a decreased threshold for activation that is then causing that state of augmented pain responses. And this is very important. So a way to assess, for example, there are some meta-analyses demonstrating that a way to assess central sensitization is by measuring pain thresholds over several structures. So for example, in this patient with knee-originated pain, we will see, and we have demonstrated already, that other structures rather than the original sort of pain, for example, the knee cartilage, is now also bombarding the dorsal horn of the spinal cord with nociceptive stimuli. These could come from the skin, from the subcutaneous tissue, and it is very important because when you have, in a sense, this attachment of the skin into the deeper tissues, and all the subcutaneous area loses that gliding process that allows the biomechanical part of the body to function properly. And this we can again measure using a pain pressure threshold. So interestingly, when you just examine your patient, could be a patient post a stroke, could be a patient with a spinal cord injury, you will see that by this maneuver where we pinch and roll the subcutaneous tissue, you see that at the area, for example, innervated by that specific spinal nerve, you see an area of hyperemia, you will see an area of extreme pain, hyperalgesia, and allodynia, and also signs of increased sympathetic activity by this redness, by this trophoedema that is localized on the sensitized area of that specific spinal nerve, and that we cannot find or identify in an area very close by, but not in that specific segment. When we see this picture with or by an active search for somatosensory and autonomic abnormalities, then we can for sure say that this patient at this time has a spinal nerve sensitization, which follows a mathematic distribution. So, for example, and this could be even considered a flow of the response from the body into a nociceptive stimuli that in the beginning, yes, could be at the periphery and very localized, but through time and by not providing that body structure proper management, then it grows into the spinal nerve, but also could go even into central nervous system, providing body hyperalgesia, but also but again, it originated by one single structure. So for some reasons, image or a simple image not translate or could not give a proper explanation of what is happening to that person in that time. Of course, this why time to different people, their metabolic state, their hormonal, genetics predisposition. So very important to assess and search for these findings, because sometimes even people can tell exactly by their, when they talk to you and the anamnesis show these changes. And when we do, for example, a biomarker profile, for example, with serum for a peripheral pro-inflammatory pain, we could demonstrate that for some chronic pain conditions, this serum cytokine profile was abnormally high for pro-inflammatory cytokines compared to healthy volunteers. But at the same time, we could demonstrate lower pressure thresholds significantly diminished in comparison to healthy control. This could also be a way to profile better patients. Be highlighted, and it's very relevant to pain management, especially in the rehabilitation field, because, for example, one known to be a localized unilateral pain, for example, coming from a joint, could have a profile in terms of cytokines in the blood, which is more similar to a generalized pain status than as a one single joint situation. That is it's so relevant for us to be examining and individualized our assessment and therefore our care. For example, we know for people with knee osteoarthritis that could also be present in people with post-stroke or post-stroke, see that the majority of interventions or single interventions recommended in international guidelines provide small to maximum moderate effect sizes, especially for functioning. That is our ultimate goal. And by hand or beforehand, we could know that these lower pressure thresholds or pain thresholds is an independent predictor for poor alleviation, for example, interventions that could be targeting more the nociceptive stimuli. And this is important because then you will be guiding your treatments and guiding your interventions to a more rational way. So this is important because now maybe it's opening our mindsets to better understand these situations where treatment was very ineffective in the past. For example, this interesting nationwide survey where they assessed over 800 people with multiple sclerosis and chronic pain, and using different methodologies for assessment, could say about 27% of the people had evidence for the combination of neuropathic and nociplastic pain, and 41% being really nociceptive pain, and about 23% only plastic pain. Not definition, phenotyping, treatment, not patient. I would like to complex pain, also a challenging condition to manage. From the neurorehabilitation perspective, this unexplained disproportional pain, which persists beyond the normal expected time for tissue healing. There is this cross stimuli with some
Can you unmute yourself, Professor Imamura? Professor Imamura, we can't hear you. Can you unmute yourself?
I'm sorry.
Yeah.
So I'll go back one. So basically, when I was saying for this specific health condition where classically we know as regional, not dermatomal, but some patients beyond that regional complex pain syndrome may also show or demonstrate signs of a segmental or a spinal sensitization. Therefore, it is complex because you really need to assess each individual patient at an individual time. Not only forgetting the important role of the central nervous system with the brain in its somatosensory processing, the effective emotional processing that could also interfere in these painful conditions. So if we could say, as a take-home message, we should be looking to personalized and mechanistically approaches to have a better way to inform our treatment strategies. So for example, if we have a constant bombardment of the dorsal horn of the spinal cord, which is intense, which is amplified, together with an inhibition of the inhibitory systems, then we have a scenario and a multitude or myriad of interventions, either by increasing the inhibition of the brain, but also decreasing the nociceptive input, not only in the periphery, in the nociceptive context, but also at the dorsal horn of the spinal cord. There are several interventions that could be dealt with, but unless we assess and understand where that specific patient raises in this spectrum, then we may probably be aware of all the interventions that Professor from Japan will mention to us in quite a bit. So with this, I would like to really thank again for the opportunity to be sharing this information, and hopefully we in the discussion could promote several recommendations for being able to treat those neurological conditions. Thank you so much for your very kind attention.
Thank you, Dr. Mata, for an elaborate presentation. And I'm sure this will open the horizon for the pain management and the pathophysiology of the pain. So now I invite a last speaker of the session, Professor Shu Morioka, to give his talk on pain treatment with neurorehabilitational approach. Can I have his slide, please?
Okay. Can I see my slide?
We can see you. So
you can see the whole slide.
We can.
Yeah, can you hear my voice clearly? Okay, so thank you for introduction, Chairman. I'm very proud to participate in host Asia Oceania Congress on neurorehabilitation. Okay, so I'd like to thank the chairperson, Dr. Surya, as well as the concerned member. So now I'd like to talk about neurorehabilitation of pain. I'm a professor, Dr. Morioka of Kyoto University in Nara Prefecture. So, okay, this time my talk will be given in contents of this slide. First, I'll talk about the brain dysfunction in chronic pain. And next, I'll explain the relationship between pain and reorganization of the body map in the brain, which is a main pathological mechanism targeted by neurorehabilitation. Moreover, the relationship between body perception and the pain will be discussed. Also, I'll briefly introduce the tactile discrimination task related to motor imagery task and the motor illusion task, including virtual reality, also as well as the neuromodulation techniques that have been developed with good evidence for neurorehabilitation. Typical mechanism of brain dysfunction in chronic pain have been reported in various studies. Here, dysfunction of the prefrontal cortex, PFC, has been also being identified. When this area is dysfunctional, the descending pain control inhibitory system is less effective. Moreover, afferent sensory signal cannot be inhibited. As a result, the subject intensity of pain increases. On the other hand, when the frequency of use of the affected body decreases, the body map in the brain decreases correspondingly. Recently, it has been shown to occur in body use frequency dependent manner, even without brain damage. The organization of these negative body maps has been suggested to cause a perceptual distortion of the body and likewise modify the degree and the quality of pain. I think it can be said that the neurorehabilitation is a means of addressing the pathological mechanism. So this figure shows the mechanism by which pain occurs as a result of injury or a trauma. The frequency of use of the affected limb decreases, leading to non-use running and the body map reorganization in the brain. When this occurs, movement is inhibited to protect the body from pain. If movement inhibition continues, fear of causing movement arises, thereby leading to fear avoidance, model fear avoidance behaviors. Also, immobilization may be host after treatment or surgery, which may limit movement or host immobility. According to previous studies, even after 5 days of immobilization, the activity of motor-related areas, such as primary motor cortex, premotor cortex, and the parietal lobe decreases correspondingly, thereby resulting in fine motor and coordination deficits and decrease or loss of motor imagery and intention to use. In addition, in the healthy side, healthy limbs, compensatory movement appears. The patient learns that the result can be achieved without using the affected side. Thus, this compensatory behavior becomes established and the affected limb is used less. As a result, the body map of the affected limbs in the brain reduce in the size. The left figure is similar to the previous one, but the parietal lobe dysfunction eventually appears. It's similar to agnosia. This causes neglect-like symptoms appear. It's similar to agnosia after stroke. For example, decreased parietal lobe activity in response to somatosensory stimulation was reported in a patient with CRPS. It had also been shown that more the parietal lobe function is reduced, the greater the extent of allodynia. As a result, the degree of pain is related to degree of alternation in body perception and imagery. And it has been found that not only body image is distorted, but also motor imagery is reduced. The left figure is an image of brain activity during motor execution and motor imagery. It can be seen that both of them activate almost the same area of motor-related region. That is, they are equivalent. On the other hand, in CRPS patients, these regions are activated during motor execution, but are deactivated during motor imagery, indicating that is a no equivalent activity. In other words, the prediction system does not work properly. And the right figure, this is our study. The amputee is asked to draw a straight line on the tablet while moving its back and host with the healthy limb. At the same time, we ask the patient to make an imagery to draw a circle with the amputated limb. It has been shown that when circle is drawn with the right hand, the straight line of the left hand becomes oval when the right hand is not amputated. Thus, even motor imagery demands have been shown to be oval to some degree. If we can quantitatively examine this ovalization of the straight line, then we can examine the motor imagery ability of patient without measuring brain activity. You can see the correlation figure. As a result, there is a relationship between pain intensity and the ovalization index. In other words, those with high motor imagery ability have less pain. This slide shows the indication of neurorehabilitation, which based on CRPS by Dr. Maccabi, but can also be applied to chronic pain in general recently. The evidence thus far shows that the symptoms are indicated in dark gray. This includes unexperienced pain involving dysfunction of the parietal lobe and the disorder of body perception, as well as the perception of abnormality and the dysfunction of motor-related areas, including the parietal lobe. These result in decreased pain threshold and allodynia due to sensory attenuation loss, movement disorder, and dystonia due to disturbance in motor control. There is a clear evidence for the treatment and the intervention methods shown in pearl gray. Other than pharmacological medication, there are known as neurorehabilitation techniques. Because of the limited time, I'll select some of them. Okay, so on first, the tactile discrimination task. For example, in the figure, this figure, so the affected area is numbered from 1 to 5. The tactile stimuli were randomly assigned to each area. Patients respond to the tactile stimuli by looking at a picture of the affected hand, where they can visually identify the stimuli site. They didn't see their own hand, real hand. This process is intended to integrate the visual image from the photograph with the tactile sense, which is a somatosensory. As a result, the distance between the 2 points of the affected hand is reduced. Perception is improved, and the pain is reduced in the affected hand. Where perception is clearer, it should be noted that stimulating the affected hand was ineffective. These procedures have also been applied to knee, also recently shoulder. This is our research. So discrimination task of tactile location to the knee for lower limb CRPH patients. Then after that, there's an improvement of the referred sensation pain under allodynia. Second is a graded motor imagery tasks. They were developed to address the problem of reduced motor imagery and the sensory attenuation in patients with chronic pain. These tasks consist of 3 stages. The first stage is the left-right hand discrimination task. It's performed not only on the hand, but also on the feet, knees, and other part of the body recently. A patient experience pain respond quickly when the healthy limb is presented, but slowly when the affected limb is presented. It's suggested that the patient who complain of pain from even imagery alone should start with this method, which is based on subconsciousness. Next, in the second stage, the patient was asked to consciously imagine the movement of the target body. Furthermore, this is a method of measuring brain activity, and at the same time providing it as a neural feedback. The third step is, mirror therapy, and this slide shows the right hand on the healthy side, and the left hand on the affected hand. The affected limb is not moved; only the healthy limb is moved. The visual attention is directed to mirror, thus the pain induced by the movement does not occur, thereby not causing pain, but giving the illusion that the affected limb is moving. It has been reported that the pain reduced by performing the exercise in this order, mainly for frontal limb pain and CRPS. It may also be performed on the lower limb recently. Okay, so the third is known as the illusion task by this. There is our research by our research group. The figure on the left shows the illusion of motion by proprioceptive stimulation. The tendon is stretched by stimulating the tendon with vibration equipment, thus creating the illusion of the joint movement. Such stimulation has been used to reduce pain and prevent chronic pain during periods of immobilization. The addition of vibration to traditional physical therapy, such as a range of motion exercise and muscle strength exercise, has been shown to reduce pain. The higher the activity of the sensory motor cortex during a motor illusion, the less pain there is. Okay, so the center is a visual illusion task adapted for neuropathic pain in patient with a spinal cord injury. The place is a mirror image of oneself. While the paralyzed lower body legs is projected from a projector and synchronized with the body of another person. By synchronization, it's possible to create the illusion that one is walking. This is not indicated for patients who experience pain just by looking at it, although it has been shown to reduce lower limb pain, such as excess phantom limb pain. So in recent years, we developed the VR tasks. VR tasks that create a virtual reality world have been developed, where tasks has been reported to improve motor imagery ability which in turn reduce pain. In this case, it is important not only observe visuality, but also to make use of the movement and the motor intention of the healthy limb, as well as to set the affected limb as if it is moving in response to the intention, so that the information is consistent. So we examined the type of pain in which VR can be effective. The research showed that the pain decreased and the ovalization index increased after VR intervention. In other words, the motor imagery ability was improved. In the questionnaire, we examined the degree of sense of controlling or agency in which the patient felt as if they were moving the body on VR, and a sense of on-hand ownership in which the patient feels that the body on the VR belongs to them. The results showed that the rate of pain reduction increased for those who felt a sense of controlling. Furthermore, when looking at the quality of pain, VR treatment was found to be effective for pain related to kinesthesia, such as a muscle twisting, but not the whole pain related to cutaneous sensation such as burning. So this slide showed the adaptation and the non-adaptation of the tactile discrimination task and the motor illusion and the motor imagery task. The tactile discrimination task is for people with a default sensation who cannot identify the tactile site or with the body image disturbance. On the other hand, cases in which body map reorganization does not occur, in which the patient feels stressed by wrong answers are not applicable. For the motor illusion and the motor imagery tasks, cases with difficulty in moving the affected limb due to pain, whether reduced or impaired motor imagery, or with proprioceptive pain, such as the twisting indicated. However, it is not indicated for those with mental allodynia, in which the pain increases just by imaging it, just see it. It is also not indicated for patients with cutaneous sensory pain, such as a knife prick or a burning, or for cases that causes the worsening of movement disorders. Increased pain and the cases where the illusion cannot be believed are also not indicated. In addition, these tasks require ask a lot of attention to patient. It's important to have an environment and time for concentration. For example, in case of mirror therapy, it should be limited to 5 or 6 times a day for 5 minutes or less until concentration is broken. In short, we need to increase the frequency and decrease the duration. So on the other hand, TMS and TDCS also can called neuromodulation techniques, may be applied as a category of neurorehabilitation. By stimulation of the prefrontal cortex, it occurred the activation of descending pain control system. In case of chronic pain, there is a positive correlation between pain intensity and activity in the medial frontal cortex area. The medial prefrontal cortex is involved in the control of emotion. This area has an inhibitory relationship with the dorsolateral prefrontal cortex. The dorsolateral area is involved in cognitive activities such as goal planning and working memory. This inhibitory relationship prevents us from planning logically when we are emotionally upset. A decrease in the volume of the dorsolateral prefrontal cortex has also been observed in patients with chronic pain. Correspondingly, decreased volume in this area has also been observed in people with depression, similar to depression. In many cases, the excitation of the dorsolateral prefrontal cortex with neuromodulation techniques has been reported to reduce pain. So they are known as a supplemental therapeutic exercise for activating the descending pain control system. In other words, it's used as a method to moderate neural activity. You can see the right figure. So we applied TDCS to the dorsolateral prefrontal cortex. After that, we confirmed the activity of the region by EEG. As a result, we reported the significant decrease in unpleasantness to the pain stimuli after the stimulation compared to before the stimulation. So this slide is a summary of my lecture. One, reorganization of the body mapping in the brain depending on the frequency of use of the body. Decrease in body perception and the image of a patient with chronic pain is due to the reorganization of the body map in the brain. When the parietal lobe is dysfunctional, body image disturbance such as neglect-like symptoms occur. There is a relationship between body perception, image alternation, and the pain. Neurorehabilitation techniques such as tactile discrimination and motor imagery illusion task can be applied to cases in which body image alternation and motor imagery ability are impaired. Neuromodulation techniques such as TMS and TDS are mainly used to promote descending pain control. So now I'm handling my department that is consists of many graduate students. These days we are continue to study our research, recent research aims such as some higher brain dysfunction and chronic pain. So please check our previous study from ResearchGate. Thank you for your attention.
Thank you. Thank you so much for an elaborate presentation, Professor Morioka. And if there's any question, I would like to request Dr. Vetsanu to moderate the session.
Yeah,
Can
thank you very much.
Yeah.
Okay. Thank you for our speaker for your great presentation. So I'm not sure if any question from the floor, but I haven't seen in the chat box. But shall I start the question first?
Yes, go ahead.
Okay. During waiting for some other question. So may I have question to Dr. Ray and Marta Imamura? Yes. About the concept of nociplastic pain, and also Ray mentioned about the algopathic and nociplastic pain. So in case of fibromyalgia syndrome, or in patients who have associated with myofascial pain, that in some patients is common comorbidity. So how we for this, how we classify fibromyalgia or fibromyalgia plus myofascial pain in nociplastic pain or whatever pain?
Professor Ray, would you like to start, or could I? So yes, thank you so much, Professor Watsano, for that very important question. So, you know, this concept of nociplastic pain is really recent, even though we know it by, we may examine people like with central sensitization, peripheral sensitization. And in this recently published May 29 this year at the Lancet Journal, the group from Montreal, McGill, showed a reveal where they exactly demonstrate the role of in fibromyalgia, chronic pelvic pain, migraine, where this mixture of conditions exist. So as I mentioned also with multiple sclerosis, complex regional pain syndrome, it just tells us that we should better examine our patients, because then we have more strategies. So when you have a fibromyalgia, you have certain interventions that are proven to be moderately effective. But then if you have a myofascial component that is missed, then when you treat everything that is present in your patient, then it seems to be better. Same as Professor Morioka mentioned. So if we understand what is happening, then we can avoid the fear of movement, but also reinforce the healthy movement.
Right. Thank you. So it's I do agree with you. It's about like a chronic pain sometimes it's quite hard to be effective by just a single intervention. And also in our rehab world, that we face a lot of chronic pain like this. It's quite hard. And if we test like a study which one intervention is impossible to make any difference. So I think it's in the research. I don't know is in terms of control randomized control trial could be combine multi-intervention compared with something to show the effectiveness. You know, like in a rehab intervention, when the patient see us, we never like a prescribe or just one thing. Also in a treatment program is a multi things to help. Yes.
Yes. Multi-point and multifocal and multi-stress. So for example, I give a great example as Professor Morioka mentioned. So if you have a patient with chronic pain, and imagine if you just giving them antidepressants like duloxetine, you were acting in one very single particular way to increase the activity of serotonin or adrenaline. But we know that the suppressive pain system is much more than that specific part. That's why maybe in the guidelines we have low effects, because we're just seeing one small part of the whole picture. So hopefully we can collaborate closely and then change the global burden diseases, and at least in chronic pain, by better understanding and how we can work in multiple levels, then we will hopefully decrease the health conditions related that could be benefits from rehabilitation, and decrease the years with disability. I think that's the main goal. And the other one is to influence primary care physicians in this concept, so the prevention or the treatment in the very acute phase is provided.
I'm really sorry to interrupt, but because of the paucity of time, I think so we'll have to close this session because we are starting the quiz. But I would like to thank all the speakers. They are very brilliant and very brilliant talks, and I'm sure this has enlightened all of us. And all the speakers, Dr. Vetsanu, Dr. Martha, Professor Morioka, and Dr. Raymond, we thank all of you. And I and Dr. Datta, we thank the AOCNR for giving us this opportunity for chairing this session. So we can close the sessions now, and thank you so much.
Thank you, Namita.
Thank you.
Thank you.
Thank you.
Thank you so
Thank
much.
you, Nivedita, and thank you, Datta. Thanks,
Thank you.
Professor Mata and Raymond. Thank you very much. I hope you take active participation in the quiz. You
Yes,
might interest from this. Join in all one, please.
Okay.
Thank you, Professor Normal. Thank you.
Thank you.
Thank you. I'll talk to you later. Okay.
Thank you.
Okay.
So I'm sorry,
Yes.
Thank you. All right.
my internet is up. We have low signal. Thank you.
Okay. Bye-bye.
Bye.
See you guys. See you in
how,
hall one.
how can we move to the hall one?
Yes.
I have to leave now here or just how?
Yes, sir. You
How
have to
can I
leave
make that?
here and then go to faculty lounge and then go to hall 1.
To hall
We need to go to hall 1. Thank you. Thank you so much, Professor Nirmal.
How to get there? Hall 1.
You go to the faculty lounge once again and then go to the hall 1.
All right.
There are all halls 1, 2, 3, 4. So go to hall 1.
I have to leave from this room first.
Yes.
Yes.
Okay. I'll leave.
Hello. He said there are no chairman for that. So coordinator only has to introduce everybody. So I have to go there at 5:30. Yeah. Yeah. So you only carry on. No, don't give any comment. Just introduce them, because he said only, I don't know what about the other CVs. They were trying to check whether they are there. Only all are there. Then it is okay. Achha, 3 are pre-recorded. So then that pre-recorded, then nothing we have to do in that, because you can't stop it, no? Yeah, 6:30. Then there is this valedictory, no? So I will, once I leave here, then I will be in hall 1 only till the end. Yeah. Okay. Then now we'll have to start at 4 o'clock, right? No, 4:30. Okay. Acha, you're going for the quiz? Okay. Okay. Sure. Okay. So 4:30 we'll meet. Yeah.
Hi, Vitriana. All set?
Yeah, all set. Sorry. I think I will try live, yeah. But
I can't hear you.
You can hear me? You can hear me now? No? No?
Maybe you'll have to take out your
okay
earphones.
Okay. Is this clear now? Can you hear me? Not yet?
Yeah, this is fine now.
Okay.
Hi.
Okay, nice to meet you. I try to present live, but I already pre-record my presentation also if anything happens. Yeah.
Hello?
Hello.
Hi, everybody.
Hi.
Yeah, I'm Raju from Nepal.
Okay, nice to meet you. I'm Fitriana from Indonesia.
Yeah, nice to see you.
Nice to meet you.
I couldn't access for video. I don't know why.
Oh.
They say Zoom not allowed.
Pardon? Now can you switch on your video? It is on now.
Hello.
Hello, Dr. Raju. Yes.
Hi. Can you hear me?
Yes, we can hear you.
Yeah, I couldn't access for the video. It's my own problem, I think.
No. I will just check it. I'll get a help. Miss Mansi, can I get Dr. Raju's video on? Bhavesh sir?
Yes, wait for 2 minutes.
Yes, fine. Dr. Raju, we will help you.
Okay.
So we have got 7 minutes. My chairperson is joining me soon. We will start. Yeah, Deepak sir?
Yeah, I think
We have 7 minutes.
Yeah, okay. You got the slides, CV slides?
Yes, sir.
Vitriana will be talking first, right?
Yeah. I will talking first.
Vitriana, then Mosi, then Naveed, then Constantine, then Partha sir. Yes.
So the host has allowed me for the video, but I tried, I couldn't. Maybe it's not a problem if there is no video, right?
Yes, no problem. You can just share your slides and give a live presentation.
Okay. Okay. Thank you.
Maybe you can rejoin and check.
Okay.
If it's a
I'll
problem
rejoin.
from your side. Mansi, could you just help him? He is unable to switch on his video.
Should I rejoin or? The
I'll
host
just-
has asked you to start your video. Start, so I should say start my video.
Yes.
Is it a recording
not-
or?
No,
or
it's a
he
live
will-
presentation.
Yeah, I'll do my presentations. But anyway,
Okay.
I don't know why video is not working, so it's okay.
We have 5 more minutes.
Meantime, I think you can ask them to show the slide of the first speaker, CV slide. So they take time to.
Okay.
That's right. Good.
Yes, all 6 slides are there.
That's good. I think you can start introducing her so that we save time on the, because it's a big session, 4:30 to 6:30.
Sure, sir.
Yeah.
Can I have first session details? First slide.
Okay.
Yeah, her slide is there. Introductory slide is there.
Good afternoon.
Good evening, everyone. I welcome you all to the session. We have our Dr. Deepak Palande, a senior neurosurgeon and a founder director of IFNR to chair this session. We have invited guest lectures on rehabilitation management, rehabilitation needs of long COVID, perception of rehabilitation, hyperbaric oxygen, carbon dioxide therapies, long COVID syndrome, and spinal injury rehabilitation. So stay tuned. I welcome Dr. Palande, sir, to chair the session. Could I request Dr. Palande, sir, to...
Yeah, I will have to leave after the second talk.
Yes, sir.
As I have to attend the...
You can just give your opening remarks and then I will introduce the speaker.
Yeah, I think this is a very long session, and we will be having talks on rehabilitation management, barrier of stroke patients during pandemic, an Indonesian experience by Vitriana. Then next will be rehabilitation needs of long COVID by Mosir Rehman Kashru. Then there will be perception of rehabilitation professionals towards interdisciplinary approach working in neuro rehabilitation by Navid Babar. Then we have interesting topic, hyperbaric oxygen and carbon dioxide therapies as physiatric intervention in stroke by Constantine Munteanu from Romania. And then will be a session on long COVID syndrome, a rehab perspective by Partha Ray. And then last will be spinal injury rehab during COVID-19 pandemic, an experience of spinal rehab center in Nepal by Raju Dhakkal. So there are 6 talks, and I will request now Sonal to take over the things to introduce the speakers.
Thank you so much, sir. So we have Dr. Vitriana, MD Physiatrist, Neuromuscular Consultant at Faculty of Medicine, Universitas West Java, Indonesia. She is Head of Neurorehabilitation Division from Central Public Hospital. Dr. Hassan Sadikin, Bandung, Head of Department, Medical Staff in Physical Medicine Rehabilitation Department, Faculty of Medicine in Bandung, Head of Residency Program, Physical Medicine and Rehabilitation, and I'm sorry to pronounce that.
It's okay.
She's Secretary and Member of Academic Senate in Faculty of Medicine, Member of Board Examination Commission in Indonesia. She has many research and developmental accolades to her credit. Ma'am, I welcome you. Please proceed.
Thank you very much, Nda. Okay, I will share my presentation first. Okay, wait a minute. Sorry. Okay. Can you see it? Okay. Thank you for the committee. Thank you, Sana. Good afternoon. My name is Vitriana Biben. I am a physiatrist from Physical Medicine and Rehabilitation Department, Dr. Hassan Sadikin General Hospital, and also a lecturer in Faculty of Medicine, Universitas Padjadjaran, Bandung. Thank you to the committee for the opportunity for me to share our experience. Today, I want to share with you a topic of rehabilitation management, barrier of stroke patients during pandemic from Indonesian experience. What are the impacts of the pandemic to the rehabilitation services and how we try to deal with it. Stroke is a disease with a prevalence of 10.9 per million in Indonesia population over the age of 15, or estimated as much as more than 2 million people based on the result of the Indonesia Basic Health Research conducted in 2018, and it might be more in number if the research were to be conducted today in 2021. This data shows an increase from the same research result in 2013. The prevalence of stroke increases with age. As we can see in this slide, elders are more common to having stroke than young adults in Indonesia. This condition may contribute to make this disease become the third leading cause of death in Indonesia, with a death rate of more than 100 deaths, or 9.7% of total deaths before the pandemic. But as a physiatrist, we are aware that stroke as a non-contagious disease causes disability more often than death. Obstacle in comprehensive stroke management in Indonesia include low awareness of stroke risk factor, unidentified stroke symptoms, non-optimal stroke management, lack of compliance toward therapeutic programs to prevent recurrence of the stroke, and lack of understanding related to stroke rehabilitation. Those events could play a role in increasing new stroke incidents, a higher mortality rate due to stroke recurrence, and higher disability rate in Indonesia. Stroke rehabilitation has been executed comprehensively in Indonesia since the patient is hospitalized or in acute phase, also or in outpatient department, subacute and or chronic phase. But it is still not ideally done because of some problems such as lack of facilities to support the transitioning phase from hospital to home after the patient is discharged from hospital. It also have a lack of human resources and limited facilities and infrastructure in the hospital. Currently, Indonesia has more than 900 physiatrists and almost 6,500 physiotherapists, approximately 2,000 occupational therapists, and 1,300 speech therapists, and 400 orthotists prosthetists. And if we compare with Indonesian population, that more than 200 million in December 2020 alone, this composition is not ideal in terms of the ratio of population. Uneven distribution of physiatrists in all Indonesia region, of which is an archipelago country, increases the challenge to do a comprehensive stroke rehabilitation. Most physiatrists are concentrated in Java Island, the most populous island in Indonesia. Related to the fulfillment of human resources needs, various efforts have been made by the government and also by the National Rehabilitation Professional Organization, such as increasing the professional education program and regulating distribution arrangement in the context of equal resources distribution throughout the country. The COVID-19 pandemic that occurred in 2020 has changed the process of rehabilitation services. Recently, after going through steady normalization of rehabilitation services, the number of COVID cases in 2021 shows tremendous increases again in Indonesia, after previously experiencing a drop in new cases in early 2021. It inflicting a big impact on stroke rehabilitation services in Indonesia. Rehabilitation services for stroke patients in hospitals during the pandemic in Indonesia then referred to the protected code stroke, which is a form of additional protection so that stroke services can continue to take place with both medical personnel and patients safe from COVID-19 transmissions. Several things were carried out to fulfill these principles depending on the ability of each hospital in Indonesia, such as cooperating with hospital to design service area and way engineering system control, designing telemedicine or telerehabilitation by design, makes availability of good and appropriate PPE, such as N95 respirator or double mask for medical personnel, reducing the number of medical personnel during treatment and outpatient rooms by dividing the work schedule, limiting the length of face-to-face consultation and prioritizing online consultation in several hospitals, limiting the variety of medical rehabilitation services, limiting the number of patients visiting the polyclinic, limiting the frequency of rehabilitation program per week, and do disabilities vaccination. This strategy has led to decrease in the number of patients in both inpatient and outpatient and several COVID referral hospital centers, because hospitals' health services are currently focused on treating COVID-19 patients. The pandemic also causes the emergency room waiting time to be prolonged and therefore increasing the risk for a poor prognosis for stroke recovery. Besides that, several stroke patients were hospitalized with COVID-19 infection. Stroke patients who also suffer from COVID are undergoing treatment in an isolated room. This then causes a sense of trauma for the patient, so they feel reluctant to return to hospital to undergo an outpatient rehabilitation. This becomes a new challenge for the rehabilitation team to overcome the physiological issues besides the impact of stroke itself. Data about neurologic patients with COVID-19 in Indonesia till now is still limited, and there's still going on study about it. To encounter the problem caused by the pandemic, some policies adopted by the hospital during the pandemic include encouraging the implementation of technology-based administrative systems that have previously been initiated in all hospitals. Rehabilitation services are encouraged to use technology-based rehabilitation or telerehabilitation to overcome problems related to the restricted face-to-face services due to the pandemic. Several policies were reviewed based on previous research to make a realistic implementation for Indonesian situation. Result of a research conducted in 2013 related to the identification of the need for an affordable technology-based rehabilitation system for the stroke patient in Indonesia has been shown that stroke sufferers need independent exercise at home with flexible time and a therapy system that is able to provide information about the exercise being carried out, give feedback, give appreciation for the success of the safe exercise and affordable costs. The size of equipment used should not be too large so that it can be used in the room. The exercise provided are related to daily activities and involve social interaction. Exercises are presented in an interesting and varied way. The exercise systems also should be allows users to select exercises, save training data, and continuing exercise that has been done before. To practice the telerehabilitation is also a challenge for a developing country like Indonesia. Even data show that COVID-19 pandemic in 2020 made increasing the use of internet connection because of the increasingly crucial need for digital transformation. Global data show that a smartphone that's connected to a reliable internet connection is becoming people's primary need and will continue to grow as many as 7 billion in 2024, or 71% of the total world population by 2025. Although the latest data shows the internet usage in Indonesian population is quite high, an increase in each year, Indonesia faces challenge also related to the fact that the most users are concentrated in Java Island. Data also show there was an uneven internet coverage in more remote areas of Indonesia and an uneven ability for stroke patients to fully utilize technology because internet users are dominated by younger individuals. This data make the approach of telerehabilitation for stroke patients in Indonesia needs to be considered to adjust to this condition and to make it feasible and useful for the patient. Trying to anticipate the challenge, Indonesia government then made Indonesian Digital Roadmap of 2020 until 2024 that consists of accelerate digital transformation for governance, acknowledge an efficient and fast public service delivery, for instance, in education and health sectors, consolidate and optimize infrastructure and share services, acknowledge community inclusion in primary developing area, and encourage equality by opening opportunities for women and people with disabilities to participate in the e-commerce chain. Hopefully, this digital roadmap can continue, even if we are still facing the acceleration of COVID-19 cases that has hit our socioeconomic stability. For stroke rehabilitation itself, in Indonesia, there is one recent application for telerehabilitation that's still in developing to be finalized from PMR Department Hasanuddin University in Makassar, South Sulawesi. Hopefully, it can be launched officially in September 2021. It is still in early development, and we are still going to expand it to make it feasible and easier to access for our patients. This is the appearance of the application, where we can write down the identity and inform consent for the exercise that we will give to the patient. And this is the appearance for the exercise option. An early study for this application show a beneficial effect, and hopefully it is simple enough to apply it for many stroke patients in Indonesia. So coming to the end of my presentation, at the present time, during the COVID-19 pandemic, stroke rehabilitation services in Indonesia are facing new challenges apart from having to look for alternative safe rehabilitation option during inpatient and outpatient following WHO guidelines. Rehabilitation services are also facing a surge in post-COVID patients who dominate several rehabilitation centers. Thus, the focus arrangements and service and medical personnel also require an adaptation in addition to carrying out related rehabilitation. By looking at the data that I presented before, the option of the telerehabilitation for stroke packed in many interesting ways is important to consider in pandemic situation. Increasing interdisciplinary cooperation in this situation is very important and need to be increased in a race against time to design alternative usage of technology accompanied by infrastructure and economic analysis so that technological system for rehabilitation services remain affordable and can be applied in all areas of Indonesia. And I will close my presentation with a quote from Martin Aku. When you have done your possible best and nothing seems to work, then walk in patience, the invisible key that unlocks possibilities. Let's face this pandemic together, hand in hand with our best effort, according to each of our abilities, and we can overcome it. That's all. Thank you for your attention. Thank you.
Thank you, Dr. Vitriana. It was very crisp and lucid talk. I don't see any questions for you in the panel, so we can move to next presentation.
Okay, thank you.
Could I have slides recorded link for next presenter, please? Dr. Mohashir Khasru, are you there? Mansi, do we have his recorded talk?
Yes.
Yeah. So may I have a pleasure of introducing Dr. Mohashir Khasru, our invited lecturer, a speaker. He's associate professor and coordinator of Rheumatology Rehabilitation Clinic in Physical Medicine Rehabilitation of Bangabandhu Sheikh Mujib Medical University. He's a graduate from Dhaka University, and he has obtained his fellowship FCPS PMR in 2010 from BCPS. He has been awarded MSc Rheumatology from University of South Wales, UK. His keen interest in musculoskeletal rehabilitation. He published many articles. He's delivered many international and national conferences and lectures. He's awarded BIS scholarship, and he has got ISPRM General Award and Victor Ibrahim Memorial Scholarship too. Welcome, sir. Could I have his recorded talk, please?
Good afternoon, ladies and gentlemen. I am Dr. Mohashir Rahman Khusro, working as an associate professor in the Department of Physical Medicine and Rehabilitation at Bangabandhu Sheikh Mujib Medical University. I would like to thank the organizer for inviting me to share my views regarding long COVID rehabilitation. Well, ladies and gentlemen, I have nothing to disclose for this presentation. We all know SARS-CoV-2 infection was first arose in Wuhan, China in December 2019. In the March 2020, WHO declared this COVID disease as a pandemic on Over time, 220 countries are affected with this pandemic disease. As of 30th July, more than 197 million population has been infected with this SARS-CoV-2 virus. The death is as high as near 1 million over these 20 months. Though in this Asia region, 65% population belong in this Asia region, 1/3 of the total infected cases are belongs in this Asia. But now the cases are being increasing day by day. And all the cases are identified in the Asia region, 50% belongs to India. We know that SARS-CoV-2 infection can manifest any of our organs. So it can manifest from here to toe. Although there are very common manifestations like respiratory clusters, along with fever, there may be some musculoskeletal clusters consisting fatigue, myalgia, joint pain, and bone pain. There may be some enteric clusters, including diarrhea, and there may be some dermatological manifestation. I would like to take the privilege to share the results of our cross-sectional studies published in July 2021 in our university journal. We found about 40% of the patients confirmed COVID cases, they manifested with moderate pain. And pain mostly affected hip, shoulder, back, and arms. However, in systematic review, we found that 33% population may develop, they have fatigue. 21% of the population has a myalgia, and 15% of the respondent in this systematic review, we found joint pain. Therefore, besides the respiratory and neurological manifestations, we should look for the musculoskeletal manifestations as well. According to the NICE guideline, according to the NICE definition of long COVID is nothing but an unexplained, long-lasting symptoms which last for more than 12 weeks that emerge during or after the SARS-CoV-2 infection. Interestingly, long COVID syndrome was initially recognized by the social support communities, and thereafter it has been adopted by the scientific communities. And there are many synonyms of long COVID. There are disparities in prevalence of long COVID across the globe. We found, though the data is very limited, we found that in the developed world, long COVID prevalence is 30%, and in the developing countries like Bangladesh, we found the prevalence of long COVID is as low as half of the developing countries. The disparities between these two regions may be due to lack of awareness among the common population, so that they can't feel or they can't aware about the new symptoms that they are facing after COVID infection. We know this infection, COVID infection, in acute phase infection, disease complications and the disease process, as well as the medications used as a part of the treatment, all contribute in persisting of the symptoms. Even though the cytokine storms, altered immune status, and the inflammatory markers, they also can exert some new symptoms and can prolong the ongoing symptoms. We all know that staying hospital for the prolonged time in ICU or in non-ICU, the physical deconditioning is evident, and this, as well as this SARS-CoV disease is very closely associated with the psychological issues as well. And many researchers, many psychiatrists are warranted that the next pandemic may be associated with the psychological disorders. So all these factors can put some reasons to make the symptoms prolonged, and the prolongation of the symptoms is termed as actually long COVID symptoms. Well, what are the risk factors for developing of the long COVID? Female gender, old population, abnormal lab tests like cytopenia, including WBC and platelet, along with elevated D-dimer, ferritin, and other acute inflammatory proteins, as well as early symptoms, more than 5 symptoms in first week, and early dyspnea is a risk factors for developing long COVID disease along with the comorbidities. What are the manifestations that are being seen in long COVID? Among the patients of long COVID, at least one symptoms is found about 80% of the long COVID, of the post-COVID patients. Although all are not meeting the diagnosis criteria, though there is no well-established criteria by the definition of NICE, 80% of the population may have on symptoms. However, the most common manifestation in COVID, long COVID is fatigue, and second to the fatigue is the headache, as well as attention disorder, anosmia, sweat, hair loss, agnosia. These are the common manifestations. Besides this, there may be some skin manifestation like vesicular, maculopapular, arterial, or type skin lesion in the back or in the lower lip, as well as there is an important sign of long COVID is COVID-2 manifestation as a long COVID syndrome. There is no clean-cut manifestation of long COVID because this is not a single disease entity, this is a syndrome. And this management mostly are symptomatic, and the main thing is rehabilitation of long COVID patients. Therefore, prevention and treatment of acute COVID disease is crucial. And we need to follow up all COVID patients after hospital discharge, as well as we should look for recovery physically and mentally, and we should check the blood biomarkers and imaging so we can look for any risk factors associated for developing of long COVID. Before going to a rehabilitation of long COVID, I like to draw attention regarding disparities between the rehabilitation facilities among the nations. We all know there is a significant disparities are prevailing in between the developed and developing nations. So we need to overcome the rehabilitation barriers that are limiting the rehabilitation services for the holistic patient care. The most important barrier for long COVID rehabilitation is lack of awareness, even among the physicians, about the disease entity. Of course, there are some poor inter-specialty relationship. There is lack of health education, as well as lack of resources. And these pandemic situation, most of the health professionals, along with the physicians, are deployed for acute COVID care. So there is gross limitations of the resources. Despite having these limitations, we should form a rehab team consisting of all the rehabilitation health professionals to maximize the effort that can improve the quality of life of a long COVID patient. We need to understand that COVID-19 related neurological, pulmonology, musculoskeletal consequences are common, and they pose a danger to the patient's quality of life and functional capacity. Suspicion of these diseases stringent control of metabolic alteration and cardiovascular risk factors, and effect and safe treatment of these entities are ongoing problem during this pandemic. So we need to assess who are at risk. Those patients who developed new symptoms or continuing the ongoing symptoms after 4 weeks, we should check for total blood count, liver and renal functions, as well as acute proteins, along with the imaging. And even after 12 weeks, if respiratory complaints persist, we should go for chest imaging. And if we found, is there any symptoms persisting, any organ involvement, or is there high risk for development of long COVID, we should refer the patients to the holistic multidisciplinary rehabilitation services to maximize the management outcome. I will not stress on the neurological and neuropsychiatric rehabilitation aspects of long COVID. This part will be delivered and will be stressed by Professor Partharoy, and I will go for the pulmonary and musculoskeletal rehabilitation needs for long COVID. We all know, despite its undeniable advantage, the present global ability of pulmonary rehabilitation treatment is shocking inadequately, which may have severe consequences in post-COVID care phase. We all know how the lung is rapidly involved with SARS-CoV-2 infections. So, in all the difference, the ground glass appearances and the fibrosis is changing overnight. And that's why in acute phase, we should emphasize on postural training, particularly the prone position for 30 minutes. And there are 6 steps of proning, we all know. And after this acute phase treatment, we should emphasize the breathing exercise. Along with the acute stage, the breathing exercise should be continued. And in the long COVID management, for the pulmonary rehabilitation, breathing exercise is crucial. It improves the COVID pneumonia, it improves the increase in ILD, it improves, and it is also effective for the COPD. This breathing exercise will elevate the dyspnea, tiredness, and improves the self-autonomy. So overall respiratory functions, quality of life, mobility, and psychological functions will be improved in breathing exercise. And we all know diaphragmatic exercise is very important to maximize the area of gaseous exchange in the lung. So diaphragmatic breathing is more important to expand the lung. That's why in breathing exercise, diaphragmatic exercise is mostly prescribed and mostly advised technique for pulmonary rehabilitation, along with the coughing and many other maneuvers and techniques. Well, as we all know that fatigue is one of the most common manifestation in long COVID, and we all know cognitive behavioral therapy is very, very effective. Evidence says that it is very effective in managing fatigue. So we should remember that cognitive behavioral therapy should be instituted in all cases of long COVID syndrome. We all know for musculoskeletal manifestation, for musculoskeletal rehabilitation of long COVID, exercise, physical exercise is the key. So we should emphasize the physical exercise after assessing the patient, and it should be tailored, it should be customized, and so that the patient can be get the proper guideline for the individualized exercise guidance. And we all know this exercise will triggers the neurogenesis and synaptogenesis, and it will improve the brain plasticity. It will prevent the cognitive impairment, as well as these aerobic exercises will help brain fog, dysautonomy, and postural orthostic tachycardia syndrome. Among many others, combined musculoskeletal rehabilitation technique exercises, Tai Chi is one of the important, and evidences it can improve muscular strength, brain heart function, improves respiratory system health, improves mental health, improves blood pressure, improves immune system, as well as it improves sleep quality. Along with the Tai Chi, many researchers found that yoga is equally important in managing musculoskeletal and as well as fatigue manifestations in long COVID. So I would like to stress on that prioritizing and tying down the rehabilitation services for the long COVID warriors should be a top priority. Self-management strategies should be promoted as well as regular follow-up. In a follow-up visit, the metabolic state and organ functions should be checked. As a part of their recovery, people with long COVID must engage in pulmonary and aerobic exercises. Specific therapies may be required in special cases such as acute brain injury by COVID. I would like to conclude my speech echoing the statement of DG WHO. Dr. Tezo said that recognition, research, and rehabilitation. Really, this is very important for long COVID management. We should recognize more cases. We should work on it more and more, and for the patient's benefit and for the savings of the life, we should maximize the rehabilitation services. And my earnest request to all that we can prevent this long COVID by wearing masks, preventing acute infection. Thank you very much. Thank you all for patient hearing.
Professor Kuslo, that was a very enlightening, wonderful session. You have made very clear regarding the rehabilitation needs in COVID patients and even the non-COVID aspects, where you have psychological, pulmonary health, dermatological health, and neurological health, how important it is. So we like to take one question. If any question from the panelists here, or should we go ahead? Dr. Palande?
Yeah, no, there's some time for question. He has finished quite in time. So
If
one
you
or
can
two
take
questions.
up one question.
Yeah. Dr. Moshir, if nobody is asking, I would just like to ask you, did you see a lot of increase in stroke after COVID infections compared to normal times?
Thank you, sir, for your important question. Actually, we don't have such data comparing brain injury in COVID and non-COVID situation. And nowadays, you know that facilities for the non-COVID patients is really decreasing day by day with the expansion of the facilities for the COVID patients. Therefore, most of the patients, those who are getting admitted in the hospitals, they are driven from the COVID infection. That's why it is very difficult to say whether the rate is increasing or not, because many cases are not being attending the hospital because of many more issues are there, along with a lack of facilities. However, theoretically, it can be guessed that brain injury and stroke induced by the COVID or any other infection could be higher than the previous stage of the universe. So the rate can be raised, and the future world may face more more disability related to the neurological as well as non-neurological disabilities related to the COVID infection, particularly pulmonary disability, insufficiency, and ILD cases will be raised. It can be said at this stage. Thank you, sir.
Because usually this problem was because of vascular involvement, you see. So there have been instances where more people are getting heart attacks as well as brain strokes, vascular, ischemic strokes mostly. Anybody else has to comment on this if they have got any experience of this sort during COVID times?
Dr. Partha has a comment.
Yes, I think I can take that question. Yes, quite rightly put. Yesterday, we are having a simultaneous stroke summer school at the moment, and Rohit Bhatia from AIMS Delhi was actually addressing this through his studies, where COVID positivity and incidence of ischemic and hemorrhagic strokes was being correlated in a 2x2 table. Peculiarly, contrary to expectation, there was no increased incidence of COVID positivity and strokes in either the hemorrhagic or the ischemic types. That was from that solitary study, but I think we need to wait for the whole study to be declared. My expectation as a clinician, I have not seen that much increased incidence of strokes during the acute COVID illness as a presentation. But then they have comorbidities as well, with hypertension and diabetes, and a lot of immunological problems that I will be discussing because Professor Khasru and me are doing a joint presentation today, as he declared to you. Okay. So I'll be touching upon it. The numbers don't indicate that the stroke incidence is up. Neither would you believe, despite the Gulen-Barre and COVID correlation, there have been studies that have been showing the evidence both ways. So I think the jury is out in regards to both the peripheral nervous system and the central nervous system. The problem is that to prove causation with COVID and stroke, we need to demonstrate the presence of the virus within the brain tissue. And I asked Wayne Feng last year in August, because I was writing up a paper then, as to what the correlation is. And they had not done autopsy. The problem with this particular 116 month is that we have not had enough autopsy studies. So we really are a bit short on the evidence because of naturally infection control issues. So that's been a limitation to our studies. And that's been the problem, actually. Okay, I shall move on and let you pass on. Thank you very much.
Dr. Vitriana, I have a quick question for you. Did you see any raise in the poor thrombolizing or a delay in getting a stroke intervention and that leading to a poor rehabilitation in your country? And what was the barriers, what were the solutions made from your side, from the advocacy and the panels, if at all they have attempts made?
In the earlier and the second phase of the COVID-19, in the 1 month ago, the emergency is very full for the patients. So it means that many patients with neurologic problems to be wait for to get into the emergency room. Besides, we have different setting, but still it is takes time to get to the emergency exit. But now I think fortunately that the COVID is already decreases and everything I think seems to be normalized, but still in high incidence of COVID. but still we have a struggle to make a patient to sure to get back to the hospital because they're very afraid about the infection and also being infected, such as the challenge for us in our rehabilitation department right now. Still struggling to find out how to make sure make the patient stay safe and still confidence about the safety to the hospital. It is more psychological than the safety itself, because we do the healthy procedure as we can. Yeah, that's all. This is still a challenge for me and also the rehabilitation team.
You can go ahead
Thank
with
you,
the
Adriana.
next. Yeah.
Yes. Can we have next speaker slide? The next speaker is Dr. Naveed Babur, Perception of Rehabilitation Professionals towards an Interdisciplinary Approach Working in Neurorehabilitation. Can I have his recorded talk played? Yes, Professor Naveed, Mohammad Naveed is PhD in Rehabilitation Sciences from Pakistan. He has done his fellowship in rehab medicine. He is HEC approved PhD supervisor. He is NCRC Physical Therapy member, editor-in-chief of International Journal of Rehab Sciences. He's director of International Journal Academy of Rehab Science Research and Education. He's principal of ISRA and ISRA University of Islamabad campus. Professor Babur, I welcome you. Please go ahead.
In the name of Allah, the merciful and most gracious. I am grateful to the management of AOCNR for inviting me to this virtual forum to represent Pakistan. I am Professor Dr. Mohammad Naveed Babur, Dean Faculty of Allied Medical Sciences, Principal ISRA Institute of Rehabilitation Sciences, ISRA University, Islamabad, Pakistan. I am Secretary General Pakistan of Neurorehabilitation. I am holding PhD in Rehabilitation Sciences and a fellowship in Neurorehabilitation Sciences and certification in Neurorehabilitation Sciences and academic writing skills from Seoul National University, Bundang Hospital, South Korea. I have more than 70 research, international publication, and one book on my record. I am member, Board of Faculty and Academic Council and Board of Advanced Study and Research, various universities of Pakistan. I am Director, Research, ISRA University, Islamabad, Karachi, and Hyderabad. I am the first one who established state-of-the-art motion analysis gait analysis lab at ISRA University. Today, I would like to talk about the perception of rehabilitation professionals towards interdisciplinary, multidisciplinary approach working in neurorehabilitation. As you know, benefits of multidisciplinary team in healthcare setups cannot be denied. If effectively developed and implemented, patient and team members both get immense advantage from it. Unfortunately, in developing countries, due to other constraints, this part of healthcare is still neglected. There are multiple reasons behind this, which include lack of clear vision. Organizations are not sure what they want from a multidisciplinary. Benefits, although known but not crystal clear to the administration, resulting in neglect from their end and facilitation and development of multidisciplinary team. Lack of appropriate curriculum at degree level and professional entering in the field, lack of basic knowledge regarding multidisciplinary approach. As you know, in developing countries, GDP allocated to the health, restraint, teaching, and training of professional and advent to multidisciplinary team in long run. Lack of skill mix is another issue. Services of allied health professionals are scarce and professionals are reluctant to perform duties in far off areas and less privileged areas of the country. We have conducted a study recently in which we have analyzed the perception of rehabilitation professionals, which I would like to continue. The main objective of studies were to explore the interprofessional collaboration among rehabilitation professionals in stroke rehabilitation. The second one, to evaluate the barriers in implementing interprofessional collaboration among rehabilitation professionals in Pakistan. As you know, multidisciplinary team approach and establishment of stroke unit in tertiary care hospital in Pakistan can reduce the hospital stay and decrease the economic burden upon patient and family and the caregivers. So we decided to explore the interprofessional collaboration among rehabilitation professionals in stroke rehabilitation and to evaluate barriers. These barriers at three levels we have identified: at the hospital level, at the individual level, and the department level. For the methodology of this study, the study design was used exploratory sequential mixed method study with both quantitative and qualitative components. For qualitative components, focus group discussion was conducted at ISRA University Islamabad campus. At least two focus group was conducted. For quantitative portion, there was a standardized questionnaire scale used with various components, and comparative cross-sectional survey was conducted within the disciplines. And the duration of this study was 18 months. For qualitative portion of the study, the data was collected from all major cities of Pakistan. The duration was 18 months, and the sample size, overall sample size was 139, in which physiatrists were 14, physical therapists were 35, occupational therapists were 17, speech language pathologists were 31, prosthetics and orthotics were 42. For qualitative data, one member from each rehabilitation professional include in focus group except prosthetic and orthotics. For prosthetic and orthotics, we include a rehab nurse and clinical psychologist to include in the qualitative portion. Purposive and non-probability sampling was used. For inclusion criteria, registered practitioner with minimum 2 years of professional clinical experience working in multidisciplinary team were recruited. For both male and female were recruited. For exclusion criteria, rehabilitation professionals working at administrative positions were excluded, and other medical and health professionals were also excluded. Qualitative data, focus group discussion, two focus group were has been conducted in year 2015 to 16 with a sample size of 6 professionals including rehab physician, physical therapist, speech language therapist, occupational therapist, clinical psychologist and rehabilitation nurse working in the multidisciplinary team. After this, a comprehensive audio videography have been developed, transcribed and documented with the help of two coders. Data was transcribed and thematic analysis along with characteristics were drawn manually. Data verification was done with the help of two separate researchers. Here are a few features of interprofessional collaboration members identified during focus group discussion. First of all, better communication. Formal and informal communication, ability to read plan of care, different opinion, common goal, use of communal case reports, interpersonal and listening skills. As you know, communication only not between team members, but also between service provider.
Mansi, the recording has stopped. Can you please reshare? Yeah, thank you.
Into the necessity. Individuals from multiple specialties are working together at teams, so who leads and when it is dynamic process to manage the issues of who will lead and when is mandatory. Then there is a team philosophy, team, sport, and affiliations. As you know, the significance of team philosophy was trust, mutual respect, reliability, obligation, and sport were the most common raised theme. But a team environment include the importance of informal relationship and alliance between colleagues is very much important. Then there is a training and development. It's far most important. Prospects for gaining new information, sharing knowledge, ongoing professional development and education is very much important in multidisciplinary teamwork. Distinct individual reward and opportunities. As you know, availability of the learning opportunity for the team members regarded as the basic required characteristics for productive services and better capacity building process individual careers opportunities also really on continuous learning process. Ultimately, this will result in a higher motivational level among team members regarding work along with the team development strategies. Absence of these opportunities in teamwork will result in members leaving the team in pursuit of the individual careers. There must be a mechanism within the team to promote individual skills through workshop and certifying courses and rewarding the members according to the enhancement of their competencies. In focus group discussion, the members identify following barriers interprofessional collaborations. Uh, they identify these barriers at organization level and team level and barriers faced by individual team members. So first of all, organization barriers. There are few listed here. Lack of appreciation of roles of other healthcare professionals, lack of finances and regulation, legality of the scope of practice, administrative and educational structure of hierarchy which discourage interprofessional collaboration, uninformed team building and decision making, lack of proper health information management system. As we are living in a developing countries, here we have a very weak health management information system. Combative nature of sharing professional role and expertise. Everyone uh, uh, has to be within the limit of their professional role and expertise. Focus group identify barriers at team level. Lack of proper purposeful training, role and leadership ambiguity, absence of proper machinery for timely interchange of information, dearth of obligation of team members, diverse goal of single team member, lethargy of the team members due to overwork, poor decision making, clash about individual affiliation to patient, too large or too small team is also one of the barrier. Traditional professional culture is also one of the barrier at team level. Focus group also identify barrier faced by individual team members. One is multiple responsibilities and job titles, as many of team members have multiple responsibilities and multiple job titles. Divided loyalties between team and own discipline, because everyone want his own discipline to be the upright. Competition between team members, gender, race, or class-based biasness, persistent defensive attitude, reluctance in accepting suggestions from other team members, lack of trust in collaborative process. Descriptive analysis, quantitative or data survey has been conducted through structured standardized questionnaire from all rehabilitation professionals included in the study. And the data was analyzed through SPS version 20. Measure of mean difference obtained by Innova for all analysis p-value less than 0.05 was considered significant. Standardized questionnaire interprofessional collaboration scale was used. Interprofessional collaboration scale is a 13-item tool that has 3 subscale on 4-point Likert scale. One is communication, 5 items, accommodation, 5 items, and isolation, 3 items. In focus group discussion, the members identify following barriers interprofessional collaborations. Uh, they identify these barriers at organization level and team level and barriers faced by individual team members. So first of all, organization barriers. There are few listed here. Lack of appreciation of roles of other healthcare professionals, lack of finances and regulation, legality of the scope of practice, administrative and educational structure of hierarchy which discourage interprofessional collaboration. Here you can see the communication in this group indicates significant differences with all other groups. Rehab physician have a significant difference other than PT, SLP, orthotic and prosthetic and OT. They have a better communication among all members working in a multidisciplinary team or in a team member. For accommodation subscale, good reliability of alpha Cronbach value is 0.66 was found in the subscale. Post hoc analysis for comparison between the occupation show that there is a significant difference for accommodation between the rehab physician and all other occupation included in the study with the p-value less than 0.05. So it reflects that rehab physician have a very good accommodating tendencies between the team members. For accommodating tendencies, here you can see rehab physician have a significant difference with all other groups for accommodation. And here it also indicates that significant difference with the occupational therapist. So rehab physicians are more accommodating tendencies than other team members. The third one, isolation subscale. Good reliability of alpha Cronbach value 0.69 was reported for this subscale. Post hoc analysis for comparison between the occupations show that there is a significant difference for isolation between rehab physician and all other occupation included in the study with the p-value less than 0.05. So mean score of rehab physician was highest, which means that they have strongly agree with inclination of the other team members to work in isolation. Here you can see the mean score of rehab physician was highest, means that they strongly agree with inclination of other team members to work in isolation. Mean score of all other professionals show agreement in this promise except speech language pathologist whose mean score ranked in disagreement. Here I would like to discuss about a little discussion. Communication among members of multidisciplinary team is another basic required parameter for this. The team must have the members with the desired enhanced communication skill who will be responsible for about ensuring the system appropriate for effective communication intra-team and devising a mechanism for the external linkages for the communication. Except communication subscale, reliability of all subscale was found to be acceptable range. Literature shows approximate reliability of subscale rater target combination as 0.8 and range is from 0.7 to 0.83 alpha Cronbach value. Rehab physicians strongly agree with the promises of communication, accommodation, and isolation followed by physiotherapist who showed 1 point less mean agreement here. Significantly greater score of rehab physician, all three subscales show that they perceive their team members well in, they are very well in resolving agreement, they are very well in sharing information, they are very much cooperative, they are very much collaborative regarding varied perspectives and ideas of the team members. Disagreement was shown by orthotists and prosthetists in communication subscale, occupational therapists in accommodating subscale, and SLPs in isolation subscale. Obstacle to interprofessional communication might be reason due to the reluctance of team members in giving opinion during multidisciplinary team meetings in fear of being blamed for preventing patient discharge. Then delay in the discharge are caused by interprofessional conflicts in management of patient. For example, differencing opinion of physical therapist and occupational therapist regarding patient's mobility level, differencing opinion between team members, patient and his family. Effective collaboration can be acquired if professional compiled to provide integrated documentation and non-compliance in this regard results in fragmentation of the healthcare practices with devastating effects. Here, a strong agreement of rehab physician on isolation subscale depicts that they perceive preferences of team members to work in isolation, which could be reflective of their good interprofessional education in comparison to other members that make them perceive that way. Researches investigating doctors' perception of teamwork revealed that openness in communication, good quality leadership, and similar traits were usually rated positively working in team members, in a team member, or in an interdisciplinary team or multidisciplinary team approach. So let's conclude this study. The benefits of interprofessional collaboration cannot be denied in developing countries, and barriers to development of multidisciplinary team are huge. We need to step forward to overcome these barriers and play our role in development of multidisciplinary teams so that our patient and the team members get benefit from this, which is already research proven approach. Proper communication, interdependence, atmosphere, leadership, knowledge, patient focus, perceptions, power, problem solving, decision making, professional commitment, roles, skills, organizational structure, and team characteristics and value key factors in an interprofessional collaboration are the key items to fulfill the interprofessional collaboration among multidisciplinary and interdisciplinary team. Focus group identify barriers at team level, lack of proper purposeful training, role and leadership ambiguity, absence of proper machinery for timely interchange of information, dearth of obligation of team members. Here is another article, Perception Towards Multidisciplinary Approach in Stroke Rehabilitation, a qualitative study, in which we determine perception of rehabilitation professionals
sorry to
working
interrupt.
as
We need to
multidisciplinary
wind up,
team
sir.
members with stroke patients.
Bhavesh, sir, would we wind up the study?
One of my original article about the attitude of speech language pathologists towards multidisciplinary healthcare team. Here we explore the attitude of speech language pathologists towards multidisciplinary member of healthcare team. Here, a strong agreement of rehab physician on isolation subscale depicts that they perceive preferences of team members to work in isolation, which could be reflective of their good interprofessional education in comparison to other members that make them perceive that way. Researches invest, and this article is about the team skills of speech language pathologist as a multidisciplinary team member in stroke rehabilitation. And this was about the to address about the team skills of speech language pathologist as a multidisciplinary team member, their collaborative work and their role as an individual team member, how they perceive to work in a multidisciplinary team setup. Here I mentioned few references to support the multidisciplinary setup and
Bhavesh, sir, can we
the
please wind
perception
up
and
the talk?
attitude of rehabilitation professionals working in interdisciplinary or multidisciplinary team member.
Professor Khusro, I must congratulate you for such extensive research. And I, being a speech pathologist from a neurological rehabilitation expertise, I would tell you it's very important what you have tried, because we need to communicate for a better communication, better facilitation of diagnosis and rehabilitation, so that we can even find the challenging situations to be solved better. So with this, we really congratulate you for the great research what you have been carrying out and the work you are doing. Thank you for joining us today. Could we have the next speaker? I'm sorry, we can't take question because we really are running short of time. We have to have a validatory function start. So can I request Constantine Montinu to please have his slides? Yeah, welcome Dr. Constantine. He's a scientific researcher, biologist, master in neurobiology, doctor of biology, engaged in scientific research in the field of rehabilitation. He is co-founder, Secretary General of Romanian Neurology Association since July 2014, and organizing committee president of ISMH World Congress. He has many honors and publications to his name, and we welcome you, sir. Could I have your talk? Please proceed.
Ladies and gentlemen, dear organizers, dear Professor Nirmal Surya, thank you very much invitation and for this opportunity to present today in collaboration with Professor Gelu Onose our work entitled Hyperbaric Oxygen and Carbon Dioxide Therapies as including physiatric rehabilitation interventions in stroke. The dogma that regeneration is not happening in the central nervous system is a myth. Over the past 2 decades, it has become increasingly clear that the adult brain and the spinal cord are responsive to signals provided by many molecules that can promote neuronal survival, stimulate axon outgrowth, and even lead to self-replenishing sets of neuronal progenitor cells, new neuronal and non-neuronal cells. The interest for this subject came from the many aspects influenced by neuroprotective gases. It is remarkable to visualize the numerous implications of hyperbaric oxygen and carbon dioxide in many basic biological processes: synaptic transmittance, extracellular matrix degradation, neutrophil infiltration, antioxidative mechanism, anti-inflammatory processes going up to the genetic level, pro-survival and pro-plasticity interventions, ion balance and anti-apoptotic cybernetics and cellular energetics. Cerebral circulation delivers the blood flow to the brain to a dedicated network of blood vessels. Within cerebral circulation, the arteries deliver oxygenated blood and nutrients to the brain, and the veins carry deoxygenated blood back to the heart, eliminating carbon dioxide, lactic acid, and other metabolic products. Thus, the related circulation is vital for the healthy cerebral function. A healthy human brain can regulate its cerebral blood flow according to any acute or chronic changes in various parameters. Cerebral blood flow and cerebral autoregulation are critically important to maintain proper brain perfusion and supply the brain with the necessary oxygen and energy substrate. The human brain is an organ with high energy demands, amounting to only 2% of the entire body mass, but accounting for about 20% of the total power consumption of a normal adult at risk. The brain's self-regulatory mechanisms protect the tissue and are dependent on neuronal and support cellular populations, including endothelial ones, metabolic and even myogenic factors. The nervous system plays a critical role in the regulation of vascular homeostasis. Neurological regulation of blood pressure and flow depends on the cardiovascular centers. Stroke is an acute pathologic event, including ischemic and hemorrhagic types. The frequency incidence of ischemic stroke is much higher than that of hemorrhagic stroke, accounting for around 3/4 of such patients. A stroke or cerebral vascular attack occurs when blood flow to the brain stops, is interrupted, or severely reduced. Neurons are deprived of oxygen and nutrients and begin to die. As known, central nervous system lesions evolve biphasically through primary and secondary injuries as a consequence of a complex and rather specific to the central nervous system pathophysiological cascade, and produce in vicious cycles damages that start almost immediately in the first minutes and can continue in the next hours and even months. A key item of the primary injury at intimate level is the impact depolarization, effusion from the disrupted cells of the potassium ions, and also further influx of calcium and secondary neurotransmitter glutamate excess, resulting in early and very dangerous excitotoxicity phenomenon. All these are important pathophysiological bases for consequent secondary injuries or damages. The lack of blood flow during a stroke results in an intricate pathophysiological response resulting in neuronal injury, multiple mechanisms, including excitotoxicity, mitochondrial response, free radical release, protein misfolding, and inflammatory changes, all of this lead to neural cell loss, but many of these pathways ultimately pave also the way for recovery. Injury and death of astrocytes, for example, contribute to cerebral damage. The delicate balance between detrimental or beneficial effects often relies on the timing and the magnitude of the factors involved. The inflammatory response is a prime example of a system that both propagates ischemic injury and also helps to promote recovery. The secondary injuries underlined by oxidative damages, stress, lead in some, cumulated with primary ones, to severe, most of them irreversible consequences like neuronal necrosis and apoptosis, demyelination, scar and cysts, rings formation, disruption of morphofunctional nerve pathways or disconnection, delivery of molecules specialized in active preformed block of axons. Rehabilitation reflects a process of care, while recovery reflects the extent to which body structure and functions, as well as activities, return to their pre-stroke state. The current understanding of brain repair processes suggests that the majority of behavioral recovery and the rapid changes occur in the first weeks to months post-stroke for most people. The time perspective represents an important conditions to maximize the restorative interventions. There are basically 8 major representative situations or biological phenomena characterized by this kind of duality, where the physiological, the functional side intervene with the pathological side, and we can give these examples. Aging through genetic program is a major risk factor for polypathology for all people. Apoptosis, autophagy, a subtle intimate biological bivalent mechanism, hyperthermia, inflammation, which be reactive for our organism, and pathological, like in, for example, autoimmunity, neuroplasticity, functional in learning, and pathological versus pathological reorganization, pain, nociceptive, physiological versus pathological neuropathic, stress, the dichotomy between eustress and distress. Restoring cerebral blood flow and saving dying neurons are goals for ischemic brain injury therapy. The human brain contains a high density of endothelin receptors located throughout neurons, astrocytes, and the cerebrovasculature. These centrally located receptors regulate various functions, including cerebral blood flow and cellular migration, proliferation, and apoptosis. Post-stroke rehabilitation mainly helps survivors relearn lost skills when a part of the brain is damaged, teaching survivors new ways to perform tasks, thereby to avoiding or compensating for any residual disabilities, but also implying neuro-restorative facilities based including on brain repair, regeneration, respectively neuromodulation. Hyperbaric oxygen therapy is a possible therapy for ischemic stroke. Presumptive benefits include increasing oxygen delivery to the brain tissue, decreased cerebral edema and local or regional cell membranes lipid peroxidation, inhibition of leukocyte activation, and maintenance of blood-brain barrier, respectively, of the neurovascular unit's integrity. Hyperbaric oxygen therapy was shown to reduce stroke volume and improve the consequent functional outcome in animal models of both focal and global ischemia. Hyperbaric oxygen therapy is recommended in aiding conditions for which blood flow and additional oxygen to vital organs can prove beneficial. Optimum levels of oxygen are known to have anti-inflammatory, antimicrobial, and tissue healing properties, which can accelerate healing and provide the needed oxygen intake for hypoxic situations. In the literature, it is shown that hyperbaric oxygen therapy can significantly improve tissue oxygenation, tension, and oxygen diffusing capacity, reduce edema and hemorrhage, support the recovery of nerve tract functions, and as well reverse various pathophysiological processes and promote reparative ones. On the other side, carbon dioxide is a standard gas in the air that has been widely used in the physiatric balneary treatment. Carbon dioxide is a residual product of aerobic cell metabolism. Metabolism is a low-fat soluble molecular gas with a strong diffusion capacity and can cross the blood-brain barrier. In healthy people, carbon dioxide is maintained in a narrow homeostatic serum titer between 35 to 45 millimeters mercury by specific physiological mechanism. The pressure of carbon dioxide in artery is the balance between carbon dioxide production and disposal. Carbon dioxide and oxygen are known vital vasodilators in cerebral blood flow self-regulation. As in patients with acute ischemic stroke, this inner homeostatic basic mechanism may be often impaired. Autoregulation of blood flow denotes the intrinsic ability of an organ or a vascular bed to maintain a constant perfusion in the face of blood pressure changes. Whether carbon dioxide has a neuroprotective effect is a question worth discussing in the research area. Carbon dioxide is a vasodilatator, and its low concentration in the blood is thought to cause cerebral vasoconstriction. The high metabolic demand of neuronal tissue requires tight coordination between neuronal activity and blood flow within the brain parenchyma, known as functional hyperemia. The circulatory response to hypercapnia increases the percentage of cerebral blood flow in the human brain with about 6% per 1 millimeters mercury raise in arterial tension of carbon dioxide, influencing the nitric oxide level, an important mediator of carbon dioxide related vasodilatation released by the brain during hypercapnic challenges. Two mechanisms control brain blood flow by changing blood vessel diameter. Autoregulation maintain blood flow and in the face of perfusion pressure changes, and brain metabolism, which adjust flow to meet metabolic requirements. Carbon dioxide increases cerebral blood flow and arterial blood pressure. After this introduction, this general presentation, the methods used for in this work is documented using an inspired by Prisma method. Accordingly, we searched for open access articles published in English during the last 5 years in 6 databases present on the slide. The contextually searched syntaxes used in title and abstract of the articles were stroke and hyperbaric oxygen therapy, respective HBOT, and stroke and carbon dioxide, respectively CO2. The Prisma inspired flow diagram. The flow diagram depicts the flow of information through the different phases of a systematic review. It maps out the number of records identified, included and excluded, and the reasons of exclusion, as we can see in this slide. The selected articles for this study were ordinated based on their Pedro-like quantitative score as presented in this table, obtained using the total citation number per year pondered on a scale from 0 to 10, where qualified only the articles with a score equal to or greater than 4. The Pedro-like score has been considered from fair to excellent in this manner. So the results, our research first identified 216 articles. After fulfilling the selection filtering Prisma-inspired methodology, including a Pedro-inspiring classifying for admittance scoring, there remained 22 full-text articles. 3 articles were on a different topic and were excluded. The main articles presenting general aspects for stroke, like example, physical fitness interventions for non-ambulatory stroke survivors, assessment of exercise stroke volume and prediction from oxygen pools in Paralympic athletes, and so on. The second slide with general articles, a few examples, physiological responses and perceived exertion during robot-assisted and body weight supported gait after stroke, the effect of stroke on middle cerebral artery blood flow velocity, dual activities of the anti-cancer drug candidate provide neuroprotection in brain slice models for neurodegenerative diseases and stroke, and so on. One main article, hyperbaric oxygen therapy in experimental and clinical stroke. Hyperbaric oxygen therapy can enhance the cerebral oxygenation and have many other neuroprotective effects through various physiologic, biochemical, and metabolic mechanisms presented in this excellent and cited review article. Other articles with hyperbaric oxygen therapy. Hyperbaric oxygen therapy improves neurocognitive functions in post-stroke patients. The effect of hyperbaric oxygen therapy on functional impairments caused by ischemic stroke, and so on. And on the other side, for the carbon dioxide therapy, we found one article, the effect of carbonated mineral water and MOFAT treatment in Baile Tujnat after ischemic stroke, a case report. There are many articles with carbon dioxide, but not so many linked with stroke directly. In this article, the natural therapeutic factors in Baile Tujnat, consisting of carbonated mineral waters and MOFATs, climate therapy, along with medical physical culture, indicated in the rehabilitation treatment of post-stroke patients had a beneficial effect on clinical and functional symptomatology, improving the quality of gait and balance and exercise capacity. Our conclusions, hyperbaric oxygen therapy and carbon dioxide therapy are promising strategies for treating stroke, but being very careful to their very narrow optimum range concentrations for beneficial actions. Future research directions mainly include experiments using such kind of interventions on different animal models of ischemic stroke. Stroke cocktail treatments, well-designed clinical trials, and studies on intimate pathophysiological mechanisms. Thank you very much for your attention. At the end, please allow me to emphasize the Romanian National Congress of Physical and Rehabilitation Medicine and Balneology Congress. which will be organized between 1 and 5 September this year in Covasna, a special balneary resort from Romania with remarkable natural therapeutic factors, to them MOFETs, with carbon dioxide levels over 98%. The Congress has been accredited by the European Accreditation Council with 40 European credits, and has the auspices of important academic institutions. Thank you very much.
Thank you so much, Dr. Constantino. It was a great talk. HBOT has not been very well accepted in many stroke in general, in terms of the younger, the older, and the vascular risk factors and its outcome. So you have done a very extensive research on that. So it was a great presentation. May I have a few comments from Dr. Surya, sir, if you're there?
Yes, thank you. Yes.
If you don't have any question, we can go ahead.
Okay, thank you. Thank you very much.
Thank you so much, Dr. Constantino, for joining with us. May I have next speaker slide? Slide, please. Yes. So we have pleasure of introducing our own Dr. Partha Ray. He's a member of IFNR Task Force Research Committee, and he's been very active in research in neurorehabilitation and neurology. He is DTM, DNB Neurology, MRCP, FRCP from the UK, and he specializes in clinical neurophysiology. He's honorary IMA National Professor of Neurology, Consultant Neurology in Neurophysiology at NHS England at Liverpool, and he's a clinical lecturer. He's a very, very knowledgeable and scholarly researcher. I have a privilege of introducing you, sir, and I request you to proceed with your talk, long-term COVID syndrome. Please go ahead.
Thank you. Thank you, chairpersons. I'm beginning to share my slides, if possible. It's on slide share now, right? I guess everybody can hear me and you can see my slides.
Yes, sir.
Good, thank you very much. Right, first of all, namaskar to both chairpersons, my colleague panelists, and fellow speakers. And I'm very grateful. Namaskar to all the attendees, delegates. A special warm namaste to Madam President Teresita Joy Ples Evangelista for joining this session. And of course, a great thanks to Dr. Abhishek Srivastava and Dr. Nirmal Surya and his team for inviting me to give this invited lecture, and to Mr. Bhavesh Thakkar and his team for enabling a virtual seamless presentation. Without much ado, let me start off with my presentation by dedicating this talk to the COVID warriors, my colleagues who have laid down their lives in the line of duty in the last 14 months internationally, and to my patients who have died and some who have been damaged by the COVID illness. I'd like to start off by quoting some literature, which is the story of Tale of Two Cities by Charles Dickens. For those who are familiar with this last 16 months has been a life-threatening time for all of us, either as members of society or as professionals or anybody. So it was basically a time of darkness, at the same time a time of hope. We thought we were wise in treating patients the way we knew, but then we were realized very soon that what we were doing was not right. So there were several treatments, several approaches. Lockdowns were coming and going. The whole world was in turmoil. So all I can compare it to is this phenomenon of the period between the French Revolution and the American Revolution, which Charles Dickens actually wrote about. So I would advise you to read this book. I read it when I was 14. And again, when I saw this happening last year, it brought back memories of those times. We have lived through a crisis, and we must learn from it, because many of us have lost very close people in this pandemic. My outline of the talk is in these two parts. Part A, I offer my gratitude to Professor Khasru, who him and me are doing this integrated talk, and I'll be covering the neurology and neuropsychiatry basis, but I would like to keep a substantial time for the lessons all of us have learned from this pandemic, because all this loss of lives that we have had should not go in vain if human beings haven't learned their lesson to avoid such catastrophes for the future. Moving on from there, well, this is the region I'm so privileged to be born of. I was born here in Kolkata and then grew up there for 27 years and then moved westwards to be in Liverpool for 27 years. And growing up there, I learned what life is like, what people are like, what are our aspirations. Moving away to Europe for the next 27 years, I got the view of this entire area from a distance, keeping in close touch and not missing a single beat. So I knew what was going on from a distance. And now the third phase of my life, I wish to get back here and address my learning to the service of the people. But that's what it looks like from outer space, be it Jeff Bezos or Richard Branson looking at it from there. But that's what we look like from above, the AOCNR, AOSNR sort of population. That's where the map spread out. I was sharing these data with our president, President Joy. And you see, we have the responsibility as a group of looking after 65% of the world's population in 2020. I've given you the breakup here. That's the combination of Asia and Oceania, 65%. And I've given you some numbers, all from the internet, of how the numbers will grow till 2070. And all we can see out here is that at the moment, at 65%, we are having to look after the maximum proportion of the world population. It doesn't decrease too much till 60, but we are responsible for the healthcare of the largest number of people in the whole world. So with great responsibilities needs great courage and great foresight. My topic is long COVID. I'll be discussing the story of this particular representative patient who has long COVID. I learned my medicine from my patients. I listened to them. So that's perhaps what I will do. I will show you two most important slides. The first one is this, in regard to suspected long COVID. I'm sure you can read it as I am talking. This is from the Neurology Journal. Arvindranath from NINDS tells us about what the patients report as their main symptoms. A longer description is here. One moment, is here. I would again urge you to read this very important slide, because once you have read this all in your own time, you would have understood what long COVID is like. The rest of the slides will be just medical textbooks. But this is the patient's description. Have a read. I won't interrupt you, but I'll urge you in the interest of time and the valedictory ceremony to be a bit quick. The highlights were somebody having asymptomatic COVID, whole family. The eldest, most likely the father, comes down with long COVID. Those are the symptoms. They get worse. Very poorly described. Diffuse pains, breathlessness, anosmia, very badly off, 6-8 weeks, poor sleep, fatigued, significant anxiety, finally coming out of it from the BMJ. I've given you the reference in case you want to read the whole article. So that's long COVID from the patient's viewpoint. Why I say so? Because that's the sort of people who can get long COVID: senior citizens, young individuals, both genders, and certainly ones with comorbidities. Classification, Professor Khasru told you about it, about the arbitrary cutoff point based upon onset of symptoms and persistence beyond 12 weeks, and somewhere in between. So these are all arbitrary. The definition is not yet out. That's a chart which shows you the distribution of neurologic and psychiatric symptoms. And Professor Khasru has dealt with the pulmonary, the cardiovascular, the cutaneous, which was new information to me, and some peculiar rheumatological symptoms that are also part of the long COVID. So that's a rough sort of timeline of how things might go. You might be lucky with just a bit of anosmia and getting recovered very quickly. That's happened to most of us. Others get into the long COVID phase. Some improve, others have a persistent problem and ongoing inflammation. Others have other symptoms which are difficult to delineate because they're simply having other comorbidities which have been unmasked. And I'll be showing you why it happens. So this particular slide, I've just enumerated the fatigue syndrome. And here I've laid out the other causes that can mimic profound fatigue. Before calling it from COVID, you can get thyroid disturbance, electrolyte imbalance, and maybe low cortisols after COVID, and that can present as long fatigue, profound fatigue. Then you have the respiratory symptoms. These are the ones I'll be talking about. Everybody knows about it. The neuropsychiatric symptoms, I'll be talking about it. There are gastrointestinal symptoms. People had diarrhea as the presenting symptom. It's still not a part of the long COVID or the COVID symptoms, but diarrhea is a definite symptom of COVID illness because we have got maximum amount of ACE and ACE receptors in the GI tract. But again, there's lots of things you've done to these patients, used various different drugs and those antiviral agents that can cause diarrhea as well. So there's always the dilemma as to whether it's long COVID or simply a manifestation of something else that's going on, or an iatrogenic complication. So there are musculoskeletal features as well. Thromboembolic syndrome, and Professor Palande asked us about the incidence of strokes, and that's why people were requiring heparin at the very beginning when they were having microthrombi globally causing problems. And that again, the multisystemic inflammatory syndrome is seen in the children, pediatrics age group, including with myocarditis, because this virus is such a nasty thing. It's only a small thing, 125 microns in size, but it's brought the whole world to our knees. That's the problem. So moving on, what is the possible etiopathogenesis? To be fair, nobody knows. All these are hypotheses as to why one gets long COVID. Why does the symptoms persist beyond 12 weeks? So those are the possible reasons that we are there. Moving on, this is a busy slide, a complicated slide, but it shows that SARS-CoV-2 is like a nuclear bomb in terms of the immune system. I've simply copied and pasted this statement from one of the high index journals, Lancet or BMJ or somewhere. It's like a nuclear bomb because when this bomb goes off, the SARS-CoV-2 virus attaches to the angiotensin receptor, and then it starts to create mayhem in the whole body. And you can see how it causes tissue damage, pro-inflammatory cytokines of various different types. We have been using these as markers and all the rest of it. So a very unpleasant sequence, cascade of events takes place, whether the virus enters through the respiratory tract as it does, or through the oral tract. There's so many ways it can enter our system, or the nasal tract, sorry. And that's the process. This was the ACE receptor distribution. In almost every organ of the body, there is ACE receptor. And the virus attaches to those receptors, goes inside those cells, and causes dysfunction, be it in the heart, myocarditis, liver, hepatitis, lung. We all know the COVID lung, the brain, which is what I'm going to be talking about very briefly, pancreas, diabetes developing, and of course the diarrhea in the smallest intestine and the colon. This slide has been shown to you before by my predecessor speaker. There are lots of comorbidities that have exacerbated the immune process for a longer time and have caused these individuals to become very sick. And with the iatrogenic complications of steroids and diabetes and all the rest of it, they have become simply worse. Let's move on to some specifics. Mental health I drag up first, although I'm not a psychiatrist, because PTSD in both medical professionals have seen innumerable number of deaths, and patients in ITU and even on the general wards have seen dead bodies being taken away in body bags has been the most distressing phenomena. Anxiety has been high across the globe in every nook and corner. Depression has been coming on because of livelihood loss, because of uncertainty. Brain fog I'll be touching on later. And I think it's a question of autonomic cerebral autoregulation failure in the brain that caused these patients to describe in common English term brain fog. Sleep was disturbed, alteration of circadian rhythm, and diffuse non-specific pain. I'm moving on to neurology because I wanted to show you this MRI. I've got this picture from one of the journals for COVID-19 induced ARDS, prolonged ITU stay, landing up with multiple microbleeds on the susceptibility weighted images as hypointense spots. This I certainly believe is COVID-induced, the microhemorrhages. But overall, that's the list of neurological symptoms that can happen. Strokes, yes, the pathophysiology indicates hypercoagulability, microthrombi, endotheliitis, immune cascade activation should give rise to ischemic strokes most definitely. But again, you see, I've discussed in the panelist comments earlier on as to the data not showing that. Anosmia agusia, where the virus enters to the nose, headaches, vertigo, seizures, and encephalopathy in the ones who are most severely affected. Now, there's been weakness, non-specific weakness, myalgia, myositis because of viral invasion of the muscles. And then patients who are having all these risk factors through being on ITU and through all these mechanisms were having critical care neuromyopathy. And all these comorbidities, which would knock anybody out if they were on the ITU, with the added ravage of this virus penetrating every cell in the body, wasn't doing any good. The autonomic symptoms are very important because this is the part of the nervous system we talk about least. Tachycardia, night sweats, temperature dysregulation, gastroparesis, or diarrhea, and peripheral vasoconstriction, including those skin rashes that you saw, were again markers. This was from 1 day ago. The BBC is now trying to identify long COVID because again, the diagnosis
Professor
is
Ray, could I
14 minutes.
request you to
Yeah.
please wind up? We have
14
Raj
minutes.
speaker,
Yeah.
and then we have to rush to the hall 1 for
Oh, I see.
valedictory.
Okay. All right.
Thank you.
I'll quick up. Yeah. 14 minutes. Yeah. Right. So these are the things we need to know about long COVID. I just wanted to highlight in the next 4 minutes, we have a new disease, a new syndrome. In our area, 60% with a 5 to 30% possibility of long COVID, we might have a real problem coming on our hands. Encephalitis lethargica, Spanish flu caused a lot of problems. We have an area which has got lots of geographical attributes. Those are here. We have a workforce problem. We had a discussion about brain drain, not only among allied health professionals, but also among neurologists. We have relied on pharmacological models. Those don't apply to neuro rehab models. There has been the idea of a tablet for a disease. That doesn't work for intensive neuro rehabilitation. In medical schools, I got only 3 pages of neuro rehab. I spent 18 months learning names of drugs. Doesn't help. In our area, these are the realities. Infectious disease drug discovery has lagged. There's not much money in it because the people who go to buy it are not coming from the affluent parts of the world. There is a big role for traditional medicine practitioners. In India, we have got Ayush. Yesterday, I was listening to Chinese traditional medicine. I'm sure there is traditional medicine remedies in all our countries in the Asia, Oceania. We have not given empowerment, autonomy to our colleagues like Sonal, our OT, special language, and just quick enough for time. Public forums, our patients finally have a voice. A few good signs we have had. We are beginning to behave as a global community. We are emphasizing hygiene and cleanliness, mental health, well-being, a global village. We realize global warming. We have talked about telemedicine. Overall, I have a good idea about long COVID. I think it's not a real worry. It's an immune smoldering process. It will settle. A few of us will be long, but I am no God. I cannot see the crystal ball. We'll have to be careful. We have a long way to go. Lots of responsibilities our 65% have placed in us. So a lot of things to do. Thank you. And that's the meaning of Namaskar. I learned from Professor Kiki Turrell this morning. With that, I finish. Thank you. 16
Thank you so
minutes.
much, sir. It was very crisp and quick, enlightening talk
I-
with
I-
extensive
I-
research you have mentioned there. Could I please have next speaker slides, Dr. Raju? Are you there with us?
Yeah, I'm here.
Yes, sir. So we come here at the end of the session of AOCNR Day 3. Dr. Raju Dhakkal is Doctor of
Yes.
Medicine, Physical Medicine, Rehabilitation from Bangladesh. He's a Medical Director of Spinal Injury Rehabilitation Center, Nepal. He's Medical in Charge, Spinal Injury Rehabilitation Center at Dhaka. He's Medical Officer, Tutor in Anatomy, Kathmandu Medical College, Teaching Hospital. He has many research publications to his name. And I welcome Dr. Raju. Without wasting the time, please go ahead. I would request you to please cut short if it's possible, so we can finish and join the valedictory soon. Thank you so much, sir.
First of all, thank you so much, AOCNR 2021 and Professor Dr. Nirmal Shure and the team. I'm Dr. Raju Dhakkal, Medical Director and Specialist PM&R Physician in Spinal Injury Rehabilitation Center, and also the President of Nepalese Association of Physical Medicine and Rehabilitation. It's going to present about the experience of COVID-19 pandemic at spinal injury and brain injury rehabilitation in Nepal. So Spinal Injury Rehab Center is the largest 61 beds specialized and non-profit referral neuro rehabilitation hospital in Nepal, working since 20 years. So since the pandemic declared by WHO for the infection prevention and control, we developed our own guidelines and a protocol to rehabilitate people with spinal cord injury and stroke and brain injury, to minimize the infections and also to provide comprehensive rehabilitations. Then during the first wave, we had meeting with home and abroad with our team. After that, we formed like COVID-19 response team in the rehabilitation hospital. At the beginning, we didn't have PCR or antigen testing, so we used screening questionnaire for the patients, visitors, and also for the staff, whether they have any symptoms of COVID or not. Then we revised our admission criteria, like how to receive new patients for the rehabilitations and the workforce management, safety for staffs and all the patients. So now we have the rules that the patients and their caregivers should be COVID negative during admission. And if we have any suspicion, then we do quarantine them. And if they are positive, that definitely we isolate them. So no, not any caretakers and new visitors allowed inside the building without testing. And this guideline has to follow by all the patients, caretakers, clinical and non-clinical staff. And we change our all services through tele-rehabilitation as much as possible. And you can see the first case in Nepal was in Jan 2020. The total cases were 711,000 and more than 10,000 deaths, and the infection rate is 20 to 30%. So around 4.5 million people vaccinated in Nepal, and all the people, healthcare staff in our rehab hospital is vaccinated. And also we have first wave in 2020, October, November, and second wave in April, May 2021, and we are still facing third wave now. So despite all the measures, we had first outbreak, and that time around 40% tested were positive. So the patients, caretakers, and we have vocational training centers for the people with disabilities, and even staff, all, the 40% were infected, and there's non-existence of accessible isolation center from the government side. So for the severe spinal cord injury, stroke, and brain injury, we have to change our pure rehabilitation hospital as an isolation center and the rehabilitation hospital to provide them the comprehensive services. After the outbreak of COVID-19, we have to treat COVID positive as well as COVID negative. So we started after doing testing, we just isolated who were COVID positive and who were COVID negative, and who had tested negative but still they have symptoms. And then at the same time, we strengthen our daily rehabilitation services who couldn't come to the rehabilitation hospital. So most of the brain injured and spinal injured were so much complex conditions, so they couldn't go to the testing center. So we have to convert our rehabilitation facility as a testing centers, and we started testing in our center by the help of all the rehabilitation professionals. And we have to extend our services. So we had new isolation ward, and then we start a regular COVID ward round and non-COVID ward round. At the same time, we used to have regular clinical audit to improve our services. And the most of the patients and the staff and everybody has psychological stress. So we started doing group activities and therapy outside the center with good suns and natures by the therapists and the counselors. And some of the patients who are still inside the building, we started some therapy clinic services and also some music therapy for the patients who were isolated in the isolation center. We provided vaccine to all the people with disabilities who came for the vocational training, and we have been started some vaccines to the patients as well. And we do regular counseling for the reintegrations and how to prevent further infection if they go back to the community by our counselors, basically from the peer counselors. So again, we had so that was in the first wave, and we had second wave at the same time, second outbreak. At that time, only around 28 people, including patient, staff, caretaker, infected. The 72% of tested were infected at that time, but at that time but majority have mild to moderate or severe symptoms. And because of ICU needed, we referred two patients in the acute hospital. Very unfortunately, one succumbed death, and the second variant was really hard. So during second wave, also we have been doing our regular, rehabilitation services for the patients. Again, we have third wave. We have now we tested 19 out of them, 8 positive. So we are our interdisciplinary COVID and post-COVID rehabilitations is still continuing in our center. The challenges we faced at that time, we have to manage all the positive and negative cases at the same premises, and at the same time, we have to avoid cross-infections. And we have to use all the cafeteria, conference hall, in the vocational training hostel, every usual ward as isolation and quarantine. The very limited human resources because most of the staff were infected. So we have started new concept that caring COVID positive patients with the COVID positive staff and the COVID negative patient with COVID negative staff. And most of the staff, they couldn't come to the hospital because of psychological unfit of COVID stigma in society. And I'm sure many SCI and brain injured left behind without rehabilitation in this pandemic time. All the cafeteria, we have to manage from outside because all the cafeteria was used for the isolation center, and we had to report Ministry of Health and Populations every time, and always we have to handle the community as well as social media regarding the whole management and the infections. And at the same time, we have to take care of the psychological status of the patients and staff. So lesson learned. So I think this time the telerehabilitation, we have to strengthen telerehabilitation, which is ideal. And contact tracing, testing, isolation, quarantine has to be continued all the time. So low resource region, we have our reusable by reusable PPE by the autoclave. So we use that one, and we have to be very at beginning. We have to separate the healthcare staff for isolation and quarantine. Infection prevention and control has to follow strictly all the time. So the second wave, we had huge scarcity of the oxygen. So many people died. So the oxygens and very important medications that has to be in the rehabilitation facilities, and all the hospitals who provide ICU care has to be in their hands so that we can do quick referral if needed. So post-COVID rehabilitations has to be prioritized now, and the preparedness and planning for another wave is always in your mind. So thank you so much for your patience hearing, and you are welcome to Spinal Injury Rehab Center. And we have just published one paper about our team effort in spinal cord series and cases nature. You can view that one as well. So thank you so much.
Professor Raju, it was very extensively done work and very quickly presented. Thank you so much. With time constraints, we couldn't have a complete presentation. I really appreciate all the speakers of the session who have contributed to the success of this AOCNR. Here we came to the last session and we are concluding the session. We all would like you all to join us with valedictory session now. Please come to Hall 1 and join with us. I once again thanks all the attendees of the session, all the chairs, and all the speakers of the session again. Thank you so much.
Thank you, Hannah.
I also take this opportunity to thank the speakers and the chairs.
Thank you also very much.
Thank you, bro.
Yeah, you're all very nice sessions.
Thank you so much.
Thank you.
Thank you.
I request all of you to join for the valedictory portion.
Yes. Please go to faculty lounge and join Hall 1.
Yeah,
Thank
Hall
you.
1.
We found that it can only be good for older adults. Here, you can see those are significant predictions, whereas for young adults and middle-aged adults, the results are not. So basically what it means is when motor coming